Hello, everyone. Welcome to our inaugural Real Health Equity Summit. We are thrilled to have you here with us today. And I am personally thrilled to have this going on because it's been a labor of love, but I know that everyone's going to really enjoy what we put together. I'm Aaron Strout, Chief Marketing Officer at Real Chemistry. And I'm very excited to have two of my important colleagues here with me today to kick off today's event. You'll hear from both of them in just a moment. We have Jim Weiss, who's the chairman and founder of Real Chemistry, and our other colleague, Mary Stutz, who is our Global Chief Inclusion and Health Equity Officer. And she's been instrumental in putting this together along with her partner, Jewel Jones, who you will hear more about in a minute. Before we jump in, I do want to cover a few housekeeping items. As everyone always wants to know, can we get a recording of this? Yes, you absolutely can. Not only will there be a version of this likely available at the end of the day on YouTube Live as an archive, but everyone that is registered for this will get a link with the edited videos available to share, to watch after the event. So just keep an eye out for that email with the recap. We do also want to make sure that you know that this is interactive. And so if you do want to drop a question or a comment into the chat on the bottom right-hand corner of your screen in YouTube Live, please do that. Some sessions will be more interactive with questions than not, but we do always welcome your comments and would love to know what your questions are. We also want you to join the conversation. So if you're a Twitter person, LinkedIn, Instagram, whatever it is, feel free to follow along the conversation, share pictures, thoughts, quotes, and we will be tracking that with the hashtag RealChemRHE. That's RealChemRHE. And I think that's on your slide right now, so you can probably see what I'm talking about. So with that, we always feel like it's interesting to know the backstory as to how did we get here. Health equity has never been more important. You'll find out more from Jim and Mary and all of our participants today. But Jim, I want to start with you because several months ago, I think when we hired Mary, and you've known Mary forever, you committed to doing a Real Health Equity Summit. We'll talk more about the timing later. But I think the audience would love to hear about your and Mary's 20 years together, right? Off and on as clients, agency partners, now colleagues, and a little bit why this is so important to you and why you take health equity so seriously.
Well, thanks, Aaron and Mary, for getting this going. I was a brainchild idea that I had. You made it happen, which is, my favorite hashtag to pull it together. I think Mary and I had envisioned a world where, many have heard my announcement that I'm now chairman, having been CEO and founder for 20 years, and Shankar Narayanan, who will be joining us toward the end of this session tomorrow, also joined. I just thought, it'd be a great way to come out and present ourselves at JP Morgan that, Mary and I had experienced years ago, the fact that very few women were on the dais. I'm on the board of the Healthcare Women's Business Association with Mary, among others, and have seen, real change and evolution there. And it happened kind of relatively quickly once people focused and figured out it could get done. Now, Mary's been at the forefront of this, not only in her life, she was impacted, has her own personal story, but, at Genentech, was leading the way many, many years ago. Well, not that many. So let's keep it in perspective. While they were pioneering personalized medicine, launching Herceptin and Rituxan and Avastin and all the great medicines that changed the face of cancer treatment, they were also beginning to explore diversity in clinical trials. And I think you're going to see with our keynote, Alexander Hardy and some of the upcoming ones at Genentech and Roche have been big pioneers in this area and first movers. And that's what I know I like to be. I like to be disruptive. And, I feel, I've been taught here by some of the best colleagues, mentors, friends. And, what I ultimately am is a business person, and I really see opportunity. What gets me upset most often is opportunity lost or squandered or missed. And I feel like we're leaving, millions of lives on the table Not just, for the good of society, which is certainly a good enough reason to do anything, because if you do good, good happens, good follows. But I think the opportunity, cost to our industry has been vast. And, we obviously have plenty of diseases that are specific to certain, ethnicities and genders. But, again, I've seen real impact happening on the women's side of this thing. And I wanted to be more active when it came to diversity and inclusion and health equity, because our mission, of course, is to make the world a healthier place. You can't make the world a healthier place unless people are healthy. To begin with, economically, it has a positive impact if people are healthy and they're living in healthy environments. So that was our vision. Mary and I, when she heard that I added it as a pillar to the 5 pillars, we had 4, but added as a 5th pillar to what differentiates Real Chemistry as a consulting firm. We talk about being digital first and analytics driven and being creative and being healthcare experts. But because we have all that, this next leap into making sure all we do is diverse and inclusive and focuses on health equity, we believe that is a really nice package. And when, Mary saw me add that, she stepped up and said, I want to come here and do that and help you achieve that. And Jewel and so many others on the team have made a tremendous impact already for our clients, for us. But I do think it's an economic business imperative to get this right in the biopharma industry, in particular in healthcare, and in so many other areas. We have to hit this. And I was at a session, I think, Aaron, you were with me. One of the things they emphasized at Health Evolution Summit was the idea of public-private partnerships. So we want to, through these efforts over the next few days, we expect to create action. This is not a lot of talk. This is, we got to get to do. Sorry to use that word, but the point is we got to get to make it happen. Action. Those are the things that have to happen. We have to be an active partnership and mentoring and teaching and guiding and growing. And, someone like Mary, who's had this background within biopharma, within, health delivery, at Stanford and at Kaiser and other places she's been, she's really written the book and, worked with the best, Bernard, and so many others in your career that have taught you and helped you. And Jewel has a similar background. So I think we're going to see that come through. We have an amazing lineup of speakers that you've put together. So thanks again. And I know you're going to review some of that so many of you have to look forward to. But what I'm asking everyone to do who participates in the next couple of days is get engaged. Yeah. Get engaged, come to us, whether you do it in your own venue, but with us, let's make something happen measurably. And every year we'll measure that as we come back together. What have we made happen? What has gotten done? It's not just hiring, it's programs, it's reaching people, it's getting people into the system, which will help our industry regardless. So it's going to be good for all of us to do it. So that's how I wanted to start and open. And, I have a mantra, which is take the river, don't let it take you. So this is our attempt to take this river and really make a difference.
Thank you,
awesome.
Jim.
Yes, thank you, Jim. I'm going to get to Mary, I promise, but just as Jim alluded to, we do have an embarrassment of riches. And again, Mary and Joel were instrumental in this. Jim and I pitched in a little bit to help bring some people, but just, covering the life sciences industry with Genentech, Merck, Takeda, Organon, GBT, some of the, most prominent payers and providers in the space, United Health, Humana, Anthem, CVS Health. As Jim mentioned, this public-private partnership, so getting government and industry organizations involved, like the FDA and the AMA and the AHA and BIO. and advocacy groups like the Black Coalition Against COVID and NBEC, Grapevine Health, May, and others, academics, Howard University, Meharry University or Medical College, University of Washington, big tech companies you may have heard of like Amazon, IBM, Google, YouTube, investment companies, because it doesn't get done if people don't invest in it, right, Mary? We've talked a lot about this. So Rock Health, Lux Capital, Health Equity Ventures, BMO Financial Group, sorry. Kimberly corrected us on that yesterday. And then certainly innovators, right? So Samita Vance and Medidata, Consejo Sano, H1, Shared Care, Cross River Strategies, B. Henry Associates, and Science 37, so many more. But Mary, let's talk a little bit about this intersectionality you've created, this amazing event you've created, this depth of conversation that's going to happen over the next 2 days. Give us some of the background and talk a little bit about what people can expect from a content perspective. They've heard some of the companies and where we're going to be coming from.
Yeah, absolutely. Thank you, Aaron, for having that list of partial list of all of the participants and representative companies. And you are correct. We have convened one of the most intersectional and inclusive gatherings of leaders from across the health ecosystem and beyond the health ecosystem, really, to elevate the solutions so that we can lock arms together and implement together. What has happened is that research up to now has really focused on the challenges and the social injustices, along with the pandemic, just really shone a light on the inequities even more. And while we will acknowledge those, we really want to double down on solutions and focus on how we can get there together across all of these entities. And you know what? We're also going to address the elephants in the room, because we know change doesn't happen when everybody is comfortable. So we are focused on making sure that the real challenges are discussed so that we can get to real solutions. So as you said, you're going to hear from community leaders, faith-based leaders, multiple industries, academia, regulators, public policy and public health folks, associations, venture capitalists, digital health leaders and innovators. Some have health equity in their titles and some don't. And I would say that, put the agendas aside, but when it comes to health equity, actually our agendas are the same, which is that we want to make health and a healthy lifestyle available for everybody. And certainly the people that we've convened today, all of our agendas are the same. So my colleague, Jewel Jones, and I, Jewel is our health equity and justice practice leader here at Real Chemistry, and us, along with an advisory council that includes Dr. Aletha Maybank, Quita Highsmith from Genentech, Dr. Megan Mahoney from Stanford, Lauren Powell from Takeda, Celeste Warren from Merck, and more. And it's an advisory council that is intersectional itself, but that we're going to keep and enlarge even beyond this, because we're not going to stop just with having this conversation. This is really the beginning. This is us recognizing that the focus on health equity right now is more than a moment. It's about the collective investment in future-proofing the health ecosystem for all. And we are seeing that the conversation is growing, and it has grown tremendously since 2018. We did some media tracking. Our wonderful Earned Media and our Simpler team did some checking for us, and we saw that the conversation around health equity just in news media alone has grown over 147% since 2018. And the conversations around health equity on Twitter has grown by 60,000 over this time as well. But our goal is that our actions are going to outpace the conversation. That's really what this is about. And what you're going to hear today is about actions. It's about solutions, current and future. We've asked these leaders who've been working on this for a long time to also kind of look in their crystal balls, if you will, and tell us what needs to happen in the coming years. What does success look like in the next 2 years, 5 years, 10 years, because we want to inspire this groundswell of, after the discussion, actions and coalitions and partnerships and funding. We need money. And so we're focused on the three, what we're calling, Julie and I are calling the 3 I's that it's going to take to advance real health equity. It's going to take intersectionality, it's going to take innovation, and it's going to take impact. And you've heard us talk about inclusivity, but I would just say health equity in its truest sense is inherently inclusive when you achieve it. But it's going to take those 3 I's to get us there. So that's what we're going to be focusing on the next 2 days, over 60 speakers, talking about everything from equitable precision medicine just today, equitable precision medicine, funding, health equity innovations. We have an exciting announcement about some health equity venture announcements that we're going to talk about today, and non-traditional partnerships, because that's what it's going to take, digital advances, all of these things that are going to move us faster and closer to achieving health equity. But I know we're going to start with CEOs at the tip of the spear, because breaking down these cross-industry silos is essential if we're going to advance health equity. We've seen too much where, public health is only talking to public health. Industry is only talking to industry. Academia is only talking to academia. Tech is only talking to tech. We are not going to move the needle doing that. We are intentionally bringing the various should-be stakeholders to the table. And we are excited about what these dialogues, conversations, and partnerships are going to spawn going forward. So I'll hand it back over to you, Aaron.
Well, thank you, Mary. That's great. And just so everyone who's listening in knows, I guess we knew that people would see the chat. I guess it's interfering with the look and feel. So I guess we have to, Jim, not be chatting while we're doing this, even though I know that's what we do and how we share our sidebar feelings. I do want to get into some Q&A here. And one of the first questions I want to ask is, JP Morgan, the healthcare conference is right now. Some might ask, why would you be doing this? I think some might get the fact that if this is where a lot of the deals get done and announced and a lot of people sort of lay the ground, but we'd love to find out, Jim, like you in particular, I know we're very intentional about it. You always have been around JP Morgan about agenda setting. And then Mary, I'd love to get your take as well. So why did we pick JP Morgan Week to do this important health equity summit?
Well, I think, we certainly thought we'd be more in person, and, it was a good way to engage people and enroll people live and in person. Obviously, we're going to do that virtually. We know we can do it this way too. And, one of the things I thought is we can go forward with it either way, not knowing for sure it would have happened. But I think ultimately it's here, and we probably, as Mary and I said, it's a continual effort, a perpetual effort that we have to carry out, at all the conferences. But, here's a place where, the C-suite and investors in particular are paying attention, figuring out where to put their money down. And it's not just about, I think what Mary's saying, and you're going to keep hearing it, it's not about particular diseases, right? It's not like we're trying to say, well, this ethnicity has this disease or that, although some of those things clearly come up and are important and there's investment. It's like, no, everybody, dealt with COVID, like everybody. So it sort of leveled the playing field in the world. Everyone had it. Everyone has been dealing with it. And what it shows is, we're all the same. It was one of these situations. We're all the same physically in terms of getting it, but we're not all the same in terms of who gets access to the best treatments, information, advocacy. All those things became clear in the pandemic, right? That, that has to evolve for us to be more successful with getting our best treatments to the right people at the right time, which is this goal of the industry. And, we have to be more, I would say, knowledgeable and intersectional. We have to be talking to one another. We can't be doing things in silos. We have to sort of pool the resources and pool the efforts so we can be more successful. And it's places like JP Morgan that often enable that, because you kind of tend to follow the investment and the money where things go. And, there's so many examples. I mean, again, I was around when you could still get into the building without a badge, and you sat around and drank by the clock tower, and people had fun, and it was great. And you didn't pay that, you didn't pay that much for hotels. In fact, maybe didn't always need to have one. It was just more open and collegial in that sense. And the idea then was make biotech reality, right? This idea that people were going to turn people into giant tomatoes. That's not what happened, right? We've cured some diseases. We've made major inroads against cancer, heart disease, and so many other things. Now it's time, now we're finally getting women in the C-suite. That was another big and important critical factor. Now it's time to go to this next place, which is let's achieve health equity. Let's stop talking about it and let's do it. And it's places like this where it happens. These are the people with the ideas, the entrepreneurs that gather, the money that gathers, all the different groups. And there's so many more of us who come together now. And if you pool all those resources, there's nothing that can stop us.
Yeah, that's absolutely right, Jim. And I would just add to that, JP Morgan is the place where people come where they want to know what's coming down the pike, what's ahead, what is the future. And so that's why it made so much sense for us to do this inaugural Health Equity Summit and bring all these great minds together for people who are already in that mindset of what do we need to do in the future. Now, added to that is the fact that so many organizations have announced in the last couple of years these massive their commitments, as well as their financial commitments to not only diversity and inclusion, but to health equity and to addressing the social injustices. And Jewel and our team did a little bit of research on that. And we found, for example, that over $2 billion has been pledged by different companies, different industries, but probably only about 200 million has actually appeared to have actually been allocated to anything. Now, we have seen a propensity of increases in hiring and appointments of folks specifically assigned to address health equity, to build the strategies for the companies to help them move the needle. And that is admirable. I appreciate that. But we know that a lot of those leaders are now focusing on their strategies and their programs and what they need to do and how they need to move forward. And they need ideas and they need connections to potential partners and stakeholders. That's the other reason why we have put this summit together, to make those connections, to help give them the ideas, to give them the perspective, to help them understand why they're not going to be able to do this in their silos alone in their company, but they're going to have to be intersectional and inclusive if they really, and innovative if they really want to make an impact. And they do have to fund the innovation, but it's not just writing a check. And that's what we've heard consistently across the board. You've got to get out there in the communities and meet people and work with them. This is what we did when I was at Kaiser. That's where I started my healthcare career. And we had to get out in the communities and talk to folks and understand what was really going on and what were the challenges. And then we made such inroads to be at the forefront of a lot of their initial health equity work. And companies who are understanding that and getting out of their offices, getting out of their own silos and building these unique partnerships and getting to know the community. Some of the organizations that I went to when I first started working in the community to help them with health equity, they already knew me. But when I joined the different companies, a lot of them said, I don't want to work with that organization. What? Because they only come to the community. They only come to us when they want something. And then we help them get it, and then they disappear. And we never hear from them. We don't even hear back the results, whether it's a clinical trials study or any other type projects or initiatives that they're doing. And we never hear back. They don't even come back to say thank you. And you will hear from some of our folks, the things that we helped you do, like your tests and your trials and all that, even with the vaccine and the COVID test, you made money off of that. but none of that money has accreted back to the community. Come on now, we're getting real here about real health equity and what you really need to do if you're going to be seen as a real partner, and it has got to be mutually beneficial to everybody. It can't just be beneficial to your organization. So you're going to hear some real elephant in the room things, as well as some great solutions and some accountability expectations.
Well, I love that, Mary. And I think that's a good lesson for people to learn, because I think we don't think about things, when you're at a Stanford University or other places where there can be that perception of you're only coming when you need something, right? We have about 3 minutes left. I'd love to just do a speed round of, Jim, looking out 3 to 5 years, knowing that this is hopefully a big leaping off point, building on a lot of great work that's already been done. What are you hoping to see on the health equity front over the next 3 to 5 years?
Well, I think Mary stated it. What we want are more, visible programs that are getting into the community, and not, it's not really about, it's important to have board representation and C-suite representation and having the people on your staff. That's all fine. But if we're not seeing real programs, result. And Mary and I had that experience creating Strikeout Cancer and other programs for Genentech back in the day. We didn't just go out and give checks to advocacy groups. We got in the field with them and created programming that was relevant. So I think the point is the programming has to be relevant and create impact. And that's, I think, if we can be talking about real programs each and every year over the next few years in this summit that have resulted from the partnerships that we've helped, engender, then I think we're winning.
I totally agree. And I would just add with some metrics where we are actually tracking the impact on lives. That is exactly what Jim said, plus the metrics to go with it. That's nirvana for us in the next 3 to 5 years plus.
That's a great way to end it, Mary, because you can't improve what you can't measure, right? I think Jim has said that before. And I know even just you pulling some metrics with the media team, looking at the increase in straight media mentions of health equity, we're hoping this will have a dramatic impact on that. But with that, I do want to wrap this up. So thank you, both of you, for starting us off on a great foot. Really excited. I'm like, goosebumps just thinking and hearing about this and looking forward to what's coming. We do want to thank everyone for joining us today. As you can hear, you're in for some great content, some amazing thinkers, leaders, as we're discussing how centering health equity as an organizational imperative does drive business and societal value. We do strongly encourage you to stay on, tune into the next session, which will be starting soon. This is our esteemed CEO panel, and they'll be discussing activating the health ecosystem to advance health equity. So with that, we will be back shortly. Jim, Mary, thank you so much.
Hi, everyone, and thanks again for joining us. I'm Jewel Jones, the co-host of the Real Health Equity Summit, and I serve as the Health Equity and Justice Practice Leader here at Real Chemistry. We'll now be kicking off the day with our first CEO panel featuring a phenomenal group of leaders. Allow me to introduce you to Dr. Michelle McMurray-Heath, the President and CEO of BIO, who will be moderating the next session. Michelle, over to you.
Thank you very much. It's an honor to help open this summit by moderating our first CEO panel. And I don't want to take too much time because, one, we have a great panel lined up. And two, if you've registered for this event, you probably understand the importance of this issue. There are too many stats and stories to cite. Health inequity is everything from the inability to get timely, quality medical care to the inability to access nutritious foods. It's lesser care in the maternity ward and in the emergency room, and it's structural and it's unconscious, but it's also a lack of understanding and action. And we should never look at this problem and be discouraged because too many lives are at stake. It's true that COVID shined a bright light on this issue, but you don't have to dig deep to compare the fate of someone who worked from home with someone who kept driving the local bus, or someone who could leave work to be first in line for the vaccine. And having gotten my vaccine at Howard University Hospital, I'm very, very happy that Howard's represented on this panel today. From those of us who were really facing difficulties trying to abandon the factory floor to follow public health advice. So I've seen this issue from many angles, from growing up in Oakland, where my father spent a lot of his career designing mental health programs for people who couldn't afford care. And my mother was a public health nurse who ran all over the county trying to extend maternal morbidity statistics and get them better outcomes. So I am so excited to be with this group today and know that the children that I used to see in the emergency room who had asthma or diabetes, who in that moment really needed deeper, broader solutions, are now getting the attention and focus, not just of our healthcare leaders, but of our biopharma leaders as well, who are developing new solutions for each of them. So today I lead BIO, as you heard, which is the Biotechnology Innovation Organization. It's a coalition of over 1,000 biotechnology companies that are really committed to making access to our industry's innovations at the heart of what we do. We like in bio to call it just science, where the science being developed and the benefits it will bring and the opportunities it creates can reach deeper into communities in ways that are just, impactful, and importantly, inclusive. So in the summer of 2020, BIO launched our bioequality agenda to help counteract systemic inequality, injustice, and unfair treatment of underserved communities. And we'll talk about many of its aspects today, as our conversation will really range from access to care to clinical trial diversity, from training the next generation of scientists, as well as supporting minority-owned organizations that contribute to our research and development pipeline. So today's panelists, they bring a range of experience to our virtual table, and I've come to believe that in order to create the change we need and to sustain it, you need everyone coming together to share solutions and build partnerships. So without further ado, today we have with us Alexander Hardy, the Chief Executive Officer of Genentech, Dr. Wayne Frederick, President of Howard University, and Dr. Joya Krier-Perry, who is the founder and president of the National Birth Equity Collaborative. I'll turn it over to them in a second, but first let me reiterate one of the goals of this summit: to center health equity in your work and in your actions. Whether you are a chief diversity officer, a public health official, or a policymaker, health equity must help guide your vision. Because while every person has the right to a healthy life, one that allows them to seize the opportunities placed before them, more people leading these kinds of lives is good for our entire community and our entire society. So in sum, health equity is both the right thing to do for others and for the society, and the right thing for each of us to be fighting for. So with that, let me begin by asking each panelist to really briefly introduce themselves a little bit more. And as part of your response, could you share with our audience why health equity is a passion of yours and why it should matter for all of us. So let's get started with Dr. Priya Perry.
Well, thank you so much, Dr. McMurray-Heath, and I'm so honored to be here with you today. Why health equity is a passion of mine. As a Black mama from the Deep South, I recognized early that my identity was also a part of my work, that many of the patients who looked like me were not treated the same way as the other patients that were there. And they also had structural barriers to their care. They had structural barriers that included segregated care, that included being devalued when they mentioned their pain or when they mentioned their children and that they had children at home and they didn't have paid leave. So health equity is so important because it means that we will really undo the harms of racism, classism, and gender oppression and fight for justice and joy for all people. So that's why it's my passion.
Wonderful. Wonderful. Dr. Frederick, let's turn to you.
Yeah, and thanks for having me, especially on such a distinguished panel. Here at Howard, I'm the president of the university. I'm also a practicing cancer surgeon. And so I get to see, I think, two parts of this issue. One is the pipeline in terms of what the struggle is to get more African-American healthcare providers across the spectrum. And the second, in my role as a cancer surgeon, is to see, what I saw just this morning again as I was making rounds. A stage 4 gastric cancer patient did not have an appropriate workup for early symptoms. Treated with some Pepsid, and now unfortunately has liver mets and carcinomatosis, and discussing hospice care with he and his family. Very difficult circumstances. So I see this through a lens of trying to fix both issues and making sure that we do that while maintaining what I think is most important, and that's that the patient should be the object of our obsession, if not at very least our affection, and putting the patient back at the center of the healthcare system, I think will certainly help close some of these gaps.
Thank you. And Alexander Hardy?
Thank you very much. And thanks so much for inviting me to be part of this tremendously important panel. It's a real honor to be here. So yes, I'm Alexander Hardy. I'm the CEO of Genentech. We have been committed to discovering and developing medicines for all patients who face serious and life-threatening diseases for over 45 years. We're the largest investor in research in the healthcare sector at $13 billion a year. We have a desire and a purpose around innovation, driving change, and making a big difference in the world. And this is in all the hearts and minds of our employees, that they come to work every day to try and discover these breakthroughs. We want to make a big difference. And the reality is as Michelle, as you mentioned in your introductory comments, the deeply entrenched inequities in our healthcare system is impeding this ability to deliver for all patients, which, as I said, is our purpose. We have an accountability here, which I'll talk more about. I mean, clearly, clinical trial results don't reflect real-world demographics. And that's an issue, that they're not applicable to the patient groups that are in need, that fellow panelists have already mentioned. And clearly, medical advances that don't reach everybody are simply just not impactful as they could be, as they should be. So, as we see, we're really at a very exciting time from a scientific and a technology standpoint. And it's really unacceptable now that so many people are being left behind. And I'm actually worried that as the science continues to move forward in the direction it's moving, that potentially it could get worse if we don't act and act together. So, this is why it's critical to me and to our company that we really understand and address the causes of this systemic inequity, so we can deliver on the potential of the science and personalized healthcare for every single patient. So this is why this is important to us and to me. Change starts, at home, and we are working really hard. And I know we'll have a chance to talk about this to increase the diversity of our own research programs and make sure we're doing inclusive research action plans for all of our clinical trial programs and to partner broadly with advocacy groups, with physicians, with trial investigators and others to really advance in this area. I would say that, this is not only the right thing to do, but, actually, I regard this as the success of our company, and our mission and our purpose depends on our success in this area. So this is why this is deeply personal and important to Genentech and our success.
Wonderful. And I know you guys have been doing some really innovative things in the clinical trial diversity space that we will have a chance to dive into. Now, I was struck, Dr. Frederick, by your example that you touched upon and I'm not sure that everyone got a chance to really appreciate what you were saying. You had a patient who presented to the healthcare system and just did not get the follow-up necessary to really detect their cancer before it spread. Was that the example?
Yes, that's correct.
Yeah. So they just went into a healthcare facility and the person just Please tell us a little bit more. Explain it.
Yeah, and this is not unusual, especially with the pandemic. And you have to remember, during the pandemic, what we did was tighten already tight accessibility for a certain group of patients. We made that even tighter because of COVID and appropriately by healthcare guidelines. But we did not appropriately make adjustments for how do we screen, how do we get people to get their mammograms, their colonoscopies, et cetera. And unfortunately, what we've seen, and I've written an op-ed or two about this, is that we're now seeing people present with late-stage cancers who otherwise would have been diagnosed earlier. And of course, disproportionately, those are patients of color and patients from underrepresented minorities who already were less likely to be screened. And now we're seeing that. Recently, data has been put out about cancer outcomes. We have a lot to be proud of in terms of we've closed the gap in terms of lung cancer outcomes. The mortality is improving, early detection is improving. But then when you look at prostate cancer, again, you're seeing still a larger proportion of African-American men having worse outcomes and having more advanced stage disease. And I think this patient that I had, I think we're going to see more of that. And unfortunately, the gains we've made in life expectancy in this country over the past 3 decades in particular will begin to erode, unfortunately. And so my description of it was the pandemic after the pandemic. And I think it's something that we're going to have to work really closely over the next 5 to 10 years in particular.
Well, the pandemic after the pandemic is a perfect frame for our conversation today. And we all know that there are many steps that we really have to take to try to ensure better access to care from birth to end of life. So let's start with the positive. What actions, whether by industry, government, nonprofits, or academia, are really moving the needle forward? I'd love for each of you to name something that you support from outside of your immediate sector. So let me build on those responses just a little bit as we go forward. So Joya, maybe let me turn to you, and you could start with what's something that really has you excited about making progress on this front?
Well, I'm excited about a lot of things. In fact, both of the answers of my co-panelists make me really excited to see an executive of a these large organizations taking ownership in health equity, taking ownership, and even admitting, as Dr. Frederick did, that our system has some faults. For so long, the work that I do blames and shames communities and says things like, well, they get COVID because they don't wash their hands, or, they're not cleanly enough, right? And so this really ensuring that we acknowledge the things that we do incorrectly, like not addressing the need for screening in a pandemic, that's huge. And how would technology really fix those kind of answers? So it gets me excited. Some concrete things I'm excited about, though, is the work of our organization, along with others, to improve the outcomes for Black mamas and families, along with the Black Mamas Matter Alliance and other Black women-led organizations. We see the current administration really listening to the people who are the closest to the problem, really learning from the doulas and the midwives who've been on the ground doing the work. We know that the United States spends a lot of money in technology, but it doesn't integrate those things. Those silos are so strong and people are not connected. So having an ability to have people, boots on the ground who've been doing the work connected to the Genentechs and the Howard University hospital system, that's where we can win. That's when we show that we really see that de-siloing and listening to and following the lead to the people closest to the pain will get us to the closest to the joy.
Love it. I love it. Alexander, what has you excited? I know there's been a lot of progress made in the last couple of years. So tell us something that you're seeing from your vantage point.
Yeah, well, I think that something that's very important to us is that, innovation requires us to have the very greatest minds, working on solving these challenging scientific issues. So, a diverse workforce, diverse in every sense of the word, is really critical for us. And that flow of the most talented individuals into clinical care, into research, whether that's research in academia or research at a company like Genentech, is really critical. And I'm excited to see the progress there. I mean, there is a backdrop once again of calling out the challenges or the issues. Is that there have been systemic barriers that have prevented students of color and other historically excluded groups from pursuing careers in science and medicine. But I can see, methodical efforts, multi-sectorial efforts to really address that. And the exciting thing I see this going all the way back to kindergarten, which we know that's where you need to start to create an interest in science, but all the way through grade school, through high school, undergrad, and then postgraduate. And I think that is enormously exciting. And a couple of things that I wanted to highlight. One outside Genentech that we support, and one that we're actually in a partnership with Howard on and the FDA, I think are exciting. So it's the Diverse Future of STEM Fund. This is providing mentorship, support, training, and resources to physicians and researchers of color, so they pursue careers in science and medicine. I think this is fantastic work, and we're really proud to support it. Again, that's intervening on one part of that pathway, but this is so incredibly important. And then we have a really exciting partnership actually with Howard and the FDA. Last year we launched a 2-year fellowship program with both organizations, and it's to increase the diversity of future drug development expertise. So incredibly important. Again, that we have diversity in these really critical institutions that play an important role in shaping and deciding on the future of innovation and the delivery of healthcare. So it's a 2-year program. It involves 6 months in the classroom at Howard School of Medicine. It involves 1-year immersive fellowship at Genentech in our Washington, D.C. office, supporting the development and implementation of strategies focused around the drug approval process, and then a 6-month FDA fellowship. We had our first fellow last year, and I'm really excited that this year we'll expand to 4 fellows. So I think that's exciting to see that sort of progress directly outside our area, but really important in terms of this ecosystem.
Fritz, that is so exciting. I'm thinking about Fritz on your team, and he hasn't told me about this yet. They have to come and spend 6 months at Bio as well. We can teach them all about lobbying on healthcare issues on the Hill, because this is so important that they have this really cross-sectional view. So Wayne, what's got you excited? You get the youth to see the youth every day. What's really
So actually the youth is what has me excited. If you look at the entering fall medical school class, we have an increase in African American male enrollment of 21% year over year. If you go back to 1978, we had less Black men apply to medical school and matriculate than we did in 2015. So this is a major reversal. And a lot of it, I think, has to do with bringing awareness. I think the pandemic has really fortified underrepresented minorities' position on really getting involved when they have seen the health inequities in our country. And I think the other factor is organizations such as the National Academy of Sciences has a project focused on Black participation in STEM and medicine in particular, and has been led by Kato Lorenzen over the past few years, and I've been honored to participate in that. But it has raised awareness and certainly given us an opportunity to bring those students in. So I'm extremely excited. When I first saw the numbers published by AAMC, I had to look twice because the jump was so dramatic in terms of the number of Black matriculants in medical school this year. So again, the work is not done, but it's a major leap forward. A 21% increase we have to call it something that we all have to be, I think, very, very happy and proud of.
And it really belies, the fiction that the talent's not out there. It says that we need to do a better job of attracting the talent and nurturing the talent. So, often a stumbling block in addressing inequities is the scalability. I'd love to get your thoughts and reflections on what is necessary to really scale some of the most exciting efforts. Wayne, let's start with you.
Yeah, I think in terms of education, we have to look at that very carefully. And I would admit, I am concerned. I think for a very long time, this nation has relied on this one institution here at Howard University in a huge way. And I think it's actually dangerous because we aren't funded and resourced in a way that represents how critical we are to the nation's pipeline. We send more African Americans from our undergrad campus to medical school than any other institution in the country. Over the past 20 years, we've sent more African Americans to STEM PhD programs from our undergrad campus than Stanford, MIT, Harvard, and Yale combined. Those two statistics alone worry me. We have produced more Black physicians than any other single medical education institution. If you look at the endowment for those four institutions that I just mentioned, it's huge. Today, depending on how the market did, it's well over 120 billion. My endowment is now at about 900 million. So you're relying on one institution in a big way, but we don't fund and resource that institution. And so I think to go back to something that Alexander said, it starts early. There's no doubt about it. But the fact that you can increase the number of African Americans in medical school by 21% year over year means that, to your point, the talent was there and we were looking in the wrong places or not giving them the opportunity. So I think what must happen and what I think is critical in terms of scalability is that we really have to push medical school admission committees to have a broader view of what a physician looks like and how we evaluate who should be in that pipeline on the way to medical school. The second thing I would say, we have a middle school on our campus, which is a charter school focused on math and science in particular. So we call it MS squared. And those young people, 96% of them go on to college, 60% choose a STEM discipline. I think it's been a 15-year experiment that has worked very well here at Howard that I think needs to be exported and scaled across the country. We need to put these young people right next to what they're seeing. I have a 17-year-old son, 15-year-old daughter. I had the opportunity to take them to the operating room for the first time about 3 months ago. And I'm telling you, nothing I will ever do in medicine again and nothing I have done before would give me such joy. Behind that mask, I could see the rush of excitement that my son got, that 17-year-old who there's so many other things distracting him right now. Plays soccer, has committed to play Division I soccer at the university I would leave unnamed for now. And the fact that he could come into that operating room and I could see behind his mask and his eyes the same feeling I had the first time I went to an operating room, just it gave me so much joy. It was worth it. Even if he never operates a day in his life or doesn't go to med school, that right there completed the circle. And I think that exposure is what we must be looking to try to build on a larger scale.
And so important given the growing inequities we've seen with school closures. I'm thinking back to my times at Johnson & Johnson, and every Take Your Child to Work Day, which was such a magical day on that campus, meant that there were hundreds, if not thousands, of kids seeing firsthand what it looked like to do research and development. But it made you wonder who was not getting across that threshold. And how could we get that exposure to a broader group of people? Joy, I saw you nodding your head. What do you think is the key to scalability?
No, what's interesting is Dr. Frederick and I have a very similar problem. We have ideas in the communities that's not been invested in, right? And so here he is at this university that's been building this amazing work, fighting above its weight for so long and not being invested in, being blamed and shamed about things that it doesn't have and not being invested in. That's what happens to Black mamas and Black birth workers across the United States. Scaling up and investing in and seeing us as valuable and worthy. Investing in Black midwives, Black doulas, Black birth centers. I was, when he was talking about even the numbers, like I grew up in Grambling, so I'm an HBCU baby. And then we have Xavier. I did my pre-med classes and stuff at Xavier, right? So there's all this talent that's in communities of color that has never been invested in. And you have the overinvestment in other places. They have so much money they can give it away, right? It's like thinking about this endowment that he just mentioned. That scalability of investing and seeing us as valuable, seeing us as policymakers, seeing us as he mentioned, broaden your view of what you see as a physician. We look like doctors because we are. Broaden your view of what you see as a CEO of a pharmaceutical company because we look like all kinds of things. And so we just need the opportunity for scalability is investing in what you devalued before because it's actually really valuable. And if you use your money and your dollars to listen to and follow the lead of the communities who have been doing the work, you will see return on your investments much bigger than you've ever seen before. And that's a fact.
Well, Joy, we're going to have to talk later because my father started at Grambling before we moved to California. So we're going to have to talk about this foundational aspect that's so important.
It is.
Well, Alexander, you have scaled within a company as well as, having reverberations across the industry. So give us a little bit of a sense of how you've done this at, the organizational level in such a big multinational corporation.
Yes, there's a number of things that we're doing. I'm actually, we've been focusing on inclusive research now as a specific, priority and measuring, holding people accountable around this topic for now since around 2016. And I would say that there's aspects of the work that we're all doing here. So some of it is going to take time. Some of it actually, I feel like we can actually already see the progress that we're making. It's wonderful to hear from Dr. Frederick already the increase in the number of African American medical school graduates. It's really exciting to hear. So at Genentech, we've really adopted this area as being a company strategic priority. So when I say that, this is not something that's sort of over here. Over on the side as something nice that we do that's sort of the back of the annual report or even on the front page of the annual report. It's integrated into everything that we do, and I think that is really critical. It's every single therapeutic area team as they're developing their strategies for their molecules, the research and the development, has this as a priority. For our teams that interact with the healthcare system, with healthcare providers, this is a priority. As we design our access programs, we think about, these aspects and we hold ourselves accountable for all different aspects. And that includes, the representation of our employee base, our scientists, our leaders, and we communicate this externally and internally to create focus and accountability that I'm held accountable for the progress or the lack thereof in this area. I think the other aspect, I think she's going to be a speaker else and another part of this agenda today is I really do think that it was appointing, in our case, a chief diversity officer reporting to me, creating a chief diversity office that included its capabilities around analyzing data and analytics to figure out where the opportunities were, and again, that accountability, to have a focus on inclusive research, which is, many of these areas require partnership, and and that is part of our strategy, is to partner broadly, as I think I've hopefully already communicated. But there's also a large part which is like within our own domain where we have an accountability. And I would say, inclusive research is one of those topics. The industry has really not done a good job at making sure that the studies are representative of the population. So, by having a very clear strategy that has that as a specific pillar and then holds every team accountable, every single officer at Genentech accountable, has a diversity inclusion action plan that includes those three pillars, including inclusive research. I think this is how we make progress on this topic as a large multinational.
Let's follow up on that point for a minute, because Genentech is really leading the industry in terms of the percentages of underrepresented minorities that you are enrolling in your clinical trials. Why is clinical trial diversity so important, and what is the uniqueness of Genentech's approach that is really resulting in really moving the needle in terms of participation?
Well, I think you'll be a much better judge of how our approach compares to others. I would say that we have a clear idea, we have a clear understanding of the issue and the accountability, and I think that starts there. That is really clear to us, and again, that accountability. I would say that. Our approach is one of both accountability and partnership. And I would say, in the oncology area that Dr. Frederick was highlighting we know that that the outcomes, the burden of disease and the outcomes are worse in these underrepresented populations. And in our minds, it starts off. Whilst there is lots of different reasons behind that, it starts off with we've got to do the research in these populations to then produce the evidence, to then create the trust. Now, we've got to work on a lot of other things. I don't want to oversimplify this, but I think it's that clarity, whilst there's accountability and a strategy which runs across the company, that is integrated to every single part, no matter which function you're in, you can see how what you do directly impacts our success in this area. It's then about starting off and getting in there and getting into actions. And on the oncology side, last year we actually announced an inclusive research site alliance. It's a collection of clinical research sites that also are very motivated on this topic to accelerate clinical trial diversity. And we're gonna, again, we can't do this all on our own, but they're gonna interact with the communities that have been historically represented. It's first of its kind, as I understand it, and Michelle, you would know better than I would, but it will allow us to start to test, try out and test different types of enrollment and outreach tactics. What is the most successful approach to reach these underrepresented populations, so we can actually move the needle. These sites, and this is where the basic stuff is. I mean, we've got to go to sites that, as an industry, we haven't gone to before, and that's uncomfortable for the industry. We're constantly under pressure, as you well know, for timelines and to manage risk. Actually, we've shown ourselves that actually these can be some of our highest performing studies in terms of speed speed of execution, quality of data is really outstanding. So we've gone to where the patients are. So the 4 sites, one is in City of Hope in California, one's the Mays Cancer Center in San Antonio, Texas. There's the West Cancer Center in Memphis, Tennessee, and then there's the O'Neill Comprehensive Cancer Center at the University of Alabama. And, we're going to try a bunch of different approaches. So, really ensuring there's diverse investigators and staff on the studies. We know that's that's important. How do we, unconscious bias training for the people enrolling the studies, interacting with the participants, patient navigation, patient education, and then addressing the real challenges, the real practical challenges. And as a trial sponsor, we have obviously things we can do here around, childcare burdens. If people are going to participate in a study, travel to the clinical trial sites, we've got to address this. Anyway, it's starting off with 4 sites in oncology. Our ambition is to really scale this up and move beyond oncology. Certainly in our focus would be neuroscience and ophthalmology as potential other areas. Geographically expanded too, not only within the United States, to other sites in the United States, but also potentially to Africa and to Latin America. And again, we're going to learn so much about this, and we want to share these learnings with broadly. I mean, we don't regard this as an area where this is about Genentech, competitive advantage. We want to really raise all boats and share this, and hopefully this will be broadly adopted beyond Genentech.
Well, it certainly is an industry leader. We actually did a podcast on Genentech's approach because it was so comprehensive and effective. So hats off to the concerted effort, because it's paying dividends. So, another area, we talked a bit about oncology, another area where I think we don't necessarily realize the depth of the disparities is in maternal mortality. A lot of people don't realize that the United States has one of the highest rates of maternal mortality in the developed world, and it's been going up, not going down. The rate of death is also predictably uneven, with the Commonwealth Fund recently reporting that the mortality rate is 2.5 times higher for Black women than for white women. So, Joya, can you tell a little bit more about why we have that gap and why it's persisting, and what is being done to try to save these women's lives?
Thank you so much. And building honestly on the work that they're doing there at Genentech, we have a similar motto. We believe that it's important that we de-silo. We know what's not working is the siloed approaches. Back when I was in medical school in the late 1990s, which in my mind is not that long ago, but my daughter would remind me, Mommy, that's a long time ago. I was taught in medical school that there were 3 biological-based races: Mongoloid, Caucasoid, and Negroid. So this was taught to me in the classroom. And although I organized at the time to try to fight against it, we still in this industry, and especially in pharma, have still a deep-rooted belief that race is biological, that gender is biological. So that belief, that misinformation, that non-scientific belief is causing us to do things like have separations in how we create drugs, and looking at the demographics. When we want to look at why you mentioned that Black patients are dying higher rates in childbirth. It's not because we have a Black gene or a Black kidney or Black lungs, but the racism, the gendered racism that's killing us, that's why we're dying. So you would look at things like access to transportation, paid leave, equal pay. You would look at the systems and the practitioners who are hesitant to care for us, who are building systems siloed on top of each other. The embedded white supremacy culture, the medical education that's not responsive, and doesn't even acknowledge the segregated care. I mean, I trained at a hospital that was named Confederate General 15 years before I trained there. That's not something we acknowledge. And it wasn't named Confederate General until the 1950s, 100 years after the Confederacy had lost the war, but because it was a statement to the community of what they wanted to honor. And so that same feeling of what you honor, the same devaluing of certain groups of people shows up in our clinical trials, shows up in our lack of diversity. So the leaders who de-silo, the leaders who know that there was never a biological basis of race, that there was never this hierarchy of human value based upon skin color, based upon gender, based upon geography, that we're all one. That's how you undo the harms that are causing Black mamas to die in childbirth.
And it's not just socioeconomically based. I mean, if you think
exactly. Yeah, we have data that shows from the CDC that Black mothers who have a college degree are 5 times more likely than white mothers to die within a year of childbirth. So we know that even no matter our income, our education, as Serena Williams, it doesn't matter. We cannot buy or educate our way out of dying in childbirth. So what we have to do to live and to thrive, to end the health inequity, is not keep blaming and shaming and telling Black mamas what they should be doing, because the data shows we do exercise. We do actually go to the doctor. We are compliant. All the things that you all made up in biases, the data shows they're all wrong. We're there. We're just not being treated like we should be. So that's what we need help with. How do we, technology for making those silos go away, ensuring that when we are there, that we are treated fairly and seen with justice.
Well, that's the reason why the maternal mortality bill being debated on the Hill right now is called the Serena Williams bill, because it's a perfect emblem that it's not about exercise. It's not about socioeconomic status.
If anybody knows their body in the world, it is Serena Williams, right? Like if she said to me as her doctor anything, I'd be like, oh, she clearly knows more than I do. So the idea that people debate Serena Williams about her body, like you wouldn't debate Aaron Rodgers about his. You would assume that he knew what he was talking about. I need y'all to give Serena that same respect.
So true. It's so true. Well, that touches on the issue about diversity among healthcare practitioners. And when you touched upon this a bit and, touted the increase that we're seeing, but can you put your finger on what is it exactly that makes increasing the diversity of healthcare providers so important in improving health equity?
Yeah, I think a major part of this is cultural competency, as well as recognizing, as I think you just heard very eloquently, that regardless of where patients are, you want to meet them where they are. And so there are two aspects to it that I do want to underscore. One is that every Black patient in America doesn't need to be treated by a Black physician, but they do need to be treated by a physician who is going to be empathetic and also go that extra mile from where they are. And those shortcomings don't belong only to people of one particular race or ethnicity. I had a 40-year-old patient with 5 kids, had breast cancer, operated on her, and the first day she had to show up for chemo, she didn't show up. And I called her, I have to admit, kind of from the ivory tower, why didn't you show up, etc. And she calmly said to me, Dr. Frederick, I apologize, but I work as a wage worker and groceries and rent were the pressing issue this week, and therefore I couldn't afford to miss work. And I tell you, I was devastated because despite the fact that I had spent so much time with this patient, I never once, stopped myself long enough to say, if you have to go to chemo this many times a day, how are you going to get there? How is that going to affect your employment, et cetera? And to be quite honest, I think sometimes we don't see that as our role, but it really truly is. And we have to do that. And that's why having a more diverse workforce that interacts with the patients is important, but just as important is having that be part of our medical curriculum. So while I do push on the issue of we need more Black physicians, we also need more people willing to open up their curriculum for that. And then the last piece I would say, which I think is relevant to a company like Genentech, Howard University is going to be doing cultural competency and unconscious bias training for major corporations in America. And our goal is to bring the CEO here and his or her C-suite to spend 2 or 3 days with us, interact and engage with our students, work on projects with them, because I think it makes a big difference when your VP has to sit in a room with a college student from Baton Rouge, who says to them, listen, I'm not going to go home this Christmas. I'm going to go stay with a friend because these are my circumstances. It makes a big difference in terms of humanizing this. And I think ultimately the last thing I would say on this issue is that the reason we're here is to amplify each other's humanity at the end of the day. And healthcare is one of the largest platforms of any field or industry that allows us to do that, to really see people for who they are not just treat them humanely, but to amplify their humanity. And the pandemic has shown that we have dehumanized so many of our fellow citizens, and this is an opportunity for us to amplify their humanity.
Yeah, so important, so important. So maybe we should turn to a magic wand question. So if each of you could only focus on one thing to really activate the health ecosystem and advance health equity, what, in your opinion, would be the most impactful? And I want you to think about this in two parts. What would be impactful right now? And if different at all, what would be most impactful in 5 to 10 years? Alexander, let's start with you.
Yeah, thanks very much, Michelle. I think, I think the magic wand, and you gave me a magic wand. I mean, I don't know if it's realistic, but I think, trust, earning the trust of the communities. That if we can, again, it's a magic wand. You didn't ask me if it was feasible to do it quickly, but I think, getting practical. There needs to be an acknowledgement of what has happened, the wrongs that have happened, an acknowledgement of the systemic barriers, and as I think was eloquently said, we've got to meet patients where they are, and increase the diversity and I think the understanding of the workforce that's serving these patients, whether it's in industry or in the healthcare system. And I think that the data shows, and again, we've touched a little bit on the pandemic. This is a nice panel because, I'm glad we're not only talking about the pandemic, but the reality is the pandemic does intrude on this topic, and it has been both a call to action, but it's also been extremely sobering and concerning. And we did a survey we fielded during the pandemic, and it showed that roughly half of medically disenfranchised patients say that their feelings around healthcare have actually deteriorated during the pandemic. And we already knew that around half of them feel that the healthcare system is actually rigged against them. So I think trust is, again, magic wand moment. Trust is what I would wish we could change, but the reality is it needs to be earned, and it's going to take time. I think longer term, I think what I would like to really see is really the scalability question that you asked. That the learnings and best practices that can be applied across a network of sites is shared across the industry, this will exist across the country. That people will be collaborating around learnings and best practices that will be shared. There'll be co-creation. And a level of collaboration and community partnership that I think will have a tremendous impact in terms of the science and delivery of innovation to all patients. So those are my two magic wand moments.
I love it. Joya, your turn with the wand.
Wand, yes. Give me a wand all day, Michelle. So I'd love for us to end the 400-year belief of a hierarchy of human value based upon skin color, based upon gender, based upon religion. Like, my magic wand would make us have a worldview that believes the least of these is as important, that believes that we win when we show love and affection and appreciation, not when we show fight or not when we beat someone else, right? So in that sense, we have codified into law a belief of a hierarchy of human value in the United States since our founding. So to undo that, my magic wand will make us have a White House office that undoes that. From the highest level of government, we have to work to undo the harms of racism, classism, and gender oppression. So you have to codify that into a place and not ignore both the cultural aspects of this belief and also the real, true structural policy barriers that are constantly show up in things like voting rights, things like access to the full range of reproductive options, and things like investing in healthcare access for all people. So we have to undo, and as a scientist, we have hypotheses. And for the longest time, the hypothesis was because certain groups are broken, we must do these things for them, right? So because people of African descent are broken, we must do these things. Now that we know that hypothesis, that beginning statement was always wrong, we've never been broken. Systems and cultures have been trying to break us. There's never been anything wrong about people of African descent, people of Asian descent, people anywhere. We're all just human beings, just trying to survive. So take away that beginning of that hypothesis, the belief that starts off that your job is to fix broken people, right? If you're here to fix broken people with your drugs, with your programs, then that's not what we're here for. And the reason that the disenfranchised healthcare folks see us as not being for them is because they see you seeing them as not as broken and not people who need support and love and well-being and who are deserving of care. So creating a culture of care, that's the long term. 5-10 years from now, we'd be a world, not just the United States, a world, a globe that really operationalized what I believe is Black womanism, a belief in love and ensuring that all people are valuable. So that's what I would want.
Love that. All right, Wayne, you get to have the last magic wand.
Yes, it's tough to follow those two magicians because they probably just solved everything right there. I'll kind of combine two themes, and it really is that we lead with love. So when I think of, for instance, a medical school curriculum, I think it's a missed opportunity that we don't have first-year medical students at every medical school follow a family all the way through their fourth year of medical school. Just think of how transformative that could be to deal with somebody you meet who's in middle school, then gets to high school. But over a 4-year period, you don't see those people as diseases or as diagnoses, but you see them for who they are. And in order to treat them well, that's what we need to do. And so interprofessional education that leads with that type of love, I think, is important. And Howard has, all 4 of the schools you need: pharmacy, dentistry, medical school, and nursing and allied health. And that's one of the things that we want to try to do to increase what that interprofessional education is so that we lead with love. Because as I said earlier, ultimately, this is not about treating someone in a short space of time over a 9-month pregnancy or over a 5-year period of a cancer diagnosis. That's not what we're trying to do here. And I think until we realize that what we're trying to do is to promote wellness and to do that through amplifying people's humanity, everything from where they eat, what they eat, what causes them stress and doesn't, and how we deal with the systemic racism that impinges so much wearing on them, then we get to a more complete and better society.
I'm struck with the distinction between following a family for 4 years and what was on the rise when I was in medical school, which was the standardized patient, the actor who was the interchangeable patient that you were supposed to, talk about dehumanizing when you think about it. And so we really do have to unpack our thinking. So let's end after those fabulous magic wands with what success looks like. What does a world with health equity of opportunities, and also challenges really look like? What is your vision for it? And what do you want the audience to remember as they participate in the rest of the summit when they keep that vision in mind? Does anyone want to step forward to go first?
I'll go first because I want to get it out of the way. Right now, so health equity is
honesty.
Health equity is all equity for everything, right? So equity in general. I want a world where you can't look at somebody and decide what they do think just by you categorizing them when you see them. When we can just see people as human beings, we walk into spaces and we do without thinking about it, making assumptions. My grandchildren, I want them just to get to exist, that people don't just look at them, no matter their color, their gender, where they live, and decide that they can just see them, but decide things about them. I want them to be known and seen and valued, and we get rid of these quick bias stereotypes about people. That's what I want.
I love it. Alexander?
Well, for me, right now, we've got a situation that in relapsing multiple sclerosis, people of African-American ethnicity need walking aids, whether that's a walking stick or a walker, 6 years before on average somebody of white ethnicity. We know that. We don't know why, and we're a long way from addressing it. So I've spoken, I know, a lot about the research aspect of it. But I think that's an unlock. But ultimately, those are all efforts. But ultimately, success looks like equitable health outcomes for all patients, no matter their race, their gender, their sexual orientation, their income, their zip code, whether in rural or urban settings. It comes to health outcomes. That's what success looks like. That's going to take hard work. We've been talking about that. It's going to take partnership. It's going to take collective power. But I believe we can make progress. But that is that's what success looks like, is equitable health outcomes.
Wonderful. And Wayne?
Yeah, I'm going to put on a very ambitious marker, and I think it's simple, and I think we avoid it oftentimes in these conversations, and that is that until the life expectancy among patients does not differ, whether it's gender, race, or ethnicity, I think we have an incomplete society. And I think we just have to lay that marker down where it is. Here in DC, in Ward 7 and 8, the life expectancy of a Black male is 22 years less than the life expectancy of a white woman in Ward 3. This is one of the smallest cities you could find anywhere in the world, 600,000 people. And yet still, that area that I just described to you is probably a 5 to 6 mile difference. And it's you can't get to either side without passing the capital of the most powerful city in the world. And yet still the life expectancy between those two people is 22 years. So I think we just have to lay down the marker that that's unacceptable. And until we close that gap, the work is incomplete.
Well, I love it. That's a perfect summation, because all of your visions would have to be true for that gap to disappear. And I'll just add that my vision is a world where we have science that is advancing at a miraculous pace, but that everyone can see themselves in the science, is invested in the science, and sees the hope being shared from all of that science among all their communities. And once again, it circles back to Dr. Frederick's statistic. And that's the one I hope that we really get to change and move. So thank you so much to each of the panelists. Thank you for your investment and time. Thank you for the work that you do outside of this panel to make the differences that you're making every day. And I just want to turn it back over to Mary Stutz.
Thank you so much, Dr. Michelle McMurray-Heath, for moderating such a powerful discussion. We just heard from Alexander Hardy about accountability and creating more equitable health outcomes, from Dr. Joy Creer-Perry about breaking the silos across the health ecosystem and ending a 400-year belief in the hierarchy of human value, and from President Wayne Frederick about ensuring that resourcing aligns with impact for institutions like Howard University, which constantly punches above its weight. What an important conversation to begin our summit. So thank you to you all. Thank you to everyone for attending. And please tune in for the next session starting soon on investing in health equity for the long term. We'll be back shortly.
Hi, everyone. Thanks again for joining us. I know that you have enjoyed the previous session with our CEO panel, and the goodness is just going to continue. Just before we go to our next session, a few housekeeping items. We will be sharing the recordings from today's sessions with all event registrants following the event. And then also we will be taking questions if time permits. So please feel free to submit your questions via the chat box on the right-hand side of your screen on the YouTube Live. Also, join the conversation via your social channels by using the hashtag RealChemRAG. That's RealChemRAG. So with that, allow me to introduce you to our moderator for this panel. Dina Shacker is a partner at Lux Capital, and she's going to be leading this session on investing in health equity for the long term. So we know that significant investment is needed to advance health equity, to put real solutions, real partnerships in place, to fund the needed innovation. And when you talk about long term, to scale. Scalability is also critical. So we're going to hear from this amazing panel, and I am going to go ahead and stop talking and turn it over to you, Dina, so that you can introduce your esteemed panelists and get us started.
Thank you so much, Mary, for having us and for putting on this conference on such an important topic during such a critical time for the world. So appreciate you and all the work that you're doing. I'll start with some quick intros and then really want to dive in so that we can hear from our esteemed panelists, starting with Dr. Michael Penn. Michael is the founding partner of Health Equity Ventures, a fund that invests in diverse entrepreneurs and disruptive companies that are focused specifically on meeting the enormous unmet need of underserved populations. He leverages his own deep background in neuroscience and mindfulness and ancient wisdom practices, and has also written a book, Finding Your North. He was a co-founder of a nonprofit called Building Diversity in Science, an organization encouraging students of color to pursue careers in science. He's on the board of trustees of St. Francis Memorial, which is a common spirit health hospital, and is also on the board of a women's health organization called Tara Health Foundation. We'll be talking a lot about women's health, I have a feeling, on this panel. Dr. Penn also is a scientist himself, an MD, PhD from UCSF, and studied biology at Morehouse as an undergraduate. We're so happy to have you, Dr. Penn. Megan, really happy to see you again. Megan is the COO of Rock Health, an organization that needs no introduction, an incredible leader in the digital health space for over a decade now. Megan leads Rock Health's enterprise membership, research, and operations. She is the force behind the power of community, the market research. They've produced incredible reports, and we're going to dive into some of the numbers there, many of which have informed my own investments. So thank you for that, Megan. Megan was previously at the advisory board, where she led the Physician Executive Council. She is a graduate of Berkeley and Duke and has studied health policy as well. So really happy to have you both here. I want to start off with just a quick framing conversation. The topic of our conversation is around health equity, and that can mean different things to different folks. So I want to start with just a quick, 30 seconds from each of you and how you define health equity. Let's start with you, Megan.
Yeah, thanks so much, Tina. Thanks for the intro. It's great to be here with both of you. I would say that, at Rock Health right now, we're thinking about it through a few different lenses. One, of course, is through the lens of looking at where healthcare disparities exist, those people and populations that have historically been disenfranchised, underserved, and are really feeling that in terms of the disparate outcomes that they're living relative to others. So I think that's one lens. The second lens is also when we think about emerging innovation, entrepreneurs, really being thoughtful about who's the pool of people that are really being supported, invested in, and do those folks really represent all the places and communities and people that we want to support? So really thinking about representation from a leadership and innovation standpoint. And thirdly is just thinking about it internally. We've done a lot of work over the years thinking about our own diversity, equity, and inclusion efforts. And how we show up for each other and how that's actually really important for figuring out how we show up for our community. So I would kind of hit on those 3 points.
That's great. Thank you. And Michael, it's health equity is in the title for your month. So I'm sure you have a very clear definition as well. Would love to get your perspective on what that means to you.
Yeah. So at the simplest level, I think of health equity as the ability for any person to achieve well-being, right? So that's in the broadest sense. But then I think and particularly why Health Equity Ventures exists, right? One aspect of health equity is diversity in fund managers, people who direct and control capital. Because we necessarily, given the fact that I'm a man of color, I'm a father of a neurodiverse son, right? All of that informs where I see opportunity, right? And how I evaluate investments. So, health equity, I think, is really an invitation for each of us to define it for ourselves. And then the common principle, and I think the pandemic has really shown this, is how interconnected we all are, right? Regardless of education, income, et cetera. When it comes to COVID-19, right, we're very much the same.
Absolutely. And I'd love to spend a bit more time later on in the conversation chatting specifically about the impact of the pandemic on how we're thinking about it. But for this panel specifically, we're diving into the topic of investing in health equity. So I want to get your perspectives from both of you in terms of the sort of market, if you will, the economic perspective here, because on the one hand, and I can speak to this as well, one of the things that excites me about our theses in this space is that not only is it achieving a healthier community, healthier society, hopefully a healthier world, as we'll talk about specifically with regard to the pandemic, but it is also an area that is capable of creating a generational company that can create real value for our limited partners, many of which are also philanthropic and charitable institutions. Megan, how do you think about the market for health equity and the prospects for investment in terms of capital deployers?
Yeah, definitely. So, and I'm sure I'm preaching to the choir, but it was a huge year just in terms of investment overall. So y'all have probably seen the numbers, but nearly $29 billion was invested in US-based digital health startups. So kind of when you look at the total market, it has grown exponentially because of COVID. And I think, of course, there's the acceleration of adoption among consumers, among providers and enterprise players. And this has kind of enabled investors, new and existing investors, to kind of capitalize on that opportunity, that market opportunity. And just to give context, $29 billion is nearly double what was invested in 2020, which was closer to 14 billion, which was the most which was an astonishing number at the time. So we are growing at such a rapid pace. When I think about investments in equity, I think it is really important to ground the conversation in, yes, to your point, this is so important from a community and population health perspective. It's so important from a justice perspective. And I also want to bring the frame of it's really important to also characterize it as an opportunity, as an important market opportunity. I think, when you consider kind of who are the biggest payers of healthcare in the US, Medicaid, Medicare, there are companies doing incredibly interesting things that, because they view this as a market opportunity, are able to be really creative and innovative with how they're serving those populations. Ask the leaders of CityBlock, ask the leaders of Circulo, who I saw just made an acquisition with Hurdle Health. And I think with also kind of paired with the shift towards value-based care, that creates an enormous opportunity for companies to not just think critically about, what can I bill for services, but what are the services that we can actually invest in, like food or housing, nutrition support, transportation. What are those additional factors that we can invest in when you're looking at population health, and really how do we, reduce costs, improve outcomes for that population? So I don't want to kind of squarely define necessarily certain companies as just going after equity, because I actually think there is opportunity across a lot of different companies. And with some of the acquisitions that we're seeing, like Included Health was initially an acquisition of Included Health, which was, Grand Rounds and Doctor on Demand deciding that they wanted to integrate LGBTQ plus centered care into their virtual care platform. And so it's a good example of, a solution that I think initially was built for the masses, really trying to get deeper on how do we serve particular populations really well and integrate that ethos into everything that we do. So that's really exciting to me. It's not, let's track funding for equity, but how are we seeing kind of equity-minded decisions and products permeating a lot more of the digital health ecosystem?
Absolutely. And I'll also add Ask the Leaders of Waymark, which is a full disclosure, an investment that we just announced last week, partnering with Andreessen Horowitz as well as NEA on a very exciting company in the Medicaid space. So lots more to come. Michael, your fund is dedicated to health equity. As you think about, how you make a case to your LPs and why this is, an opportunity that will generate returns for them, how do you think about framing the market?
Yeah, so the first way I think about it is just where the dollars concentrated. So if you look at Medicaid as an example, right, the hundreds of billions of dollars, right, that's focused there, as well as Medicare, right? So when I think about health equity, it's about groups of people who aren't well served by the current system, right? And that's inherently broad. However, there's an opportunity, I think, for intentionality, right? So we mentioned Hurdle and Included Health. There's a recognition and I think an increasing ability for startup companies in the healthcare system to really speak to individuals, right? In the ways that their identities intersect. And I think that will only become more important. And ultimately, the way that we define health and well-being at HEV is by integrating all of those things. Another example that's orthogonal, right, is I think it was an Andreessen investment in a company called Glorify, right? And it's a very Christian focused, it's not a healthcare company, but it's recognizing that there are more aspects of who we are that incorporate and encapsulate how we buy services, how we engage with the healthcare system. And so, what I get really excited about are companies that recognize that there's a higher power that they can tap into, right, to serve the individual. And so I think we're going to see more and more of that in terms of acquisitions and in terms of new companies.
Absolutely. We're 15 minutes in, and I've got to bring up my favorite topic, of course, which is women's health, which is not only an area that we're very passionate about at Lux, but also an area that is absolutely essential when we think about health equity. At Lux, we've invested in Maven Clinic, the largest virtual care platform for women and families, the first unicorn in the space. We're also investors in A-Life Health, with just doing advanced AI for IVF, and Aiden, which is building personalized birth control with polygenetic testing and biomarkers, and recently just announced this week in a company called GameToe, which is working on ovarian longevity. So definitely an area that we're excited about. But you touched on this a little, Megan, and actually Rock Health has produced some incredible research and I think coined the term Women Plus. Nomenclature is a big issue when it comes to this topic. So for the sake of clarity, I'm going to call it women's health, but please know that we are, it's certainly inclusive in intent in the language, of course, with non-binary and other folks across the spectrum. Can you share a little bit about what you uncovered in terms of what the trends are in women's health and how that relates to prospects for health equity, especially given half the babies in America are born under Medicaid?
Yeah, absolutely. I think a couple interesting things that I'll call out. And I think, Dina, you've also certainly kind of advanced thought leadership in this space as well, of not kind of exclusively thinking about women's health as centered around birth, right? As centered around kind of the fertility, pregnancy, birthing, and then parenting experience. Of course, those are essential pieces of potentially an essential piece of an individual's journey. And there are so many interesting solutions there. But, I think really excited to see companies think a lot more expansively. I think Maven or even a TIA are, it's really exciting to think through what are the comprehensive services that women, non-binary folks kind of need throughout the course of their lives. And I think it's important to dig into what are the chronic conditions that are disproportionately impacting women. What are the ways in which those are showing up in their lives, and thinking about things like, women are more likely to ultimately be caregivers, whether that's for children, whether that's for parents or grandparents. And so all of this definitely contributes to someone's mental health, physical health, and their capacity to care for others. And so I think, to Michael's point, there's so much opportunity to build with precision for these communities. And this is, slightly tangential. It's a little bit like upending the question, but I wanted to bring it up, which is that I think there also can be assumptions about who solutions are built for. And sometimes I think it's really intentional. This is a women's health product, but we have a portfolio company called Equip, which is a virtual care solution for adolescents with eating disorders. And there are huge assumptions about who those illnesses impact. I think, what I've learned from those incredible founders like Christina is that, a lot of people will assume, these are illnesses that, really impact women, white women who are thin, kind of that's the stereotypical model. And they have done so much in how they branded themselves, in their services, in their outreach, to make sure that people know, no, that is not exclusively or even mainly the population that is affected by anorexia and bulimia and other eating disorders. And so I think it's really exciting to see, to your point of how does equity fit into all of this? Founders really breaking the mold of, there may be assumptions that we need to break in order to serve populations that are incredibly in need of these services and maybe have been overlooked in the past. So apologies, a little bit of a winding response, but I think ultimately the expansiveness of women's health is really exciting, and the opportunity to explicitly call out when are assumptions actually getting in the way of us delivering care to populations that need it.
Absolutely. I'm so glad you brought that up, and also a big fan of Christina and Equip. So congratulations on that investment. Michael, I want to double click a little bit on the notion of racial justice and racial equity, specifically in maternal care. And I was, happy to see the White House putting a real emphasis on this unfortunate crisis that we're facing, and calling for a national day to recognize and put funding toward the Black maternal health crisis. How are you thinking about innovation that can help to address the outsized impact on communities of color in particular when it comes to maternal care?
Yeah, well, so thank you for that question. In many ways, right? So it again comes back to intentionality, right? And understanding your audience, right? And so there are many, many exciting companies in the women's health space. Cura Health is an example, Mommy based in Los Angeles. And right, it's leveraging both technology in creative ways, but also trusted relationships. And that combination, I think, of tech enhanced or enabled, coupled with trusted relationships, is a powerful synergy. But also on the other end of the spectrum, I'm invested in a company. Oh my gosh, this is COVID post-brain.
I've got it too. I'm right there with you. Don't worry about it. We can get back to that company.
Oh my gosh. It's a molecular diagnostics company that Sarah Prognostics is the name of the company. Right. And they have a molecular diagnostic for preterm birth. Mm-hmm. Women of color are 2 to 3 times more likely to be impacted. And yet there was a missed opportunity in terms of how that test was developed. And so I think there's a huge opportunity. They have data that shows that their test, by identifying women and giving their caregivers an opportunity to intervene, can save thousands of dollars per mom, right? And so there's a huge opportunity to apply that innovation, right? That doesn't require anyone to change their mind per se about racial justice, right? It's simply about providing equitable access, right? And I think we'll start to see disproportional benefits, both in terms of clinical outcomes, but also in terms of savings, right? For the system, but also even potentially revenue for providers. So I think there's just so much untapped potential with this focus on specific groups that are underserved.
I'm glad you brought up diagnostics, Michael, because I want to turn the conversation a little bit to the research side of the equation. And we've talked a lot about care delivery and about different overlooked markets. But when it comes to clinical research, Megan, how are you thinking about some of the investments that you're seeing that are targeting diversity in clinical trials and that are addressing both geographic and demographic inclusion at the earliest stages of research?
Yeah, we're seeing a ton of investment in that category on the whole when you think about largely software-based programs that are used to accelerate drug discovery or are used, to your point, in ways to accelerate clinical trials, whether that's recruitment, data management, electronic data capture, getting through the approval kind of regulatory pathways, et cetera. So that was actually like R&D catalyst is kind of how we categorize that space. That was actually the most funded category that we saw over the past year. I think what's exciting is, one, to your point, there are definitely kind of startups tackling that issue of increased diversity. But I think what's really important and has always been important with digital health solutions is that you need the enterprise appetite for that. They need buyers that they're selling into or who are actually going to integrate these tools into the trials that they're running, into what they're doing. And as part of Rock Health, in addition to being early stage investors, we advise those large enterprise healthcare companies, including biopharma. And we've actually gotten requests for projects over the past year from leaders at those organizations saying, we know this is critically important. And not just from a justice standpoint, but from the standpoint of we need to actually figure out who are the populations impacted by the conditions that we are trying to treat through our therapeutics. And, we just need to better match that. And so I definitely see that appetite growing. And that's not enough. I think when we started to do some engagements with those pharma companies, learned that it's also how are we connecting into those communities to build trust? How are we actually, tapping into people's voices who have had lived experiences for decades, for generations that impact their health, how they think about healthcare, who they trust in relation to their health, and how do they form relationships? So I think sometimes, with $28 billion, it's easy to get carried away and just be excited about the new stuff, the new people, the new innovations. But I think for all of this, including how do you gain the trust of someone to participate in a clinical trial when they have never done that before, you really need to think about connecting into communities that have that trust with those individuals.
Trust is such a key part of the equation, Megan. You're absolutely right. And I think, thinking back to the last couple of years and what we saw with the pandemic, an example that I often give in terms of how to think about technology and innovation in the context of healthcare and health equity is the incredible innovation that went into the rapid development and the breakthrough science behind the vaccines. But at the end of the day, technology alone was not enough to get shots in arms. Building trust, developing relationships within community. We're still seeing that today, of course, with the situation that we're in. So it's absolutely a key part of the equation. I am going to take a moderator privilege and chime in a little bit on a couple of our investments, only because I was asked to by Mary. But on the topic of clinical trials and diversity, this is an area that Lux has invested in for years now. We're investors in Science 37, which is one of the lead categories category leaders in the virtualization of clinical trials. And of course, as we know, going virtual is now become a necessity, but is one of the key drivers in enabling better access to broader patient sets who are unable to take time off from work or may be physically too far away from trial sites. So we're excited about that. We're also investors in Human First, formerly Electra Labs, which is specifically enabling biopharma to gather data through wearables and through digital biomarkers, another exciting area, as well as in H1, which is developing a really exciting program specifically focused on diversity in clinical trials. And importantly, it's not just on the patient side, but also on the provider side, which is an area that is really important. I think we saw a few months ago the Journal of American Medical Association producing a series specifically on racial equity in research and representation from clinical scientists as well in terms of who's actually researching the racial implications of medicine. So that's an important area that I think is often not discussed. And then, of course, there's geographic diversity as well. We recently announced an investment in M Pharma, which is helping to enable inclusion of data from across the African continent as well. It's shocking to me just how Eurocentric still our data sets are. And the result is not only that we're not getting to insights faster and to therapeutics faster, but oftentimes these are actually life-threatening implications. An example that is often shared is with the sleeping medication Zolpidem, commonly known as Ambien, where as you both may know, and for the purposes of the audience, the initial trials were did not include enough women, and the dosage recommendations initially for women were frankly too high, and so there were a number of reported incidents of women who fell asleep at the wheel as a result of being recommended a too high of a dose. And so these are implications not only for health equity, but truly for saving lives. I want to talk a bit about social determinants of health, Michael. And we have a question from the audience here, which is asking about how you think about living conditions, social welfare, social determinants of health from an investment perspective versus traditional tech-enabled services.
Make sure I understand the question. Is there a business opportunity in servicing or addressing social determinants? Is that kind of?
I guess to clarify the question, do you think about social determinants and living conditions in terms of technology and innovation, and where there might be an investment as a separate category, as factors that can go into decisions that you make around tech-enabled services? How do you think about this sort of notion of social determinants of health within the context of your investment theses?
Yeah, no, it's integral, because the reality is our health is determined outside of the healthcare system, right? So you have to integrate all of those things. So we talked about spirituality, right, as a dimension, right, of the whole person, but it's also the context in which that person lives, their culture, right, their values. And so you really can't separate them. And one thing that, clearly the pandemic has shown us, right, so deeply is how intimately connected those determinants are to health and well-being, whether it's access or even outcomes. And so I think, to me, the compelling companies and founders are those that really think in a comprehensive and almost a systems manner, because for addressing the needs of vulnerable populations, you kind of have to have all of those balls kind of in your mind, right, and design solutions in that way. And I just do want to make a comment about, diversity of clinical trials, right? And I'm very excited about all of the innovation in that space, but it's also just for the founders out there who are building digital health or even precision medicine products. There's so much of a great need to capture race and ethnicity data, right? Like all of the factors that make up who we are. We have to move to a place where we capture all of that data. So I want to just make sure it's not just about getting different people into clinical trials. It's actually making sure that when we're touching anyone as it relates to their health, that we understand more about who they are, because that then sets us up to generate interventions, right, that are tailored and specific.
Absolutely. A timely example of, with regard to the COVID vaccine trials was around the recent reports about menstrual cycles and the challenge of being, able to actually document the effect or lack thereof on women, because it wasn't part of the follow-up in the trial. And so it's not only about inclusion, to your point, it's about data capture as well. So I'm glad that you brought that up. You also brought up another point that I want to sort of turn to you, Megan, to ask about, which is around the sort of different stakeholders in healthcare. And this is one of the things that is often hard to understand from the outside if you're not working in and around healthcare. There are so many different providers. I guess providers being one of them, but so many different stakeholders, right? Providers, you've got pharma. I often call them the 3 or 4 Ps: providers, pharma, patients. How do you think about engaging these different types of stakeholders in the context of health equity? I know that Rock Health, as you mentioned, not only invests, but also engages with a number of different types of stakeholders in healthcare. How do partnerships help us drive health equity forward?
Yeah, it's a great question. I think that's always been at the core of what we've been trying to accomplish at Rock Health. I mean, we've made it clear our mission is to make healthcare massively better. And one of the ways that we think to achieve that, what you must do is engage this really kind of broad section of the healthcare community and kind of bring everyone in, because there's so much opportunity for cross-pollination of ideas. Just to give a specific example, and then we can pull back. I think one of the coolest innovations I saw last year, which actually had very little to do with technology and kind of the things we would typically invest in, was from a leader I spoke with at Penn Medicine. It was the Penn Center for Community Health Workers. Michael, you had mentioned that so much of our health is determined by things outside of the healthcare system, and I totally agree with that. And I also think that so much of our health care is going to be delivered not necessarily by the healthcare system and by kind of licensed people. I think in the future, there actually needs to be more of a focus on community health workers, on caregivers, on social workers, and even kind of peer coaches, therapists, like facilitators. Like, I think that community piece is so important. And so what they were doing at Penn was really looking at, okay, how can we connect non-clinical people with high-risk patients in the community and actually support them across a lot of these social determinants of health? It's not a particularly new concept, but they did a ton of interviews. They did a randomized controlled trial to show really strong outcomes. And I think pairing that with, right now, there's also a crisis, to your point of like all the different stakeholders that we rely on in healthcare. We really rely on clinicians, and they're incredibly burnt out right now. More of them are thinking about early retirement than ever before. There's such an emotional and physical, I'm sure, burden of carrying kind of this COVID crisis. And so I think what programs like this does with the community health workers is like, how do we kind of scale that pool of people that can support health and wellness needs when it's not necessarily like a therapeutic or a clinical intervention where you need a clinician providing care, but how do we kind of leverage all these other groups of people who can be trained to provide really critical support and nurturing support in communities. And so I'm excited about that, but I think this is where you have to think about the full ecosystem. So it's really hard to, in a model like that, bill because these people aren't licensed healthcare workers. And so how do we, again, think about this in the context of value-based care? How do we get health plans, employers, and providers around the table to think more creatively about care models like this that I think really put the focus on reducing disparities in health in communities and actually figure out how do we make a model like this sustainable? Because they've actually done a really good job of scaling to about 20 states. And then when you kind of start to layer in some of the scalable components of technologies, like how do we just kind of make this happen in a more scalable and sustainable way so it touches more people?
Thank you, Megan. We've got about 2 minutes left, so I'm going to end with a quick fire round for both of you, which is what is the area that you are most excited about as we look ahead to 2022 when it comes to potential investments in health equity?
Michael, I'll let you go first.
Thank you. So what I'm most excited about are opportunities to build solutions in communities, right? The pandemic taught us, right, that the communities actually have the greatest amount of knowledge and wisdom as it relates to their own health. And so what I'm really excited about is, both partnering with payers, entrepreneurs, and communities around building solutions that are tailored for them, and really scaling the hyper-local dimension of healthcare.
Agreed with you there. Megan?
Yeah, I love that too. I was going to say excited actually about marketplaces. I think right now the healthcare market feels fragmented from a buyer perspective, whether those buyers are patients and consumers or whether it's plans and employers. And so the opportunity for kind of consolidated solutions that are easier to navigate in the context of something like a marketplace where you can actually see what are the options available, what are the options that are best suited to me, can be really exciting and again, kind of hopefully shift the power balance into the hands of patients and consumers.
I love that. Well, thank you both for your hot takes. Super excited about the prospects and what the year ahead will bring. And thank you, Mary, for hosting this important conversation and conference and for having us.
Thanks, Dina.
Well, you are quite welcome. And yes, thank you, Dina, for being a great moderator for this panel, as well as bringing your own knowledge and expertise to this great work. And this has been a great session on investing in health equity for the long term. And I want to thank everyone that is attending. And I do want to encourage you to please tune in to the next session starting soon on new partnerships, investing in health equity. I'm excited to moderate this announcement that we'll be making through a couple of participants and partners about how some organizations are putting their money where their mouths are and the exciting partnerships that is creating. So, I know Michael knows about this, so it has been difficult for him to not one up, right, the announcement. But so, again, very exciting things happening. I think organizations and people are starting to realize that you just can't go at this in the traditional ways. And I just heard from all of you some very non-traditional ideas and approaches. These are the types of things that we want to bring out there and get everybody understanding. There are other ways to do this than just how it has been done in the past. And this panel, I can tell everybody on this panel is up for it. You're ready to make that change happen. And that's why our theme is changing out loud, because we're giving you the opportunity to share your thoughts, your thinking, your visions of what's possible and the unique and different partnerships and how we have to consider the whole person. We cannot just look at individuals, but certainly, just as healthcare subjects or patients, but they are individuals and they live in communities, and we have to take all of that into consideration. So thank you so much for your brilliant ideas and thoughts about how we can invest in health equity for the long term. So with that, I am going to just remind you to, as I said, we are going to go into the next session in about 10 minutes. So we'll be back. But until then, thank you to all our panelists and thank you to all of you who joined. We'll see you soon.
Hi, everyone, and welcome back to the Real Health Equity Summit. We are really excited about our next session with the American Hospitals Association and Jumpstart Nova on new partnerships, investing in health equity. We won't have time this time around at the end of this session to answer audience questions, but we still want to hear from you. So please do drop your comments on the session on the right-hand side of your screen on the YouTube live chat. And just a note about housekeeping, remember to join the conversation on your social channels as well by using the hashtag RealChemRHE. And with that, I will hand it over to Mary, Doug, and Marcus.
I'm super pleased to have this conversation that we're about to start with our guest. Joining me for this conversation is Doug Shaw. He is the SVP of Business Development for the American Hospital Association, and also Marcus Whitney, who is the founder and managing partner of Jumpstart Nova. As you've heard us say already, we've really spent, as a society, we've spent the last 2 years shining a light on the challenge to addressing health inequities. And for real health equity, we want to make sure that we focus on the work that is happening, the organizations that are doing the innovation. We want to focus on things that are impact-driven, silo-breaking solutions, and we want to make sure that it's all focusing on this concept of shared responsibility. And so our guests are going to talk about something that is very different, out of the box for the organization and both organizations as they are pursuing new ground and forging new paths in our focus on advancing health equity. So Doug, I'd like you to start with giving us a little bit of background about the American Hospital Association's commitment to advancing health equity and what you're doing to address it.
Sure, I'd be happy to. You know, in brief, the American Hospital Association has had an entity called the Institute for Diversity and Health Equity, and this team has been working for some time on addressing health equity from a number of different perspectives, from programmatic opportunities within hospitals and health systems to helping to address greater diversification of the boards representing those same organizations. Early in 2021, we identified an opportunity to do to open a new front, if you will, and that was to really create opportunity to invest in the emerging solutions that we need but don't see enough of in the field for health equity, to address the underrepresented communities through solutions that are best described and best developed by people who understand the communities and their particular needs. Mm-hmm. So our goal had been at the outset of last year to identify funds, venture funds that were working specifically to address health equity, working specifically to equip entrepreneurs and founders who took this, is a serious mission to address, and to work with those funds who themselves are led by those historically underrepresented in the venture community. And I'm pleased to say that we had identified in relatively short order last year a handful of funds that really met those criteria. It's a fairly, exclusive list of funds that met that criteria. And Marcus Whitney with Jumpstart Nova is one that we will be working with and are preparing to take an investment in.
Thank you. And that is, I do want to just talk a little bit about that, the recognition that that there have to be resources if we are really going to move the needle, and the fact that it has to be significant resources, I think is something that a lot of organizations, entities are missing that point. And so many organizations are just focusing on their own silos and what they're doing within their organization. But I have to say kudos to the AHA for recognizing that not only do we have to partner outside of our silos, we've got to fund outside of our silos. How difficult was it for you to get your organization to move in that direction? I have to ask.
Not as difficult as you might think. We've had some experience in the last few years of putting, well, as they would say, our money where our mouth is. That if the field needs innovation, then why shouldn't the AHA step up and help invest in that very innovation? With the success that we've had doing that for a few years, we realized that innovation, broadly speaking, is a good thing, but could we direct that innovation activity towards those things that we've said are among the top priorities for the association to address? And immediately as the words came out of our mouth, health equity was the first thing we began to look at. There are not an overabundance of healthcare focused venture funds. I mean, healthcare is certainly a big play in the venture fund world, but when we get to those solutions and innovations that hospitals and health systems care about, we're not looking at patent extensions or other things. We're looking at things that truly are programmatic improvements and solutions that address community needs. There aren't as many as you might think. And then when you further constrain that to saying which are really focused on health equity and which are really lifting up those founders and entrepreneurs in those communities, it's a short list, but we were committed to wanting to do it. We'd had the experience in doing it in a broader sense. And as soon as we raised the concept internally, we got nothing but green light. The time that we've spent in 2021 setting this up was really in helping to look for those funds that met our criteria and talking with folks like Marcus and getting us all on the same page with regard to a 3-point plan that we can get into a little bit later about how we think we can go about this.
All right. So then now, Marcus, tell us about your vision and your commitment and why you started Jumpstart Nova and your ability to be discovered, if you will, by the AHA with this great funding initiative.
Yeah, so I'm based in Nashville, Tennessee, and Nashville is a very, very strong healthcare services cluster. Not exclusively hospitals, but certainly there are some very, very significant health systems that are based here. And that's really sort of the genesis of the cluster here was HCA. And so being in this ecosystem, you have connections to real leaders in the healthcare system that you may not have if you're in other places in the country. And so I've been very, very fortunate to be in the early stage healthcare venture space for the last 7 years and developing relationships with real leaders, not just like kind of from the outside making these investments and hoping, but knowing CEOs and SVPs of major multi-billion-dollar health systems and becoming friends with them. And so over the last 2 years, as you said, as the whole country was looking at this issue of equity and health equity in particular, I sort of looked around Nashville, thought about the power that lived all around me, and also sort of recognized my own position as really the only Black healthcare venture capital partner in town. And Nashville is not known for being incredibly strong when it comes to venture capital broadly, but in healthcare, we definitely punch above our weight, I would say. We have a very, very strong legacy of healthcare venture capital funds that have been very, very successful here. And so, it's not like when I say I'm the only Black healthcare venture capital partner, I'm talking about 1 out of 3 funds. We've got double-digit funds here that have managed hundreds, probably in aggregate, multiple billions of dollars over the decades. And I'm sort of I am the only partner. And so that put me in a position where I recognized that I probably was then the only voice that could talk about how problematic that was, right? And how when we were hearing the leaders of the healthcare industry start to make calls for health equity, well, so much of the work that's going to happen in health equity is going to be innovative work, right? Because you're talking about addressing problems that have not been addressed for a very, very long time. And so the idea that you're going to go ahead and do some incremental work inside of your existing organizations is unlikely. You're probably going to need out-of-the-box thinking, out of the box ideas and out of the box people to come in and work on these problems, people you've never seen before, you've never met with before, and they're not going to come from within your four walls. And so to me, the way that that's going to be operationalized is going to be through venture capital. So I say all that to say that led me to write a letter in June of 2020 to Nashville's healthcare leaders. I felt that I had earned enough respect and I had strong enough relationships that I could speak in plain English about the situation we were in and sort of, some of the unfortunate systemic racism that was underneath the healthcare industry from decades ago, that today's leaders weren't intentionally promoting or anything like that. But when you're talking about an industry that was started in the 60s, right, it's like you're sort of stuck with some things that were baked in back then, right? And that's really what I was trying to sort of illuminate, and that we hadn't really addressed the things that were baked in back then. We just didn't do a job of sort of saying, hey, how do we address the fact that when this whole industry started, everybody didn't have a seat at the table, right? And so you look you look today and you look at the management teams, you look at the boards of directors, you look at the venture capital funds, and they are overwhelmingly white and male, right? And that's just the way that it is. It's just the reality. So wrote the letter, got an overwhelmingly wonderful response from leaders in the industry, and realized, hey, maybe there's an opportunity for me to take this platform that I've been building for 7 years, this Jumpstart Health Investors platform, and create a new vehicle that was dedicated to investing in Black founders. And when I first even said it, I thought, I don't think I've ever heard of a healthcare vehicle that was doing that had that exclusive focus. I figured people were saying, hey, we're trying to really focus on people of color or diverse founders or things like that. But I was pretty clear I wanted to focus on Black founders, not that other people of color don't also need to catch up in the venture capital game, but quite frankly, each one of those groups needs their own level of focus and attention, because those communities are not sort of one big amalgam. It's each community has its own issues. And so I'm uniquely qualified to raise and lead a fund that's going to invest in Black people. And so Black founded and led companies, innovative companies, right, that can address healthcare problems, maybe problems that can help all of us, but certainly problems that could help our communities, right? And again, the response was overwhelmingly positive. I just want to say one thing about the AHA, because I spent a year and a half raising the fund. Today, as this equity event is happening, is the official launch of the fund after, I guess, 16, 17 months of really hard work. And we ended up with, thank you, and we ended up with almost 100 limited partners, which is a lot of limited partners for a fund. But we wanted that because for us, we felt like this was a movement, and we wanted people who wanted to participate to participate, as long as they were credit investors and all that kind of important stuff. But the reason why I'm bringing that up is because if I have 100 limited partners, I talk to many more than 100 people and organizations. And so I can tell you that the response from the AHA, that not just I, but my friends who are Black fund managers also raising funds that I'm friends with and had the pleasure of sort of all talking to the AHA at sort of one time. The response when we went from, hey, this initial meeting to get to know us, to us saying, hey, listen, we're raising funds, we need to, and them saying, got it, let's go. That was very, very, very unique. Okay. That was very unique. And we felt very respected, I think, because they understood hey, we're not here to go through workshops or something like that. We're raising funds, all of us had prior investing experience. I've been running this business for 7 years. Toyo at Sia Ventures was running venture at Blue Cross Blue Shield of Massachusetts for 8+ years. You know what I mean? We weren't new to the game. And Doug, I want to thank you and Joy and the team for treating us with the respect that we didn't always get while we were, out raising. It felt really good, and it makes us very grateful to be in partnership with you.
This is like a tutorial for partnerships, just between the two of you talking about how this moved forward. I mean, this is something that just needs to be shared. You've touched on so many things, both of you, in your approach, how you got your organization moving forward. Marcus, how you, as a person that is at the forefront and knows what needs to happen and is driving that change and giving real feedback, addressing the elephants in the room of, the unique response, the rapid response, because I mean, this has been going on for so many years. Like you said, we don't need to drag it out forever. The respect, the not building in all the bureaucracy and workshops and all these things. I mean, it's just, these are the types of comments that we get back from folks who talk about the frustration, right, of trying to move different innovative things forward. So kudos to both of you for what you've done and for the partnership. So Marcus, you're closing your fund in 100 partners. What's the number?
Yeah, so we went out to the market. Look, we had no idea what the appetite for the fund would be, and all of the initial conversations. This changed pretty quickly once we started to build up deal flow and can kind of provide what the pipeline looked like. But early on, it was like, are there founders out there, right? And it was a reasonable question insofar as nobody had ever organized the data around this particular issue before. I would say the best that we ever had was Dr. Ivor Horn did a report just before we started to kind of go to market on digital health and founders of color. And so that was, I think, the first real work that had tried to give us some data around how many founders there were out there and how they were faring out in the market in terms of raising capital. So we went to market with a target of 30 million. And we, for Fund One, felt like that was pretty good. We're focused on seed and Series A investing. We've had a really, really great response, and we then oversubscribed and had our hard cap raised just a little bit. So we closed finally at 55 million.
Yes, that is super amazing. Congratulations. Wow, that is amazing. And so, Doug, this was your first one, and you have two others or three others that you
in that ballpark. Yes. Marcus is the first of a series that we intend. Yes. And what we're intending is kind of a 3-point approach to partnership. I think it may really stretch the definition of what a limited partner is. First, we want to invest. We see real value and real diligence in the deal flow that Marcus has already developed. We really like the investment philosophy and the strategy that he's employing. Second, we want to make sure that our members see and have the opportunity to understand the same thing that attracted us. Our members, like us, oftentimes take investments from their reserves into community solutions, into other innovative approaches that are going to improve their ability to care for the communities that they have for their responsibility. And so we would expect that in raising awareness of what Marcus is doing with the fund, that there may be some hospitals and health systems out there intrigued enough to want to invest as well. As this first fund is closing, this will help to develop a pipeline for Fund 2 and subsequent funds that Jumpstart Nova may offer. And the third point is it's not too early because, again, there is a real portfolio of promising companies already within Jumpstart Nova. We want to raise visibility of the work and the solutions and the entrepreneurs that are already in play, so that there's an easier time for them to develop a pipeline of customers or prospects as they begin to get traction and grow scale. So that's where we see the AHA being a helpful partner, not just in developing the pipeline of investors, but also the pipeline of potential customers for these companies.
Thank you. And then Marcus, give us a quick sense of the types of companies that you're already looking at to fund. I mean, types of companies as in what kinds of approaches are they taking to addressing health equity?
Yeah. So when we look at the companies that we're investing in, we look at them through the lens of really the type of business model that they're employing. So are they a health IT company? Are they a biotech company? Are they a tech-enabled healthcare service company? Are they a consumer health and wellness company? Are they diagnostic device companies? So that's really how we organize our companies when we look at them. Not so much what particular population are they targeting, because for us, we feel that generally speaking, if what they do has real efficacy, then it can work across multiple populations. It's really just a matter of getting aligned with the right partners. And this is so key in healthcare, probably more so than almost any, I won't say any, but almost any other industry. And this is why, I really love what Doug said about stretching the definition of limited partner, because that's critical in healthcare, right? It's like no one is an island in healthcare. You have not seen the healthcare industry disrupted by the innovations of the internet as you've seen other industries. And the reason is because A, it's a highly, highly regulated environment. B, it's the business of lives. And so, this is not something that should be easily disrupted. And so you've got to work with the people who already are responsible for managing these communities, for managing these communities and who have these communities' trust. And so we have to be looking at how can we organize our limited partners to be able to support our portfolio companies. And so it's very much, it's weird. It's a little bit like a marketplace, right? Insofar as our job is, healthcare is a $3 trillion industry. There's a million different things we could do. We have to match up our limited partners and their strategic needs. And we need to understand those strategic needs with our portfolio companies, right? And so sometimes we may see a fantastic portfolio company, but feel we may not be the best investor for them, because even though we can put capital, we may not have the strategic capabilities to really help them be successful. And we just feel strongly that in healthcare, that strategic piece is critical. It's not just about the capital.
That's amazing. Thank you so much. So
I will add, we could not agree more with Marcus on that point, that the days of, passive investment in a fund should be over for any limited partner who really cares about what they're investing in, that they need to stand ready as more than just money, but contributing time and expertise and entree for those entrepreneurs to gain traction.
Excellent. Thank you so much. This is an amazing solution. I'm so excited to share this with our audience during the Real Health Equity Summit. Thank you so much, Doug Shaw, VP of Business Development with the American Hospital Association, and Marcus Whitney, the founder and CEO of Jumpstart Nova. All the best to you. We're going to stay connected and keep track of all your great work, Doug, and your progress, Marcus, because I know we're out of time, because I would love to hear both of you talk about where you see us in the next 5 to 10 years if these approaches are really gaining traction. But I think we're out of time, so that's for the next conversation. Thank you so much for joining us.
Thank you.
Thank you, Doug, Marcus, and Mary, for another great conversation on new partnerships, investing in health equity. And, Marcus made so many important points about what it takes to truly ensure that diverse-led funds and innovative organizations have the resources they need to really improve the health outcomes of all. Thank you all for attending. Please tune in for the next session, which is starting soon, on disinformation and digital determinants of health. You'll definitely want to hear from Dr. Lisa Fitzpatrick, who is a leader in the digital health literacy movement, as is Dr. Garth Graham, who is a leader at YouTube Health. We'll be back in just a few minutes with more.
Hi, everyone, and welcome back to the Real Health Equity Summit. We are super excited for our next session on disinformation and the digital determinants of health. I am a firm believer, if you've ever heard me talk about it, that our digital innovations and health literacy are going to help us move the needle to advance health equity. But there's a lot to do so that our digital assets don't actually work against us. So this panel is going to provide some great perspective on that and talk more about the solutions that will help us advance health equity. Just before I turn it over to them, though, a few housekeeping items. We will be sharing the recording from today's session with all of the event registrants following the event, and we will be taking questions also during this session if time permits. So please feel free to submit your questions via the chat box on the right-hand side of the box on your YouTube live screen. Okay, we definitely want to hear from you. Also, join the conversation via your social channels by using the hashtag #RealChemRHE. That's RealChemRHE, and keep the conversation going. So with that, allow me to introduce you to our moderator, Jennifer Paganelli, practice leader of Earned Media here at Real Chemistry. And she'll be leading this session again on disinformation and the digital determinants of health. And JPEGs, as we like to call her here, I want to turn it over to you and your great panelists so that you can get us started. Welcome, everybody.
Thank you very much, Mary. It's been an incredible day so far of dialogue, and I want to thank everyone for taking the time to join this very important discussion this afternoon as part of our Health Equity Virtual Summit. As Mary said, I'm JPAGS. I lead our Earned Media team. We're also very earnest, and usually at JP Morgan, we're dealing with reporters who are covering advances and news coming out of the meeting, but there's no place I'd rather be today than helping to moderate this discussion about a very important topic, disinformation and the digital determinants of health, featuring two incredibly passionate thought leaders who not only talk the talk, but walk the walk in a really big way. So I'll make a couple introductions. We'll get to our top 10 list of questions. We'll keep the floor open for your comments and questions, and I'll do my best to get to them. So let's get to some intros. First, let's welcome Dr. Lisa Fitzpatrick. She's an infectious disease doctor and CDC-trained medical epidemiologist. Her career has spanned medicine, research, global health, community education, and patient advocacy. She is the founder and CEO of Grapevine Health, and a phenomenal content creator in her own right. In fact, she just recorded her 50th episode of the Grapevine Health podcast, which highlights stories from and insights and experiences from her community members. So we'll dig into that and why that's so important. But Lisa, thank you and welcome.
Thank you for having me. Great to be here.
Of course. We've also got Dr. Garth Graham. He's the director and global head of healthcare and public health at YouTube. He's a cardiologist by training and brings really deep experience, not just in the private sector, but also in academia, government, etc. He's been in his role at YouTube for about a year now, so he cannot say that he's the newbie anymore. And we're really excited to hear about the progress he and his team have made in short order. So thank you, Garth. Thank you, Lisa, for helping us grapple some of these complex issues at hand. And as they relate to disinformation in a digital world and the very real impact on underserved communities. I want to focus on shared responsibility, investment, and the action you feel is needed right now by individuals, by companies, and societies so we can address it together. And don't sugarcoat anything. This audience can take it, so I want you guys to be real with us. So let's jump right in. All right, question number one. You are both so incredibly accomplished in terms of your health expertise, and you've had professional journeys that have taken some interesting twists and turns along the way. But I want you to tell us what personal experience or light bulb moment led you to your current role today or inspires your work. Dr. Lisa, I'm going to put you on the spot and ask you first, and then Garth will follow.
Well, JPEG, thank you so much. It's great to be here. And I'm glad you asked this question because a lot of people don't actually know this story. There is a moment that led me, even though it was many years ago, led me to this moment right now. And that is when I was at CDC, I was also pretty engaged in the community. And I sat on a panel answering the community's questions about health. And afterwards, a man walked up to me, maybe in his 50s or 60s, and he said, "How does someone like me access someone like you on a regular basis?" And this is a man who had a primary care provider. He was on medications for his health conditions. But something about the way I was communicating to him spoke to him. And I thought, there are probably millions of people like him who leave the hospital and leave their doctor's offices every day, and they have no idea what to do or what was said. And I wanted to use my talents to help people like him. And so while it took me a really long time to get here, that's always been sort of my North Star, thinking about that gentleman, all the people like him, even my own patients who have told me about not understanding what we're saying to them. So.
Thank you for sharing that. Thank you. Garth, what about you?
Yeah, so I'll try to make mine short. And following Lisa is always a challenge. But I'll try to cut it into. So one, I would say personally, I'm from Jamaica. I'm Jamaican, but then grew up in the U.S. And I would. There were a lot of people in my personal life that, as I kind of got more education and felt I was learning more, would have disagreement in terms of views, and they would have different views of health as I kind of learned the traditional health system. And what I realized, similar to what Lisa was saying, is, a lot of folks in our communities, there's a couple of things that happen. I think one, the information that we generate in our kind of education or kind of healthcare infrastructure many times don't make its way in the right way down to the people like where I'm from and people in our community. And then similarly, many times there are belief systems within our communities that are not respected by kind of the traditional way in which healthcare is delivered. And I, as a clinician, oftentimes would find myself arguing with my longtime friends and people I'm so close to, people I've known since I was like 3 years old. And we have just very different beliefs, but it doesn't mean that they are evil or wrong, but sometimes it's just different views on the side. So this concept of how information makes people make decisions all been important to me. And then as a clinician, you see so often people make decisions based on, again, information. And I think information is a determinant of health, much the same way there's social factors that are determinants of health and other things that play into kind of the healthcare ecosystem and how people make decisions. So I think kind of both, professional living in a world of highly educated people who have education, and then another kind of highly educated people who have a different kind of cultural, some may say street smarts, but other kinds of educational world, and realizing we need to bridge those two in terms of how we share information with communities.
Thank you for that. Thank you both for sharing your North Stars and what kind of inspires you every day to tackle, what can sometimes seem like a really overwhelming challenge. Lisa, I want you to help us ground us for a second. A lot of us know what misinformation is. We've heard about the social determinants of health. Garth just mentioned kind of the information determinants of health. School us on the digital determinants of health and what that really means, because I'll tell you that was a concept that was a little newer to me. I don't often hear the phrase. So educate us.
Well, we're often coining new phrases. So even though we're talking about that today, just wait next week and then you'll hear a new one. So
totally.
But when I hear this term, digital determinants, it makes me think about access to technology and the technological tools that are so readily available for so many people in society, but with uneven access. And so there are a couple examples of this. One is we'll take telemedicine, since that's on just about everybody's minds right now in healthcare. When when the telemedicine rollout happened because of the pandemic, it took a lot of catching up to ensure people who didn't have broadband access or didn't have the skill set to use the technology they have, whether it was their phone or their iPad. So what we saw was that a lot of people in underserved communities, they were less likely to access services via telemedicine until we were able to improve their digital literacy, help them understand how to use technology. And there's also a lot of fear in some of these communities, particularly among seniors who don't like to use technology, but they realize once someone helped them that, wow, this is something I can do. And there are still many people who have been left behind because they don't have access to technology and can't have a telemedicine visit. So we still have work to do in that area. The other big area that I think we need to talk a lot more about across the health sector, but particularly among payers, is access to remote patient monitoring tools. So these are things like pulse oximeters to check your oxygen, blood pressure cuffs, glucometers, so that people with diabetes or who are concerned, they have pre-diabetes, they need to monitor their blood sugars. The access to these tools is also uneven. And so I think these are the things we need to be talking about when it comes to digital determinants of health, because the people who have access to these tools are the same people who've had access all along. And we will exacerbate inequities if we don't figure out a way to enable access to these tools and teach people how to use them who traditionally don't have access.
That's great. Thank you so much, Lisa, for grounding us there. Garth, I want to turn it to you for just a second. You have been in your role at YouTube for about a year now, and I think a lot about YouTube's scale, the reach. You're reaching 2 billion people a month, I think was the latest stat. It's insane, and the responsibility that really comes with that. So how has the company taken concrete actions to address some of the disinformation that's been proliferating well before COVID, but certainly COVID has shined a light on it, right? I think about vaccine hesitancy and the like, but I know you and your team have been heads down standing up some unique approaches to counter that. I'd love you to tell us a little bit about those.
Yeah, so, I view tackling misinformation as kind of multifaceted. First, decreasing and removing the misinformation, disinformation that people may see is one very important first strategy. So, reducing the risk that people may be exposed to bad information that may lead them to make harmful or bad decisions. And so we've been very proactive about removing and kind of evolving and continuing to be very aggressive in that context. First started with COVID, and then along the general vaccines route, expanding a lot of that to kind of tackle vaccines overall during my time so far, to be able to tackle misinformation proactively. And one other important part of this is, then this goes back to kind of something Lisa was saying, is along those lines, people have questions. People are seeking information, and it is not that they're nefarious to seeking information. Many times people just want to make the best decision for their own family, and they may end up getting the wrong information, making bad decisions. And no information is also not helpful as well. And so being able to create information, to work with people who are creating information in culturally relevant, understanding the concept of health literacy and how you reach people, using video as a very concrete way to break down information. And quite frankly, we worked with Lisa and others. And, some of the stuff that Lisa and her team have done, I think is on the cutting edge of how you really communicate with community. And so we've been trying to advance a lot of that work and advance it globally, not just in terms of how you work in DC and the Bronx, but also how you figure out how you work in India, how you work in Japan, how you work in UK, and working with a lot of the various entities there. So I think What we're trying to do is evolve how health information is communicated, understanding the importance of culture, understanding the importance of context. I use a really good example that, honestly, there's two examples I use often. Is I talk about the work that Lisa did and does. And the man in the street, and how she takes the voice of the man in the street and amplifies it to be as important as anybody else's voice in this conversation. A funny story, some work we did with Dr. Fauci, where we paired Dr. Fauci with the rapper Fat Joe. And it was really to try to get to deliver, at least when we're in the earlier phases of the pandemic, deliver information about not necessarily vaccine safety, because it wasn't vaccines were already then, but at that point to understand how people could deal with their fears about COVID, but also understand safety measures. And in the middle of it, Fat Joe asked Dr. Fauci who's his favorite rapper. And I was like, oh my gosh, he's gonna lose the whole audience now. And he's like, Tupac. And then he explained why Tupac was his favorite rapper. And what Dr. Fauci did there is he broke down the information or the cultural barrier to have people get an understanding of how he understands the culture, and so that his information can be delivered in a better. And it's a small example. And again, like I said, I think Lisa does a more scaled, better example. Others who work in similar work that she does. But the whole idea of how you reach people in a culturally sensitive way is important. Gone are the days, JPAG, where people are looking for a flyer or a billboard as their only source of information. Gone are the days when me as a clinician, my word is all that matters. And if I go, jump 2 feet and then skip, people are going to do that. No, they're going to take information from different places, from people that they trust, and then make the decision. And there's nothing wrong with that. People should be empowered. And so this idea of how you shape information in a culturally appropriate manner, and the work we've been trying to advance, working with a lot of similar groups who do that, is particularly important for us.
Can I add something to a comment Garth just made about the video with Dr. Fauci? What's so important about that is the ability to express humanism, because it builds trust with people. Because so often physicians and other healthcare providers, scientists are put on some sort of pedestal, and we're seen as untouchable. But when we can be real and authentic and show people that we're human too, and that we don't have all the answers. Like, I'm someone who will readily say, I don't know, and share concerns. Like, right now is a great example. There are so many ways I've been humbled by the pandemic. So I think that is really an important element in trying to reach people with health information. Being honest, being relatable and authentic, and showing that you do understand, or that you share some of the same concerns and some of the same interests, that makes us much more effective at being able to get people's attention, and it builds trust.
And that's important. And that concept of building trust is important. And all of these things around trusting information, trusting science, that's what really makes people make decisions. So again, be able to remove and tackle, and get rid of misinformation, that's very important. But what Lisa and folks who do her kind of work that we've been working with, pioneering, I honestly think is the future of medical communication. It's this idea of how do you digitally and in other ways advance the voice of the community, so they trust you, and then decide and make decisions there. So not to persevere on that point, but that concept of trust is particularly important when you want people to, follow what you're going to say next.
Well said. And Lisa, did you hear what Garth said? You're going global, girl, and I love it. If anyone hasn't checked out the Dr. Lisa on the Street videos, after this session, not now, go check them out. They're really awesome, and they're real.
What's interesting about the comment, though, is that many of us, myself included, in the health sector, have a bit of an elitist attitude toward communicating with people in the ways they want to receive information. And so, namely, YouTube, social media, some of the gimmicks on TikTok. I'm getting there, but I'm not all the way there. I mean, I'm in my 5th decade. And so we trained in a very different way. doing research in the standard way, and there's a process and sort of a culture that we are so, it's so ingrained in us to think, wow, we really need to change the way we try to meet people and communicate with them. And it may feel a little silly. I'm still trying to get comfortable making these Instagram reels, but guess what? This is where people are getting their health information, and they're using their phones to get health information.
And they're acting on it. They're making life or death decisions based on what they see. So it's not just TikTok.
So JPEG, I want to riff off what Lisa just said, and that is this idea. Like similarly, I was trained, and in a fashion where we value, publications in journals. We value textbooks, information, and we reward in academics and other forms of health careers, reward people who advance information in that aspect. And then we frown on the way regular people get information. And I think that's where I say that Lisa is on the cutting edge of I think it's going to change. I think all that's going to change. We have to start rewarding for how many people are listening and are you engaging? Not just how many people hear what you're saying, how many people are you engaging? And so, I often say publications and p-values and impact factor is nice. What's more important is who's listening. And that's really the crux of kind of how we evolve. And part of this whole discussion is like what's needed to happen next. And what I think is we need deans of education like Lisa that understand, educate the next generation, the current generation of healthcare providers around the importance of community-based communication, the importance of health information. And again, it's not to say that is a singular factor. We really have to have a concerted effort at scale around misinformation. And a lot of stuff that you see in the Surgeon General's report about a whole society approach, et cetera. All of those things I think are important. But along those lines, we have to evolve being in people's lives with information and rewarding those as a currency almost more than we do scientific publications that sit on shelves and nobody ever reads them.
Amen.
Very well said. I mean, even as, teams like ours, we're communicators at heart, right? When we go to meetings like ASCO, the big cancer medical meeting, or AHA, or ACC, it used to be the doctors that were on the podium doing the plenary. They were the thought leaders, and they're still important. They're still driving important research. But in terms of influence and relevance, it is people who, like experts like you all, who can meet people where they are already living their lives. People are not living their lives in Medium. Fun fact. They're living their lives on YouTube, right? And that's gonna, folks who can, and so that's my question then. Lisa, I'll turn it to you. Should health literacy or community-based kind of communication, modern communication approaches be taught in medical school or just school earlier?
Oh, absolutely. But I also think we can't really wait another generation or 5 or 10 years for this to take hold. This has to start happening now because people are dying because they get misinformation or they don't understand how to take care of themselves, little actions they can take. And so we should be teaching this upstream so that students across the allied health professions understand this. But those of us who are working in the health ecosystem right now, we've got to get on board. We have to start partnering. We have to find ways to collaborate to get that information that's so cherished in these manuscripts and these peer-reviewed journals. We have to get it translated in a way that people can believe in it, trust it, and use the information. And so that's where I think we're really falling down because this divide that Garth and I are talking about, sort of, I use the word elitism again. We have to move past that and recognize that the science is still important, but we have to partner researchers, scientists, healthcare providers, the language we're speaking, it has to be deconstructed and demystified so that people could actually use it and want to engage with it. Because some of the feedback I get is, I'm tired of your charts and graphs. I don't want to see any more graphs. And so you ask people where they're getting their health information. It's not from researchers who are showing graphs. It's from their grandmothers and their aunts and uncles and their, the sexy video on Instagram. So we have to get with the program.
It's so interesting. So, and Garth, go ahead, build on this. I know you got something to add.
This reminded me of something I saw the other day. So I have some very ill-behaved kids that are my own, that are 6, 4, and 2. And my 4-year-old was at the doctor and was just freaking out. And she got down and she started to talk to her and play with her first and engage her first. And then after that, I couldn't get that little girl to stop talking. The whole thing just changed. And it wasn't until that experience. Again, just kind of underscore this concept of engagement. But Lisa just said something about how we need to teach people that concept now. This is just another version of those ideas. These are versions of patient engagement, patient-centeredness, putting the patient at the center of the equation, as opposed to us as the healthcare delivery practitioner at the center and wanting to say things and deliver things the way they want to. And so, I think that, and a part of this conference, and I was watching some of the other things people have been talking about, is what are the bold ideas that we need to do next? And I would take I would put Lisa's work as a prime example of that, and others who do that kind of work, that, we need community-based education at scale now, and we need to teach that. And value that in clinical medicine and public health, because the downside of that, as Lisa said, can hurt people in a variety of different ways.
Amen.
And I think doing it at scale, the beauty of the smartphone is how we do it at scale.
Yeah.
But that's why it's so important to figure out where people are paying attention. What are they, when they wake up in the morning, where are they scrolling on their phone, and why aren't we in those spaces? See, the healthcare sector is often behind because we are so stuck with our own processes and our own culture. And so the sooner we can pivot to recognize that, a bit of this is marketing. Like, how does Nike sell shoes? How does Coke, get so many people to drink? Because those commercials, they touch you. Why can't we be more like that in our communication of health information?
Well, we have to be, because we're not selling sneakers. We're not selling soda. This is life or death health information. So if ever there was a time to step up, it's now. Right on the line right now and tuning in, you've got a lot of communicators from the biopharma industry. Okay, companies that are developing new treatments and COVID tests and vaccines that are saving lives. How can industry get involved? How can they make investments here? Or how should they think differently about the ways they communicate? Because we spend a lot of time counseling clients to kind of get with it and show up in more modern places and differently.
Wait,
I don't want to hear from me. I want to hear from you.
I'm going to go first because I was a setup to Lisa's answer. They need to work with more Grapevine Health and other related organizations. And it's not meant to oversell this point as I'm trying to articulate. But the truth is we have to understand people who understand people. And working with people who understand people. And we have to, again, think about how we do that at scale. And so, again, a big part of our work this past year has been how do we invest in efforts like these and allow them to not maintain, but develop in their own way. And it's just amazing it doesn't even matter what platform they're on, just amazing to watch it. So I wanted to set that up for Lisa, because I do think that, for organizations, especially come from a more formalized part of healthcare and are trying to think through how to reach people, I think there are people who are doing it. And, working with them is particularly important. But then that just sets up Lisa for her answer.
Garth and I have probably been on panels together, so he can anticipate what I'm going to say. So at the top of this conversation, you told us not to sugarcoat, which I tend not to do anyway, but I'm going to be just like really plain here. When it comes to the pharmaceutical industry in particular and biotech, there is a severe trust deficit that needs to be bridged. So the way information is communicated from these companies right now is far too sterile. It's not relatable. It's far too scientific. And it further exacerbates the distrust the community has, particularly in pharma. And so I'll just tell you a quick story here. A few years ago, I moved into an underserved neighborhood so that I could sort of be in the know. And I got to know one of my neighbors who had multiple health conditions. And every time I saw him, our conversation would veer toward his distrust of his doctors. Why? Because every time he went to the clinic, he would get a new medication. And he said, you know, those doctors and pharmaceutical companies, it's all just a game. They're just trying to make money. There's nothing wrong with me, but every time I leave there, they give me new medication. So amongst ourselves, we probably understand that he needs medications, but if it's not communicated to him, and if you look at the optics of how the community views what's happening in the health system, it's a business. So they don't see people reaching out to trying to go the extra mile to help them understand what's happening. What they see is I'm walking in for this symptom and I'm walking out with all of these prescriptions. Are you trying to poison me? Like, what are you doing? You're just trying to make money. And that's real talk. It's uncomfortable for us to listen to that, but we have to own that and figure out how we are better stewards of information and communicating that information in a way that people begin to trust us. So I think the first step for biopharma or biotech also is to first listen to the community and start to figure out how you bridge that trust gap. Because beyond that, we won't get people enrolled in clinical trials. We won't get people taking medications on the schedule that's prescribed. So adherence will continue to be an issue. We have to understand the root of these issues, but we do that by first listening and being humble enough to accept the information. So I'll stop there.
I think that's great. I mean, it's so true. And it's hard, listen, we're speaking truth right now. You can't communicate effectively if you're not listening first. You talk about listening ears. I've heard you talk a lot about that, and really kind of immersing yourself in someone else's perspective and this idea of being humble enough to know what you don't know, but really take action to understand so you can address those the skepticism, the distrust, and everything else. It sounds like there's more we can be doing in a very practical sense to address that. Companies, individuals, et cetera. And
I'd like to pose just a rhetorical question, though, to the pharmaceutical companies that are listening. There's a lot of discussion about how to diversify clinical trials. I mean, I've been involved in this kind of research. I've, done some focus groups on this, but this question is still looming large, despite this question being posed for 2 decades or more. And so if clinical trials are complex, not well understood among the community, and difficult to access, what are we doing to fix those problems? Those are the fundamental reasons we don't see diversity in clinical trials. So aside from the trust issue, is it accessible to people? Do they know about it? Do their providers know about it? Those are some basic things we can do so that we can stop having this conversation and ask this question. 10 years from now, we'll still be asking, how do we diversify clinical trials? Because we haven't done the work yet.
We haven't. And that kind of gets to a question about shared responsibility. None of these issues we're talking about can be solved by any one stakeholder group, right? It really takes all of us, I think about the biopharma industry. Well, they should be sharing the right information at the right time for folks so they can get involved in trials, because we know that that's critically important. But we can't just overly rely on digital tools to do that. We've got to meld the digital tools with the human, right? Working with translators, and the right voices that are trusted in the community to address some of these gaps and be real about those types of partnerships. I think you're hitting on something that's critical.
Well, and JPAC, one of the things that was unique about what mobilization around COVID is so many folks started to see themselves as part of the solution like never before. So I think we there are opportunities. The challenge is as many times whenever an urgent situation no longer becomes urgent, people fall back to what they were doing before. But I do think now is the time to think about what we do next. Listen, the public has never been more interested in science than they are now. And the question is, how do we make it understandable and relatable? And I honestly think we're at a cusp in terms of health education and bi-directional, how we educate ourselves as healthcare providers, but also how we educate the community and how we bring those two together. And I think the question and in panel discussions like this and others is, how do we genuinely move forward? Because as Lisa said, a lot of these challenges for those of us who work in this field have been repetitive. We've gone to the same meetings, had the same discussions, seen the same people, and be like, weren't you here 10 years ago? We were talking about, these set of problems. And I think the question is, what are at least the incremental solutions so that we somehow get out of the repetition or repetitive nature of how we've been addressing the challenges so far.
Well, if that's not a good metric, the fact that you should not be saying that, a year from now, 2 years from now, that you're seeing the same people, it's like Groundhog Day. We can't accept that, right? Listen, I've been told that we've got a few minutes left. It went so fast. So maybe what I'll end on, and this was a tremendous discussion, and there's so many other questions I have, but what are, in your opinions, the one or two actions, they can be big, they can be small, that you'd like to see us take from our audience right now to address some of these issues we've talked about? In fact, just give me one thing you want to see, one action. Garth, I'll give it to you, and then Lisa, you can close us out.
Put ourselves in the shoes of the people that are either receiving the information or receiving the service, or who we're trying to reach, and understand their lives first, as opposed to trying to understand our own structures of delivering information first.
And I would say just challenge your assumptions about what you know, because a lot of times we approach these problems because we've been working in the field for a long time. We think we understand what it takes to solve the problem, and maybe we don't. So I agree very much with what Garth is saying. We have to be willing to humble ourselves, listen, and incorporate the feedback we're getting from the public.
That's great. Yeah, if there's one word I'm taking away from this, it's listen, and really be open-minded and acting, and be humble. So thank you, Lisa and Garth. I can't thank both of you enough on behalf of our audience for your candor today, for the important work you're doing in your organizations. Lisa, it sounds like you're going to be a star. So if you need a publicist, I can help you. It's fine.
It was like Garth said it first.
We'll check back in this time next year to talk about that. But in all seriousness, thank you. Thank you for helping us understand these issues. They're not easy. We need to get real about, how we approach them and how we actually do something together that's going to move the needle, not be more of the same. Mary, I see you're here. Why don't you close us out?
Yes, I am here. They had to remind me to get back on because I've been taking just furious notes. This has been super amazing. I love this session. It is so real when you think about the fact that we have got to get out of our own selves if we can. And when I say ourselves, I don't mean just us physically, but out of our own walls, out of our own mindsets, meet people where they are. I loved the comments about how it's information that really is what is making the difference. I love the comment about the smartphone and how there's so much more that we can do there. And are we thinking about what do people look at when they first wake up in the morning? What are they going to? They're not reading scientific journals and doing all these things. They're
Maybe Garth is. He's not.
Right. They're not even reading, their prescription bottles or whatever stuff we think that they are doing. It's not happening. So there's so much more when we understand about the potential value of the digital determinants, about the fact that disinformation is literally killing people. And so even though, there is some humor in how we talk about it, understanding where people really go for their information and, talking to folks in ways that they can relate to each other. Who knew that Dr. Fauci liked Tupac? I like
I didn't know.
Right. But making people human like that just makes...
It's not rocket science, it's connections, as my 5-year-old would say. Connection, it's a human relationship connection, and if we can ground ourselves there, we're already 2 steps ahead, but anyway.
Exactly. So thank you, JPAC. Thank you, Lisa. Thank you, Garth. This has been an amazing session. And thank you, everyone, for attending. I know we didn't get a chance to get to questions, but we will follow up. So please tune in to the next session starting soon we're keeping it going, keeping the conversation, the dialogue, and the solutions and the ideas going forward. Our next session is Getting Rooted. It's about structural racism in medicine and the role providers play in addressing it. So that's where we're going to pick up next. Again, thank you so much to our panelists, to Dave Pags, our host, and we'll be back shortly.
Thank you.
Hi, everyone, and welcome back again to the Real Health Equity Summit if you've been with us for a good portion of the day, and welcome to those who are just joining. We are really excited, as we have been all day. The energy has just been great around these conversations, but we're really excited about our next session, which is called Getting Rooted: Structural Racism in Medicine and the Role Providers Play in Addressing It. I'm personally not sure if we could fit any more words into that title, but you get the point and you understand that it's an incredibly important intersectional dialogue for us to have. Before we get started, a few housekeeping items. Just a reminder again, we will be sharing the recording from today's session with all event registrants following the event. We will be taking questions if time permits, so please feel free to submit your questions via the chat on the right-hand side of your screen on YouTube Live. And also, the conversation isn't just happening here, it's happening across social platforms. So we invite you to contribute to the discussions using the hashtag RealChemRHE. I'm actually moderating this conversation today, and I'd like to introduce you to my fellow esteemed panelists, Dr. Megan Mahoney, who is the Chief of Staff at Stanford Healthcare and Clinical Professor in the Department of Medicine at Stanford University. Dr. Gigi El-Bayoumi is the Founding Director of the Rodham Institute at George Washington University School of Medicine and Health Scientists. And then we also have Reverend William Lamar, who is the pastor of Metropolitan African Methodist Episcopal Church in Washington, D.C. Though the impact of medical racism and structural racism stretches far beyond Black Americans, it's really important that we ground this discussion in the theme of the Real Health Equity Summit, which is about changing out loud and in some ways addressing the elephants in the room, right, for us to drive change. And I'm sure that we are all more than familiar with Harriet Washington's research in her book, Medical Apartheid. It vividly contextualizes the deeply rooted, justifiable distrust in systems that intentionally and historically excluded those whose humanity was invalidated by the same systems which were not originally meant to help and heal them, us, in the first place. But toward the very end of the book, Washington writes that today, much medical research is more than safe for African Americans. It's necessary. And her point was that the fear and distrust that is the direct outcome of Black bodies only having labored utility were more than valid, and they continue to be more than valid, right? And that we must acknowledge the past in order to regain trust and to seize the future. So that's where I'd like to start our conversation today. So my first question is not going to be about trust, it's going to be about trustworthiness. So to improve trustworthiness in and the relevance of our collective efforts to advance health equity, when it comes to the role of providers, what does it look like to change out loud? I will ask Dr. Mahoney to get us started.
Well, thank you, Jewel, and thank you all for joining today. I'm looking forward to the interaction. We have a wonderful panel here. It's an incredible privilege to be a part of this esteemed panel. So I do appreciate the quotes from Medical Apartheid. That was a difficult book for me to read, to acknowledge that I have been part of an institution that has this legacy and this history. And I'm excited at the same time to start defining a new future for all of us collectively. And it really does start with reflecting on our past and looking at ways in which we are accountable and need to build that trustworthiness. It really is the most essential part of what we can do in medicine. So what I would like to share is that I'm seeing that I'm not alone, that there are a number of us in the medical field that are very eager and hungry for this change, for real structural changes to happen. And it's not only because we know it's the right thing to do, we also are responding to our patients. And the COVID pandemic in particular has affected our patients' ability to trust the care that they're accessing. In a recent survey by West Health and a Gallup poll, I was looking at the percentage of Americans who do not feel comfortable accessing care, they don't feel like they're getting the value they need. Over half of the Americans feel some level of discomfort with the care that they're receiving. And that's a problem. We need to change that. And I'm eager to jump into a conversation about structural changes that need to take place to respond to our increasingly diverse patient population. So thank you for having me.
Great. Dr. Gigi, I see that there's something on your mind. I can just tell you're eager to jump in.
Well, thank you. There's always something on my mind. So thank you, Ms. Jewel, and good afternoon, everybody. I think that it's important to not just talk about historical, but ongoing racism, classism, and sexism. Of course, the country and how actually universities were established, especially Ivy Leagues, universities were actually on the backs of Black people. And if you want to read just an excellent book, well, there are so many, but I just slipped my mind. But one of the books is If They Were Her Property out of Berkeley, actually, California. I'll get the books and share them in a second. But I want to talk about sort of my frustration with the latest DEI, microaggressions, health equity. It's really talking around the margins and not really looking at the specific issues. We have a crisis. The fact that we have worse outcomes right now in COVID and continue to see more Black and Brown and Indigenous peoples dying from COVID, and same with the children, that's a crisis right now. We cannot afford to do in-depth studies because there's a lot of studies that are out there. The time for action is now. So what does that look like? First of all, let's admit that there is a very strong class two-tiered system within our institutions. The way that mostly Black people who run the hospital, be they the staff, be they the people that bring the food, be they people that stock the shelves, whatever it is, that are crucial to running our healthcare system, which actually comprises about 80% of the workforce, get treated in a horrible manner. I can tell you that 1 in 5 of the medical assistants that I work alongside with, and please visit the Rodham Institute website so you can see the studies that we've done or commissioned, 1 in 5 are getting government assistance. 1 in 5. I have a woman that I work right alongside with who works at McDonald's to make ends meet. That is pathetic. If we really care about providing good care and equitable care, we need to hold up a mirror to ourselves. There are colleagues, faculty that I like that never acknowledge the people that we work with. If that's not racism, classism, et cetera, I don't know what is. Furthermore, I can tell you that especially there are Black women that can run the institution where I work, and yet the people who keep getting promoted may have some letters behind their names, but are, I'm sorry, incompetent oftentimes. And so what equity looks like is really being consistent at every single level. And of course, when you do that, everything is going to be reflected. That approach will be reflected in patient care. I got more to say, but I'll stop.
So, Pastor Lamar, I certainly see that there's something on your mind. And I'll just say, as someone who doesn't just experience the healthcare system as a patient and as an individual, you spend a lot of time, right, going in and out of, out of the hospital system as you accompany your congregants, the work that you all do from a community-driven perspective, a justice and community-driven perspective that's focused on equity, justice, and liberation. So really kind of curious to hear your perspective on this issue and this topic of that we have today.
So I want to begin with a theological framing, and that is, in my opinion, in our tradition, the Creator made us and made all that human beings might share abundance and we might flourish together. So health, physical health, communal health is is you cannot separate that from shared abundance and human thriving. So I like this language of rootedness, and I think we must remind ourselves or learn for the first time that the structural racism that we see, racism in America, cannot be intertwined. It cannot be distinguished from, rather, capitalism. Capitalism, structural racism, white supremacy, anti-Blackness are tied together. From the 50,000-foot view, because I know that there are people watching who are venture capitalists who are trying to figure out how we do a better job of this. I, as a pastor, I want to encourage us. We must take the capitalist logic out of the healthcare system. Be profit driven. We have to have new ways of considering economics and investments, because what I see from my parishioners and people in the community, you cannot access health without money. So Dr. Gigi just shared the difference in the life expectancy between people who live in Georgetown and people who live in Ward 8. The people in Ward 8 are no less human, but they do not have access to the wealth. And they don't have access to the wealth because of structures and systems. And if we do not use our imaginations and creativity to discover new ways to share health and new ways to share scientific advancement with all human beings. You know, if you look at what the pandemic teaches us, it teaches us that viruses don't care, right? They don't care who you are or what you have. And if you have a group of people who are suffering, who are poor, who don't have access to the best medical care, then their lack of health affects all of us. And so the connectedness must be lifted up. And I really want to encourage us. We don't do work around health, be it physical or spiritual health, with a profit motive. We have a vision of community, a vision of human flourishing. And I believe that the people listening today resonate with what we're saying, and we can imagine something new. Something new is possible. What we're doing definitely isn't working.
So to that point, what or who is missing from the current discussion about, the role that providers play in addressing structural racism, social determinants of health, and all the other issues that create the inequities and injustices? And, what has become too much of a focus or a distraction in the conversation about this?
I can tell you that, we have the Anti-Racism Coalition at GW, and a lot of the discussion is about microaggressions that are focused on medical students and faculty. As somebody who's faced micro and macroaggressions, that's an important issue, but we're not getting down to the issues that I had alluded to before. So people that are not at the table are the, non-MD, especially non-nursing. People that are not at the table are our patients or our communities. So there are key, stakeholders that are not there. And the people that are the closest to the problem drive and understand the solutions, but may not have the resources. So the way that I look at us, as especially in academic medicine, we are consultants. We really serve at the pleasure of the community. They know best. And we are here to help facilitate, accelerate, and catalyze.
Yeah, I just wanted to build off of that comment that we really do need to break down some silos. And as a provider, as someone who's been in academic medicine my whole career, I can't say enough about getting outside of the ivory towers to learn about where health and illness really is impacted. It's not within the hospitals or the clinic walls. It's happening out in the community. And I'll just share a couple of examples. I served as a provider in the California state prisons. California has the unwelcome record of having the largest prison system in the country and the largest women's prison system in the world, and that's where I worked. And I worked in solitary confinement with a transgender woman, and she was only able to go out into daylight, 1 hour a day. And seeing her experience as a transgender woman in this large women's facility was eye-opening for me as a provider. I was able to see where health was really happening, how incarceration and recidivism and, our prison and industrial complex is affecting society in a way that I could read about in a textbook and I could go to a medical school class about it, but to go and see it in real life, or even, getting outside of our country, going to, I spent 2 years in Nairobi, Kenya. And I have to say that, Reverend Lamar, the comment you had about how do we partner with the community in an innovative way, I learned how they were doing it. It wasn't a profit motive at all. It was about, I wasn't able to even engage with the community until I went to the chiefs, the village chiefs, and I engaged with church leaders. And so bringing some of these things that we know are effective in other places, bringing them back, community health workers being a great example, so that we can have real experiences and understand what the we call it social determinants of health, what those are, and bring them into medicine so we can really practice real medicine and really provide real health and real health care. So those are my perspectives.
I just remember the name of the book. It's called Ebony and Ivy is the name of the book.
Yeah.
Okay.
It's a great book, Dr. G. It's a great book. No, not at all. So what I was going to say, not only must we envision a new way of conceiving our work economically, but I think that we are entirely too self-congratulatory. So you go to a couple of DEI classes and you take some microaggression stuff and you shake hands with somebody who's of a different color and you got the picture. There's a deeper reality. Let me tell you what I have experienced as a pastor and someone moving about in the community. As Dr. Gigi has said, normally what you have in the room are people who think they are called to make decisions for others. But the people who are not in the room carry the wisdom. And so here's the issue, though. I've been in rooms where we bring those persons in, the excluded, but they are not treated well. Their stories are not valued because the leaders in the room do not value their humanity. They see these people as problems. So I go back to Du Bois and his Souls of Black Folk, where he said he's reading and someone's asking him, how does it feel to be a problem? Well, he's not the problem. The structures were created to extract from him and not to allow him to flourish with the gifts that he brings. So what I would say to many of us, we've got to learn how to listen to the wisdom and the knowledge that these persons have, though they may not have a certain educational attainment, their wisdom and ability to navigate the very cruel economic reality that is the early 21st century American empire is tough, and they navigate it. They find ways to survive. And if their wisdom and knowledge leavens the loaf of what it is that practitioners and researchers and leaders are doing, their voices are missing, and that costs us as far as the health of the community. So how can we have different kinds of conversations, building real relationships across the divides? That also will help as we envision new structures and new possibilities.
And if I could just add, even from an economic standpoint, we have the most expensive system in the world, and yet we're number 37th. One of the reasons that the big three, and I'm from Michigan, automakers failed is when you look at Japanese, car manufacturers at the time of 2008, they spent about $400 per car on health insurance for the workers. We were spending $1,400. So even if you're looking at it from an economic standpoint, it doesn't make sense. But I want to add something to you because I don't want this to come off as me judging. Okay, we are the enemy. We have seen the enemy. The enemy is us. So for 20 years, I was in charge of educating medical students and residents. And I always tried to kind of forestall or mitigate the jading process that I would see, where at the very end of their training, they would objectify the very people on whose backs they've trained. And this is what I've come up with. I said, we are teaching racism, classism, and sexism. Let me give you an example. If you have two women, both with pneumonia. One is a college professor. Another one is homeless. She's HIV positive. She's in the middle of a psychotic break with her schizophrenia. Who is easier to take care of? Of course, the college professor. We speak the same language. If I tell her, professor, you need to refrigerate the antibiotics, you need to take them with food, and if there's a problem, call us back. And if she can't get in through the phone system, which is dysfunctional where I work, she can call her friend and say, you know somebody at the medical school, how do I do that? The other lady, first of all, we can't understand her. She's disorganized. When we are trying to give care to her, look what we do to our learners in terms of putting them in bad situations. It's below zero, with the wind chill, it's 0 degrees outside. There is only one shelter that takes people who have any medical problems. The administration says, you got to discharge, you got to discharge. You're going to discharge them to the street. What is that doing in terms of the morals and the ethics of that person? Furthermore, in the hospital, because I work both in the hospital and the clinic, there aren't those systems that really can help support that lady, right? So everything gets put to the intern or the medical student. But here's a solution to combat that. We need to know where people live. We actually have a program called See the City You Serve. We need to see people when they're not sick. I mean, I don't know about you. When you've been sick, I can tell you my hair is all screwed up. I look awful. That's not how I want to present myself. I'd rather present myself in a more sort of equal footing. So there are things that we can do. And there are systems, as Dr. Megan has pointed out, I'm also of African origin, that have worked and are much better than us. And humility, I think, to your point, Reverend, is so important for all of us.
Dr. Gigi, can I build on the point that you just made about how we show up, especially in community, in the comfort of our own homes, and in healthcare systems and spaces? You know, as you guys were just talking, it brought me back to a thought about my great grandmother who passed away when she was 92 years old. So I spent a lovely, few years getting to know her and spend part of my life with her. And I will never forget, one of the clearest memories for me is how my great grandmother, who was born in the early 1900s, how she dressed when she went to the doctor's office. Mm. She got dressed to go to the doctor's office, and I didn't have the words for it then, but now I do. And I know that it was about respect, humanity, and dignity, right? She, some of us might call a portion of that Black respectability, but what she was doing was she wanted to make sure that this woman born in 1902 in Virginia, right? In Virginia, she wanted to make sure that when she went into healthcare spaces, she was seen as neat and well poised and well put together, and so that they would see her as human. I can't help but to wonder, based on what you've just said, and the fact that all of us have biases, right? If we could only focus on 2 or 3 things about the role providers play in addressing structural racism, what do you think would be most impactful in 5 or 10 years? Because at the end of the day, I've adopted some of those same habits, right, that I saw. And I do the same thing with my kids and my family. But I would love the freedom to not to feel like I needed to walk into a doctor's appointment or into the healthcare system looking as I do when I go to work, right? And there's a privilege in that. So, what would you say are the 2 or 3 things that we could do to improve the role of providers in addressing issues related to structural racism that would have an impact in 5 or 10 years?
Okay, I'll get started. Jewel, thank you so much for sharing that story about your great-grandmother. She reminds me of one of my favorite, the description reminds me of one of my favorite patients who's actually from the Midwest, but she moved out recently to be with her daughter. She's a little bit younger, so she's 86 now, and we'll call her Ruby. I'll just use that name. But when I first met her, she did talk about some of her previous healthcare experiences and how she felt like the physicians were talking down to her. They weren't listening to her. She was just really polished. The way she dressed was very, the way she came across. She really wanted to convey respect and dignity, and yet her experience was not living up to what she was bringing to the table. And so I was happy to be able to work with her. And one of the things that we were focusing on was hypertension. We were interested in measuring her hypertension outside of the walls of the clinic and engage her in the digital health revolution. An 86-year-old African-American woman, we hear about the digital divide and, it turns out she was able to engage. She was like our favorite patient as far as that's concerned, so engaged, entering her data. It did take a little while. She and I work with a medical assistant, work with a health coach, and then also with her daughter. But she was able to get on the technology and do it. So I think that when you're asking about 2 things that I would focus on, I would want to ensure that we're doing our part. She's showing up. How are we showing up? Are we doing our part to overcome any digital engagement issues that could be there? Are we showing up as far as our bias? Are we really addressing that in our healthcare system? Are we eliminating the ways in which racism persists in the way that we're practicing medicine? One I've talked a lot about previously being the use of race in our calculators that we use to determine who should be on blood pressure cholesterol lowering medication, and then and kidney disease function calculations. Really eliminate. We are there to show up for our side of it as well. And then the second structural change that I would say is really important is to address the rising cost of care. I know that we have all been talking about this, but increasingly this is affecting communities of color, and people are more and more reluctant about accessing care because of the cost and the risk that they face of receiving a bill that could be devastating. And we're seeing that more and more because of the pandemic. And so that's something that we'll need to face going forward.
I think that providers live frenetic lives, and probably to hear people like us saying, need to do one more thing is probably like, oh my God. But part of what I want to encourage keep the imagination alive that the system that we have, and to use the words of Ron Heifetz, is not broken. It was designed this way.
Exactly.
And is profiting and growing powerful off of a system that is producing this inequality and really dealing death according to race and income/class. So you have to imagine the new reality economically and the new outcomes and move into that creatively. I think number 2, in the healing tradition, I see you all as healers. The healer lived amidst the people in the community. We have to find ways that those still practicing the healing arts are in the midst of community, how you build relationships and learn, where you subvert the reality that you are always teacher and never student, but you assume the posture of student and learner. And I think finally, there are so many ways for you to use your voice and to speak up, because we know the majority of Americans want a universal health care, right? But the way that our system is set up, with the way that the Senate is designed, which is radically undemocratic, where a state like California has 2 senators and a state like South Dakota has 2 senators, right? So the people are not being represented as they ought. So engaging in that way with the political realities that can get us closer to shared flourishing and human abundance.
So I would like to remind everybody that what we do as clinicians or the healthcare system only accounts for 20% of all outcomes, right? We've alluded to social determinants of health and structural determinants of health. I will just tell you that of all the factors that impact mental health, food is before even housing. So I think, first of all, educating ourselves of why it is that the economic health of a neighborhood is important. You know, before backstage, before we came on, I talked about in DC, people who live in Georgetown, they have a 94-year life expectancy on average. People who live in Ward 8, it's 66 and a half years. If I, as a physician, all I did was to get kids to graduate from high school, I would add 10 years of life. Right now, there's only 42% of kids that graduate from Ward 8 in high school. But what I would say is this. People talk about cultural competency as though we need to learn every little, culture and subculture of all the peoples in the world. No, we lead by being human. When I used to orient the residents, I would say, pretend that this is your mother, father, sister, brother, aunt, uncle, or grandparent. Be human. And guess what? Pastor, you talked about the frenetic lives. When you behave that way, that actually immunizes you against burnout. Us. So this sort of directional learning is not just for the benefit of the people we serve. It's actually, I always say, I get more. So that's one. Be consistent in your behavior is number 2. It's important that we know the names of the people that we see every day. It's important that we know that, oh my goodness, so-and-so's child is struggling with cutting themselves. Okay. Or, so-and-so's grandmother has died. So I couldn't agree more about the profit motive and how we really have to, there's so many ways that we as clinicians can make our voices heard. But what we also don't want to do is we don't want to re-traumatize people that come from communities, whatever those communities are, right? Because we tend to forget about minorities within minorities, like disabled people who live in Anacostia, or blind or deaf people or shut-ins. So that when a woman who's overweight, and I'll give you a specific example, one of the residents comes in and says, I have a lady, African-American woman, I lectured her for half an hour about why she needs to lose weight. I said, but it says here that she's coming here because she may have had a mini stroke in the emergency department. I walk into the room and the lady is just sitting like this. And of course, I said, tell me what happened. So these ideas that, that we know better, the point that Dr. Megan made about listening, just listen. And believe it or not, although I'm a talker, I do listen. But I think it's important that we examine what we do on an everyday basis, every day with everybody that we interact with, and that everybody has value and is important.
Great. Well, I know we only have a few minutes left, so I would love to do a very quick lightning round to hear from everyone. Just one last question. What does success look like to you when it comes to ensuring that providers are leveraging their seat to improve health outcomes for all? And I know that we have Dr. Aletha Maybank, the Chief Health Equity Officer for the American Medical Association, joining us tomorrow. And they're doing a lot of great work, but would love to hear from each of you. What does success look like? If Pastor Lamar, if we were to reimagine, right? What does that look like very clearly and very tangibly as a last thought for those who are joining us for today's conversation?
I think systemically, it looks like universal health care. All of us share an excellent standard of healthcare, no matter what our zip code. And I think it also means that we have to build human connections and relationships to tear down the stories we tell ourselves. So Dr. Gigi, whomever you were speaking with, when they saw that obese woman, they were telling themselves a story about her, which victimized her, made her a person who makes poor decisions, who's morally bankrupt. And absolutely none of that may be true. And so we've got to retrain the stories that we tell ourselves and provide everyone excellent care.
Great. Dr. Mahoney?
I think in the next 10 years, if we could produce a generation of healthcare professionals out of our medical schools and other professional educational schools, a generation of healers who are oriented towards promoting health, who have effective communication skills and listen and orient the plan around the patient's and community's goals, that would be success for me.
Great. Dr. Gigi?
And for me, it's also about outcomes, that the gap that is in Washington, D.C. gets closed. But from the moment a human being comes to whatever healthcare system we're talking about, that there is a smile, that they're being treated with dignity, and more important, when they're leaving with a smile and feel like they've been listened to. And so, and everybody else that's working in the system. But that's what I would say.
Great. On that note, thank you, Dr. Gigi, Reverend Lamar, and Dr. Megan Mahoney for this important conversation. Thank you to everyone who attended. Please do tune in for the next session starting soon on future-proofing health through inclusive innovation. And we'll be back in about 10 minutes.
Please visit the Rodham
Hi, everyone, and welcome back to Real Health Equity, the Real Health Equity Summit. We are having an amazing time, such great discussion and dialogue and talk about real solutions. And right now we are going to be joining another amazing session. This one is about future-proofing health through inclusive innovation. So I've been really looking forward to this conversation because, as we know, with all of the major advances in healthcare and across the health ecosystem, we still haven't moved the needle in a meaningful way on improving health equity. And we understand that's going to take lots of innovation. And that's what this great panel is going to talk about and share some solutions and their own future-proofing visions. So just before we get started, though, I have a couple of housekeeping items. We will be sharing the recording from today's session with all of the event registrants. Following the event, we'll also be taking questions if time permits. So please feel free to submit your questions via the chat box on the right-hand side of your screen on the YouTube Live, and then also join the conversation via your social channels by using the hashtag RealChem, RealChemRhe, so that we keep this conversation and dialogue going. With that, allow me to introduce to you our moderator, Dr. Reed Tuckson. He is the co-founder of the Black Coalition Against COVID. He is also previously the Executive Vice President and Chief of Medical Affairs for United Health Group, a Fortune 20 health and well-being company. That's where I met Reed during my tenure there. Reed is also the Managing Director of Tuckson Health Connections, LLC, a vehicle to advance initiatives that support optimal health and well-being through a variety of intersectionalities. So we know that he is really going to pull everything he can out of this panel to give you some amazing information about solutions to future-proof health through inclusive innovation. So with that, Dr. Tuckson, I will turn it over to you to introduce your esteemed panelists and get us started.
Well, thank you so very much. It's a great honor to be with you. And I want to welcome everyone to this Future-Proofing Health Through Inclusive Innovation. As we know, at their best, when intelligently and appropriately engaged, health innovations that are coupled with the enabling power of technology can really create much greater optimal health and, if used intelligently, a sustainable pathway for health and medical care delivery. Unfortunately, as we are painfully aware, our nation, with its aspirations as a civilized and democratic society, has a long way to go towards providing and ensuring that all of its inhabitants have the best possible opportunity to live maximally healthy lives and live in maximally healthy communities. For a number of reasons, achieving equity in health status and outcomes is by far one of the most challenging issues facing society today. And as we understand, one that will occupy much more attention this year than in the past. But let us be very clear. We have a huge gap to close between our aspirations and our realities. New voices and new reality-based conversations and solutions are needed that move us beyond rhetoric, beyond aspirations, to lead us to real, implementable, and sustainable solutions. And that's why we're here today. So let's get us started. And we're very, very pleased that Ryan Brown is here with us today to start us out and make sure that we have the opportunity to understand and listen to the experience of the head of global diversity and clinical trials for Science 37, a company that seeks to expand access for patients and providers anywhere through agile clinical trials. Leading diversity in clinical research across Science 37's global business relates directly to the company's mission of improving diverse representation in clinical trials. Throughout your career, you have had a great experience in driving diversity across academia, grassroots community organizations, clinical industry task forces, and collaborating with patient advocacy organizations. So based on this, let's start out with what or who is missing as you look at the current discussion about future-proofing health through inclusive innovation?
Dr. Reed, thank you so much for that warm introduction, and huge kudos to the Real Chemistry team for putting together this timely summit. I gave this a long, hard think as far as who's actually missing. And, when I think about where decisions are made, it's representation behind the closed doors. It's representation at who decides and who greenlights what is funded, what regulations are put forth. And so when we look at things such as, and it's JP Morgan, right? So we have to look at the venture capitalists. And I know that NVCA and Deloitte did a recent study and survey, if you will, and they saw that there is just a really big lack of diversity within their membership. And we're looking at organizations that manage over $256 billion in assets. And the venture capital firms are responsible for roughly $30 billion in new investments in life sci. And so if we're looking at organizations where, we're talking small groups, typically six plus kind of companies. But when you look at the great majority of who's in charge of funding, the large majority of the workforce is over 70% white. And so when we talk about health equity, we have to look at the venture capital firms. We also have to look at our regulators, and there's no blame here. It's just looking at historically where we've come from, and the voting members of Congress, right, over the 500 that are there, roughly 77% are white. And if we look at what's going on with our census, the large majority of the nation, for example, in the US is 60% white. So all of this kind of suggests that, the majority voices have rightly been represented in all the right spaces and places. However, as we're looking to build in equity, we need to ensure that we start to shift some of the representation around, so that way those that are coming and growing from minority communities, which are largely starting to become more majority, have real representation, have voices in the spaces that need it most. So that way, the green lighting from funding of projects to ensuring that we've got diverse representation with our providers, all of that translates down into really reaching the patients that we wish to seek and treat. So in my humble opinion, it's those are some key areas in where, frankly, folks that look like me are missing. And we need to do something about that.
Let me follow up on that a little bit. That's a really, really fascinating perspective. And when you think about the role of venture capital, and you think about all of the organizations, the startup companies that are trying to get out of the box with whatever particular unique product they may have, how much do you sort of see the conversation with the capital markets as being a social-based responsibility, a moral-based responsibility, or at the end of the day, can this be couched simply as return on investment enhancement?
So I think that's a fantastic question. And one of the things that we're really looking at here is, quite frankly, biology. And what we're looking at is survival. And there was a really great article recently written equating biology to business. And so if we look at, genetic diversity, for example, if you don't have it, species, they become extinct. And similarly in business, we are talking about survival here. It is no longer a moral nice to have. But if you look at companies that were on the Fortune 500 in 1955, for example, only 52 of them still exist on the Fortune 500. So several of them are extinct. So if individuals are reticent to embrace change and to embrace innovation and think of diversity as a nice fluffy topic that they took with their HR Kumbaya retreat, what we're talking about here is an ability to make a meaningful impact on your bottom line. And if you look at the Deloitte study, those that actually embraced having more diversity, both ethnically, gender, and otherwise, actually financially outperformed those that didn't by over 30%. And there's plenty of other research that alludes to the fact that at the bottom line, for good business, for sustained innovation, for organizations to remain viable and to not be extinct, this is definitely equity as a way to help shore up your financial future, the sustainability of what we're talking about, not just for business, but if we're looking at the human race, we're looking at survival of organizations to drive and embrace innovation and to really be change agents. And in order to do so, embracing diversity, just taking a simple look at biology and applying those same principles to business is truly a great path forward. I get real passionate to read.
Thank you so much. We're going to keep coming back to that theme, I think, and this is a really, really great way to start us out. I'm happy now that Ariel Katz is with us. Ariel, you are the CEO and co-founder of H1, which, as I understand it, is a centralized source of truth for healthcare professionals, a centralized network that you are building of real-time information that seeks to unlock key insights and opportunities for engagement. I love your mission statement, and I love what you are about every day. Based on your experience with the company, and you've had a very extensive past as well before you joined H1, what does success look like to you in this space?
And thank you for having me here. I'm really excited to be here and speak with you. And Mary, thanks for bringing and giving the spotlight. So H1, one of the most important things that we do is help clinical trials that are going on have diverse physicians and diverse patient populations get enrolled in those studies. We learned about this. I mean, this has been going on forever. We learned how big of a need it was about 2 years ago. Go to any life sciences website, every top 20 website, and they're going to say they value diversity and inclusion in their clinical trials. Ask them, what are you doing about it? And they're going to say, I don't know, I'm trying to figure it out. And they'll say that behind a closed door. It's really hard. It's hard. It's hard to recruit a single patient. It's hard to recruit a single physician, let alone ones from different backgrounds, different races, different genders, everything. And at H1, we spent a lot of time focused on how do we make sure that there's more inclusive medicine for the world that people trust and they know is built for them, because today it's not, and we all know it. And so our goal, we set this internally as our North Star. 50% of clinical trials in 5 years from now have diverse physicians and diverse patient populations enrolled in those studies. And we're far from that today, but we work every day and night to get there. And so that's what success looks like to me. And it's an ambitious goal, but it's needed for the world. I mean, we're experiencing it with the COVID vaccine and everything. And so that's what I think of it. That's what success looks like to me in a few years from now.
So let me take you further down that road in terms of the challenge. You mentioned the COVID vaccine, and if we have learned anything about this period in American history, it is the distrust that people of color have historically had, and for very good reason, with the elites of our society, the institutions of our society, and the medical care system in particular. It's this issue of trying to establish trust and trustworthiness has been a challenge. How do you think about that? And is this an irresolvable problem? And can one company do it by itself?
No, it requires all of us to move in the same motion. I love what Ryan's doing. Love what you're doing, Ryan. I love what you're doing as well. It's incredibly difficult. The way that we're trying to solve this is get people involved earlier, not when the vaccine is approved. It's too late. I wouldn't trust it. Get them involved with the study design. Who's not in the discussion? Patients from diverse backgrounds. It can be people of color, it can be males for breast cancer studies, it can be females for generally male conditions. It ranges across the spectrum. And there's a big issue with access to the right information. How do you find a physician that has diverse patients? That's a big challenge that life sciences companies face that we're trying to help them solve. Can one company do it? No. But we're seeing right now, I mean, there's a change. Two years ago, if you went to like any big top 20 pharma company's website, they didn't have anything about diversity and inclusion on the clinical trials. They spoke about it as a nice to have. Today, everyone has it. And so we're seeing the industry open up, and it requires all of us to move as quickly as possible. And we think we could do it by getting involved early, getting people involved earlier in the process, rather than when the vaccine's approved, it's too late. When a drug's approved, it's too late. It's too hard then.
Great. Thank you so much. I'm eager to turn to Maya Hartigan, the founder and CEO of May, a fascinating company. And I cannot think of a company that is at the right time, at the right place to deal with a critical issue. What May is involved with is a culturally competent digital health platform that connects Black expectant and new mothers with critical resources to drive positive pregnancy outcomes, providing pregnancy and postpartum support tailored to meet the needs of Black women is one of the key things that we need to do in our society, given really it makes you almost cry when you think about the disparities and gap in maternal outcomes and birth outcomes for Black women compared to others in our society. And so, Maya, I am so glad that there's someone like you who's decided to take this on. We talked already about this issue of trustworthiness, and I'm curious about how you see it and how do we advance this concern as we try to move forward to advance health equity?
Yeah. This is such an important conversation. So first, I'm just thrilled to be here. I think it all comes down to trustworthiness, right? To the conversation that we've been having as a group here. When we think about disengagement, there is a complexity of reasons why that disengagement occurs, right? And for many of us, for many people of color, that has been the result and the outcome of years and decades and repeated instances of marginalization and disrespect in our care, right? And I don't say that from the perspective of suggesting that doctors are bad or core care teams are bad. I say it from the perspective of wanting to reinforce this notion that consideration for the whole person is meaningful with every healthcare touch point, with every conversation. And the more that we, as people of color and underserved populations, don't feel it's there, the more we disengage and the more that is an understandable outcome, right? And so when we think about May as a platform, we're doing a couple of things. We are a digital health platform, but we also have an overlay of community-based support and a model of support that is meant to be culturally specific and meant to be built around this notion of establishing trust with peers, with people in your own community. We are building out, in addition to our digital health capability, a doula-supported model of care in maternal health care. I think this is an important thing for us to consider when we think about peer support relationships, is the need for connection, right? The need for connection with healthcare experts with whom you believe have shared some of your life experience and therefore with whom you believe can respect you holistically in your care. And that is missing. That is missing, right? Where Black Americans represent 14% of the population, but about 4% of physicians in the US. For those of us who want and seek a culturally representative care team, it can be very difficult for us to find, right? I think we have access issues that go much further than that, but I think the ability to actually find that culturally competent team and care model for many where we can acknowledge, right, that we will be respected, we will be fully seen and acknowledged for all of who we are, right, is something that is deeply missing. And so any opportunities I think that we can find to supplement, right, our core care teams with folks we trust, folks who may look like us or just respect our life experiences is something that I think is very necessary. And to the extent that legislative changes, supporting reimbursement for some of these new care models are supported and become permanent coming out of this pandemic, right? I think that will be to the good of all, right? Because that allows for us to find that trusted connection, that diversity in our care teams. And I think it's really necessary for many of us.
Maya, let me walk you further down the road, and this is all about real talk. So let me try to get real talk here. And this will sound like a very naive question, so I'm giving you a lot of room to run. It might come as no surprise, I'm an African-American physician. You can tell. I am a product of Howard University undergrad, but I did my medical training undergrad in medical school at Georgetown, and then I trained in internal medicine at the University of Pennsylvania. I met a lot of white colleagues who, and all the colleagues I met, seemed to be well-motivated people. They were humanistic people. They went into medicine for all the right reasons. I didn't experience real, abject racism and bigotry from my colleagues. Now, there were a lot of other people that I was concerned about, but not from the physicians. And what I'm trying to ask you in a sense of is help us in real talk to understand what is the concern that is expressed by your clients when they say, I really have a distrust problem. What are they feeling, and what is the consequences of that?
Yeah, look, I think it is. I think it's an implicit bias in our interactions with one another, and I think that is something that probably comes naturally to many of us, and it's probably something that we do subconsciously, right, with people who are different from us. And I'll acknowledge that I probably have done that myself, right? I can tell you, for example, when I had my first daughter, I have 3 young daughters. When I had my first daughter, I had been in healthcare for about 10 years. I had an OB say to me, "Do you eat vegetables?" I said, "Yes." She said, "Can you name a vegetable?" Right? And this is the sort of thing, it is well intended, but it is inappropriate, right? And what it suggests to me is that that care provider was making assumptions about me, about my level of intellect, about my degree of self-care, about the importance I was assigning, behind nutrition and the health of my new baby. It's inappropriate, right? And what it results in is a breakdown in trust, right, between us and our care providers. And I think going beyond this anecdotal example I share from my own pregnancy, there are so many examples, right? And I think well-established evidence at this point of Black women reporting pain that's unaddressed, Black women reporting symptoms that aren't addressed in a timely manner, those things being discounted to the detriment of our mothers, right? Women being sent home and hemorrhaging from home because they've expressed a concern about pain or bleeding that was not addressed by care providers. And I think that for many of us as Black mothers or Black expectant mothers, not only are we feeling this, but we're also reading it in the news, right? We're reading the experiences of so many other Black women who have been marginalized or ignored in their care, right? And we are therefore approaching this life experience from a place of extreme stress and worry, right? Where we have concerns about voicing those opinions, or we have concerns about feeling aggressive in asking questions. And ultimately, what we need to remember is that these are our bodies, these are our children, these are the most important things for us to take care of. We have to ask the questions, and we have to feel comfortable to say, if you are not adequately considering my well-being, I have to find someone else. And that too is a hard and scary thing to do, particularly at such a vulnerable point in our lives.
Based on my own experience, I don't think you could have picked a better example than the issue of pain, where my work at the University of Pennsylvania with sickle cell disease was an eye-opener for me, as Black folk had to beg and plead for the medication they needed to relieve their pain, and not have people bring other assumptions about the fact that these were just drug addicts trying to get a high. I think you really gave a very good example. Ryan, let me come back to you a little bit. And first of all, I asked you just to deal a little bit with this trustworthy issue. I didn't give you a chance to weigh in on that and how you all are dealing with the question of trust, in whether or not that is a barrier. But also, are there any other distractions that frustrate your work or that challenge your work to be able to move forward with an equity prism?
So that's a really great question. And, some of the distractions are the idea that, well, I've taken a class on this, isn't that enough? Or we talk about it, we have a work stream, we've written blog posts about it, we've done our part, and we've addressed it. Instead of doing the real work of, as Ariel was mentioning earlier, really getting into community, right? And partnering with providers that have those trusted spaces and places, and really bringing patients and those that look like and feel like the community, and making sure that they have a seat at all levels of the table, whether it's folks within the organization, but also at the most senior levels as well, having representation. From a trustworthy standpoint, I can't say it enough, and you hit on it too, and I think everyone on this panel, what we're really seeking here is the human connection point. Right. And if everyone can take a step back to realize that we have this shared human experience, if you will, and to just consider and remain curious and a little open, that you may not have all the answers of what is really going on with certain communities. Some of the distractions are, people say that they want diversity, and I can speak from experience. And yet when we look at inclusion exclusion criteria, for example, there was a sponsor that was extremely excited. Diversity is the new hot term. We want to do something about it. And yet when I looked at their inclusion criteria, they said, yeah, we really want to recruit more from the Hispanic and Latinx community. And I said, okay, that's fantastic. But if you look at the criteria, the main key criteria for the inclusion criteria was must be fluent in English. So you are totally abdicating, a whole different form of people. So what we're doing here at Science 37 to really build trust within community, first and foremost, we have established a center of excellence, and we've established an entire business unit dedicated to it, where we've tied meaningful targets linked to our bottom line to hold ourselves accountable from every level of the organization. And we have representation within every single department. We have a diversity and inclusion and clinical trial champion. So that way it is not a nice to have, it is not lost somewhere in the shuffle. And it's important because as we are reaching into community, making sure that we have a workforce that reflects the communities we wish to serve, making sure that we are collaborating with community health workers in combination with our technology, making sure that we are creating pathways for more physicians that look like yourself, Dr. Reed, and others, to where we're not leaving people behind in research, but instead of only going to the sources that we know at large academic institutions, really reaching to community physicians, reaching in Medicaid practices, and training them on good clinical practice and reaching across the aisle so that way we can have sustainable pathways to really reach the trusted sources that are connected to the patients we wish to serve.
Let me just ask you to give a brief response to something that Ariel said that really stuck with me, and that is engaging the patient early before the trials and engaging the community. What was your reaction when you heard Ariel's point?
I couldn't have screamed louder from the rooftops in all my work with various patient advocacy groups. I have a really good colleague of mine in the industry and very keen physician, Ivy trained, and he's like, Ryan, we got all this book learning, but at the end of the day, it sometimes comes down to common sense. And he said, we want to capture all these data and these endpoints, and he was working on a really rigorous study. And he said, we couldn't understand why weren't we getting any patients? So finally they had to scrap it, and they said, let's go talk to the caregivers. Let's go talk to the patients. And the patients and caregivers took one look at that schedule of assessments and said, there's no way I would do XYZ or this assessment and that assessment. If you could modify XYZ, and then sure enough, they made those adjustments to the protocol, they could start enrolling. So sometimes we got to take a step back and go reach into the communities and not assume that we know what's best for them, because we get caught up in the science. I'm a chemist by training. I love science. I get excited. But we're talking about real human beings. And so when Ariel said that, I was like, absolutely, from every single angle, we need to make sure that our communication, the cultural sensitive language that we're using, as Maya was mentioning, it's imperative. And it doesn't matter if providers are from the same race, but making sure that you can speak that language and you have the right heart and the right curiosity to create that connector.
So Ariel, partnering with physicians, what are the real talk, real life challenges of trying to work with clinicians and other health professionals to get them bought into this agenda and be a part of what you're trying to produce?
Yeah, it's a great question. And I'll say something funny, Ryan. We worked with a sponsor and they said, we want to recruit Hispanic patients. And we said, but none of the physicians that you have speak Spanish. Good luck. So they say these things, but then we had to show them, no, we have information on these doctors. None of them speak Spanish. You're not going to recruit anyone that only speaks Spanish. You're crazy. And so they all say it, but sometimes they need information to make that possible. In terms of partnering, it's very hard to get access to this information. And Maya said it's spot on. You want to see a provider. It's your health. What's more important than your health? Can't buy health. And you want to see someone that you feel like understands your life circumstances. I want to see a 30-something-year-old male doctor because I think they understand my body and my life better than other people do. And if you don't have a doctor that looks like you, that speaks the same language, you might not feel as comfortable. You might not want to get enrolled in a clinical trial. But it's really hard to get information, and it's really hard for sponsors to actually know the race of a physician, the language that they speak. And the partnerships that we're trying to strike with blockdoctors.org, for example, or National Black Nurses is to be open to partnering with pharma companies. They do want to do good at the end of the day. They do want to create more inclusive medicine, but one company can't do it. You asked that question to me earlier. You need the community, and the community is various societies, various organizations, sponsors and life sciences companies, data companies like us, technology platforms, to bring it together. Because without that, it's all sparse, broken up information. And you can't even, if you want to make it happen, it's very hard to find diverse physicians, very hard to find diverse patients. And so partnerships with societies is something that, and organizations, is something that's needed. Otherwise, I think it'll take a long time to get access to this.
Let me ask you a quick question, and then I'll get to Maya here. There are, as we are having this conversation, a significant number of white physicians who are frustrated with where society is today, who are upset with the angst and the tribalism and the ugliness and the meanness, and would like to find a way to be helpful and supportive, and maybe actually good candidates. How do you find, or can they be found, these altruistic people who are on the sidelines going, I love people, I care about people, I may be white, but I want to be in the game?
It's a great question. And we've asked the same question to ourselves. You saw change on the life sciences side as well as on the provider side. So you could go on Google now, like Mass General Diversity and Inclusion Center. Wasn't there 5 years ago. And not all the physicians are African-American or from minority races. I think the executive director is white. That person deeply cares about it. Great candidate to recruit diverse patients into a study. There are people that publish about it. There are people, like in scientific literature, there are people that are active on social media. And so there are other people, but that doesn't mean the patient's comfortable seeing them. And so although those physicians exist, I think what Maya said is spot on. Doesn't mean the patient's comfortable. And without that, short of out of luck. And so those people exist. We've been able to find some of them. It's becoming more public information, but I still question if patients will trust them. And without that, you're out of luck anyways. And what we've seen is the patient population mirrors the physician population in a clinical trial on all characteristics. And so I think we'll see how it plays out over the next few years. But my guess is I think physicians will mirror patients in all characteristics and demographics in clinical trials moving forward.
As I turn to Maya, let me just underscore something that you said. And for our audience, I want to make sure that they are aware of some of these assets that Ariel has talked about. The National Black Nurses Association, the leading digital health publisher in the Black community he mentioned, which is blackdoctor.org. These are extraordinary capable organizations. In addition, the 4 Black medical schools, Howard, Meharry, Morehouse, and Charles Drew, have formed a research consortium along with the National Medical Association. And so there's a very, very lot of firepower out there. So those of you who are in the audience need to know that there are some significant assets that are being put into play that are available to solve some of these problems. Maya, the issue of partnerships has come up a couple of times here, and I'm curious to see, in your mind, what partnerships do you believe in, and are they a part of your strategy for building out your company?
Absolutely, yeah. So, and ironically, my background is in drug development, so I'm completely, in support of everything that Ariel just shared from the pharma partnership perspective. With my May hat on, I think about this a little differently, right? Well, what I think about primarily in the context of May and the platform that we're hoping to scale is that far too often, I think well-meaning entrepreneurs like myself, like all of us, build a solution hoping that it will reach those most in need and those most underserved, right? And what happens far too often is that the easiest path to building and scaling some of these platforms is focusing direct to consumer, thinking about not touching the complexity that puts some of these solutions on a path to reimbursement and really in the hands of those who need them, right? So with my May hat on, thinking about partnerships, what I am primarily thinking about is putting the solution on a path to reimbursement and partnering with health payers, right? And specifically, because I am building a solution that is focused in Black maternal health, I'm thinking a lot about Medicaid, right? Medicaid's funding about 65% of Black births in the US. By no means is it the singular experience of Black expectant mothers. It was not my experience, but I think it's really important to think holistically about the population and make sure that we are not building to the exclusion of the majority of the population, right? So when I think about the most critical partnerships for us at May, I am thinking about payers. I am thinking about positioning May as a supplemental maternal health benefit for Black mothers, right? Those who are experiencing the most striking disparity in maternal health outcomes. I am also thinking about Medicaid. And what's so interesting to me as I continue on in this journey is how few other digital health platforms we are bumping into on the Medicaid side, right? Because again, I think the easiest path is to go and sell your digital health platform to employers or position it for direct to consumer utilization, right? And I think that makes us miss a whole lot of people, right? And so the path we're taking, admittedly, it is tough. It is lower margin, but I think it is critically important to our business in terms of helping us meet the majority of the population that we're serving. And by ignoring it, we would be doing a huge detriment to the business.
Well, I'm really, really pleased that you made that analysis. I think what I'm hearing and coming through from you and others of our panelists is the health equity fight is a moral fight. It is an ethical fight. It is a fight for the soul of the country. You cannot have a civilized democracy if you have these kinds of disparities in health outcomes. So there is that. But this is real talk to business community. And so I think what is clear, the insurers clearly would want to know what works and what doesn't work well, because they can't afford to lose money to pay waste buying things that, and their customers who are paying the bills for insurance don't want to waste their dollars on things that don't work. We have business opportunities. Black folk and Latino folk and Asian Pacific Islander folk and Native American folk, they spend money. And they have insurance, and when they don't, they spend money and out-of-pocket expenditures. So this is not like we're talking about, doing stuff and not getting a return on investment. This is pure cold-blooded business. And there are markets here that need to be addressed. And so there are multiple incentives here going forward. And I think that what you all are trying to say, and what I'm hearing you say is, let's not have the investors in the audience, the capital market representatives in the audience, the insurers in the audience, thinking that this health equity problem is a problem. Oh my God, I don't want to get involved with these people. There is a problem. No, there are solutions to these issues. And and I'll just say this as a Black man, we as Black people, we may have challenges. We may have problems, but we are not problem people. There are solutions here. Well, we have just enough time to go and do a quick round robin lightning round. And I'm going to start with Ryan and then Ariel and then Maya. And the issue here is you get less than a minute to say exactly what you had said before that you want to double down on, or you get to say something you didn't say that you would kick yourself in the back when you left because, I wish I had said that. So Ryan, how are you going to use your less than a minute?
Absolutely. All right. Straight to the point. First and foremost, it is great business. And with less than 4% representation of Hispanic, Blacks, and VCs, it's a moral imperative to make sure we're funding things that move the needle, making sure that we've got representation at leadership. I want to challenge those who are sitting on boards to reach down and do a skip level. It's been proven and shown that a lot of folks that are of minority backgrounds, females, diverse candidates actually happen to be 2 levels down from the CEO. So there's some really great data that also shows that if you can reach down and pull someone along, it could have a meaningful impact on your bottom line.
Thank you. That's it. You did it. Yeah. Ariel?
If anyone gets excited on the line about having diverse physicians and patients involved in clinical trials, and in a couple of years from now, having more than half the clinical trials run globally have diverse physicians and patients, reach out to me. My email is ariel.katz@h1.co, or you can ping me on LinkedIn.
As an entrepreneur. Maya?
So I will just say very quickly that I think that this conversation about what makes financial sense and what makes good sense for all of us as people, I don't think that those two things need to be mutually exclusive, right? I think what we see is that those who are underserved, those who are disproportionately impacted by poorer outcomes are driving disproportionate cost into the system, and a more rigorous investment in that population will return those financial benefits in addition to doing good.
Well, thank you. What a great, great, great contribution from each of you. Ryan, Ariel, Maya, we really want to thank you. And we turn it now back to Mary Stutz to take us home.
Yes, thank you. I have just enjoyed this panel so much. I have laughed out loud. I'm glad my microphone was not on because you all have just done a very spirited, actionable, and very impactful conversation about the importance of inclusive innovation. So thank you, Ryan, Maya, Ariel, and Dr. Tuckson for a great session. And we want to thank all of you for attending. Sorry, as you can tell, we did not get a chance to get to questions, but we will keep track of your questions. And this is not the end. As we said, this is not just a moment. This is the beginning of the movement to actually future-proof healthcare, to follow the progress of the many solutions that have been discussed here. So this is not the last time you'll hear from these panelists. You'll get more information about this. And I love the metrics that have been laid out in this session, some meaningful things for us to track going forward, our progress on making movement with advancing health equity in these areas. Both there is the societal imperative and there is a true business imperative. We are leaving millions of dollars on the table. We are, even more importantly, losing millions of lives because these things are not being addressed, and health equity is not being advanced. So lots of work to do. Thank you so much. Now we want to go to a session with Junie Simpson at Genentech, and she is one of the folks that is out in the field that is doing that intersectional work that we're talking about, that is a part of the solution, where we need to have folks from across corporations, across the communities, across industries and regulatory bodies and all of that. And so we are going to go to Junie. We won't, as I said, we won't have time at the end of that session with Junie to answer audience questions, but we do still want to hear from you. So drop your comments on the session on the right-hand side of your screen on YouTube live chat. And remember to join the conversation via your social channels by using the hashtag RealChemRAG. So with that, thank you all again, panelists, and take it away, Junie in Houston.
Hello, my name is Junie Simpson, and I have been with Genentech 13 years. During my tenure year, I've always had a passion for diversity, equity, inclusion, and belonging. And so I have showed up a leader, and I've been a field leader for more than a decade here at Genentech. It was very clear to me, we most recently launched into our customer engagement model that brought healthcare local. And I was a healthcare director here in the Houston ecosystem, which was one of 8 ecosystems that launched, to really just look at the individual makeup of the communities that we serve. And Houston being very diverse, it became very clear that our customers and our communities were very concerned about health equity. They really wanted to look at the demographics of the patients that we serve here in Houston. And I brought those insights back to Genentech. And Genentech leadership responded in large form, first by building a health equity strategy, which I represented the customer engagement team on that strategy building. That strategy includes 3 external pillars. The first one is increasing representation. The third one is access to equitable care. And the third, which I think is very key to bringing healthcare local, is building community trust. So what are some real world solutions that we're engaged in to advance health equity? We really believe that early disease detection and education are proven mechanisms to address health inequities, and our customer-facing teams are well poised to make an impact with a right-size approach, leveraging culturally sensitive and health literate screening and educational resources in the name of building community trust. That has been our approach as we have engaged communities across the country in this new ecosystem model. Health equity is not just a moral imperative, but a strategic priority aimed at opening up access to healthcare in underserved communities, Houston being one of them. And so one of the approaches is the Chief Diversity Office in 2020 really launched or executed on a health equity study. And what we found was that medically disenfranchised patients had a vastly different experience with the healthcare system. In the study, there were over 2,000 individuals that were interviewed. 1,000 of those were members of the general population, and around 1,200 were from the medically disenfranchised communities defined as Black, Latinx, LGBTQ+, and low socioeconomic status. About half of the medically disenfranchised patients interrupted their care or skipped appointments or stopped to provide 3 to 5 times more benefit for patients at 50% less the cost to society. And the intended outcome to focus on advancing health equity for the underserved populations through improved access to our medicines and increased participations in clinical trials. As you know, health disparities persist by gender, geography, race, ability, and other factors driven by systemic inequities. And so with these 3 pillars, we want to help to address the mistrust in a way that aligns with the community's needs and our corporate priorities. Some examples is that we have embarked upon in the name of early disease detection. One example that I can offer is the liver cancer screening campaign that was just launched here in the city of Houston, targeting Latinx and African Americans. We developed a patient-centric campaign to help address disparities in liver cancer screening rates. This was an unbranded disease educational effort aimed at patients with cirrhosis or other risk factors that often lead to liver cancer. What we found was that in South Texas, there was an increase in mortality with the African Americans and Hispanic communities. And we found that Texas was home to 6 of 12 cities in the US with the highest liver cancer incidence, and that included the city of Houston. Texas was also had the 4th highest liver mortality rate among all states. And so with this in mind, the campaign consisted of print banner, a billboard, strategically located in a geography of interest to really truly activate patients. And we also have a website which provides more information about common risk factors for the associated liver cancer. So the call to action is just to ask their doctor about their risk for liver cancer with the goal to truly activate more patients to inquire about their risks and to be screened. So as it relates to closing gaps, disparities of care gaps in the city of Houston, we recognize fully that we could not do this alone. And so we sought advice from those who were closest to the patients. We sought advice from some of the larger accounts like MD Anderson, Methodist, Memorial Hermann. We also sought out the CEOs of the federally qualified institutions across the city that actually see these underserved patients to make sure that we provided them with a resource on some simple steps that the patients can take to be screened regularly or to really identify themselves as, being at risk for liver cancer. The partnerships included the societies for primary care across the city, because we really do not call on primary care physicians. We actually play in the specialty arena. And so it was through that partnership with the federally qualified institutions across the city that we were able to really disseminate. And really the billboards that went out in certain areas targeting African Americans and Latinx were more of a trigger, because we did a pre-launch strategy where we communicated about what we were trying to accomplish and got them to agree to disseminate the resource to educate the public and these patients about screening and the importance and risk for liver cancer. Another example that I'll offer you as to how we've partnered nationally across the healthcare system is with the American Cancer Society. The aspiration was to establish Genentech as a leader and a partner of choice in advancing health equity. And we know that pandemic-related disruption to the healthcare system resulted in more than 50% of eligible adults missing, canceling, or delaying their routine cancer screenings in 2020. For the first time in 50 years, the American Cancer Society is embarking on a national public awareness campaign to encourage people to get back to routine cancer screenings. Genentech is proud to be a founding sponsor of the Return to Screening campaign. It is a national initiative convened by the American Cancer Society and the Centers for Disease Control and Prevention. And this innovative project promotes resuming cancer screening, which has been severely impacted due to the coronavirus pandemic, focusing on communities with the highest disparities. This is something I've given a lot of thought to. I really do believe that the key and the role that we have as an industry player is the early disease detection and education. And when I say education, I mean making generational impact by engaging a population early. And these are how people understand that who are the influencers in a community. For example, we know with certain communities, the Black community, faith-based organizations are definitely key. They have health ministers that are focused on this. We have got to go and engage the community and build that trust. And the way that we do is by bringing value and bringing education to really change those health behaviors. So my aspiration in this role is for us to close those gaps that exist across the therapeutic areas where we serve patients. And those are areas like neuroscience, ophthalmology, oncology. And so for us at Genentech, I feel that we are well poised. The fact that we're brought healthcare locally, that we can actually understand who the influencers are and those closest to the public and to patients, and actually give them the resources that they need in order to educate. And through education, I feel that we will find generational impact and change in health behaviors into the future. So that is my aspiration as I think about, what role Genentech can play in the communities that we serve.
Thank you, Junie, for such an insightful discussion on Genentech's Community First Health Equity Strategy. We are, again, excited to continue building on an amazing day of conversations with our next session, which is called Making the Case for the Business and Societal Value of Health Equity. A few housekeeping notes that we will be sharing the recording from today's session with all event registrants following the event. Also, we will be taking questions if time permits. So please do feel free to submit your questions via the chat box on the right-hand side of your screen. on YouTube Live. And also, the conversation isn't just happening on the YouTube platform, it's happening across social channels. So be sure to use the hashtag RealChemRHE to jump into the conversation. Now allow me to introduce our moderator, Minnie Baylor Henry, who is the president of B. Henry and Associates. And she's going to be leading our session on making the case for the business and societal value of health equity. Minnie, I turn it over to you to introduce our esteemed panelists and to get us started.
Thank you, Jewel. And it's my pleasure to be here to have a conversation about this important topic. And those of us who have worked for large organizations understand the importance of the building of a business case around different initiatives. And so what we're going to talk about is just that today, and hopefully the integration between building the business case and the societal value of building the business case. And so as you think about the business case for health equity, it seems quite simple, doesn't it? But really, is it? And if it was so simple, then why has it taken us so long to shine a light on this? And how sustainable is that light? And we're going to have some conversations about just sort of truing that up and really arguing for the sustainability of health equity. So I'm delighted that we have such a distinguished panel, and I'm going to ask each of the panelists to introduce themselves and to start us with just sort of one opening thought about the criticality of health equity in your organization. And so with that, we'll start with Laura.
Great to meet you. And thanks to Real Chemistry and you, Minnie, for hosting us today. So my name is Waryogu. I am a primary care physician by training. In my current role, I serve as the principal medical officer for Amazon and the medical director for Amazon Pharmacy. So Amazon's new full service retail pharmacy, integrating all of the convenience you know from .com, bringing that into the pharmacy space. In my prior roles, I'd been the founding medical director at an innovative company called City Block Health, delivering primary care to high-cost, mostly minority populations. And I've consulted in health equity for both local and international governments. So this is a space that I care a lot about, the space that I think is of the utmost importance. To answer your question directly around why is health equity important to our organization, we pride ourselves at Amazon on being highly and extremely customer obsessed. So that's something we speak about in every meeting. Customer first, customer obsession. Your customer is everyone. You have a diverse customer set. If you are not focused on equity, if you're not focused on serving all of your customers, then we're not doing our job. We're not delivering. So to truly be customer obsessed, that means serving all of our customers equitably. And that means going above and beyond, because we know that with the systemic imbalances that exist in society, we have classism, we have racism. If you don't account for all of those inequities and take steps to address them, you're not going to be as customer obsessed as you should be.
Great, thank you. We look forward to probing that a little bit more later on in the conversation. So Nirav, same thing, a brief overview of your background and give us sort of your opening thoughts around this business imperative.
Thank you, Minnie. It's a pleasure to be here. And my name is Nirav Shah. I'm an internist by training. And currently I am senior scholar at Stanford University and chief medical officer of ShareCare. ShareCare is a digital health company. It's a platform that actually helps individuals manage all of their health in one place. In prior roles, I've served as chief operating officer for Kaiser Permanente in Southern California and health commissioner of New York State. To your question, at ShareCare, we believe our core philosophy is that we're all together better. And we focus on that, and it drives all of our actions. To the extent that a focus on equity really allows us to change behaviors better and help people get to where they want to be, it really helps shape all of our strategies in all we do.
Great, thank you. And last but certainly not least, Jonah.
Yes, hi. Really excited about this conversation. Thank you for having me. My name is Jonay Khaldun. I am the Chief Health Equity Officer for CVS Health, so an organization that includes Aetna, Caremark. Of course, many people are familiar with our pharmacy and retail chain as well. So right now, I'm the Chief Health Equity Officer. I'm also a practicing emergency medicine physician. In my background, most recently, I was part of a team leading Michigan's COVID-19 response as the Chief Medical Executive there. And prior to that, I was the Detroit Health Director. So really excited about this conversation today. And I would say for CVS Health, I mean, it's really simple for us. Our motto is that we bring our heart to every moment of your health, and that we create systems so that people can get access to health in the most simple way possible. So equity is very central to our business. And again, I look forward to having the conversation today about how to best do that.
Great, thank you. So as you can see, we have a really distinguished panel with lots of different experiences in your background. So they're well equipped to have this important conversation about this business imperative. And so let me begin by quoting Wara. So Wara, on September 23rd, 2020, you tweeted that the systemic part of systemic racism means that left alone, the system will continue to produce the results it was designed to create. And I love this quote. And so I'm going to ask you if you would comment on that as sort of a starting place for us to have this conversation, because it's so poignant that you, in September of 2020, you tweeted this. And I'm also wondering about sort of the relevance of that tweet today.
It's relevant today. It was relevant 10 years ago. It was relevant 50 years ago, unfortunately. What it's saying is that we have to recognize that the system is designed in a lot of ways to produce unequal outcomes, and that cuts across industries. That is, banking, that is housing, that unfortunately is also healthcare. And for us to have better results, for us to truly achieve health equity, we have to take a systemic view. We have to understand the multiple players who are affecting our customers, our patients, and we need to understand all of the ways in which the system is disadvantaging them, all of the ways in which all of the barriers that they are having to overcome. And that means when we're designing, we need to design with that in mind. So that means we have to make sure that we do our part to not make the situation worse, but to actually hopefully contribute to the solution. But we also need to partner with the ecosystem, because it cannot be an individual solve. It has to be a systemic solve. And we have to hold both of those truths at once, to both do our part and to also partner with others so that there's also a systemic response.
So I love that quote. And so I'm wondering, Anurag, if you could react to this quote from 2020 that's so relevant today and so applicable to everything that we're all doing on a daily basis.
Yeah, the systems thinking that we have to do is fascinating. And there are systems that, I'll give you an example from my time when I was at Kaiser. The average colorectal cancer survival rate in America is about 65%. But at Kaiser, the 5-year survival rate was 85+%. And that was because of the systems in place. You're not relying on humans to remember or forget. You're not relying on any one person to be a single point of failure. You surround the member or patient with all of these reminder systems. You show up for an orthopedic appointment, your orthopedic surgeon will remind you to go get your colonoscopy, right? And so that systems approach to improving quality, improving outcomes, and focusing on disparities, and specifically those populations who are more vulnerable, allows one to raise the bar to the top of the evidence-based pyramid. And that's where that systems thinking allows the defaults to change, and that's the first job we have to do.
Okay, so I'm wondering, Jonay, I know that you're somewhat new to CVS, but CVS is a pretty complicated system. I mean, there are lots of tentacles when you think about sort of the CVS family of companies. And I'm wondering about sort of your thoughts around this whole idea of integrating care through a systems approach.
Absolutely. A lot of my previous work has been in governmental public health. But I'll tell you, one of the things I would always talk about in those roles is that the work of health and community health and public health is not just about the work of the government public health department. So really always have focused on public-private partnerships and how we think holistically about care and health in communities. So I think it's really important. CVS Health has been a leader, quite frankly, in advancing health during the COVID-19 pandemic, providing over 41 million tests, half of those actually in underserved areas. Also over 50 million vaccines, 40% of those being in underserved areas. So I think it's important when we think about this system that none of us alone can actually address health equity. We really have to think about what can we leverage? What do you as an organization uniquely have, whether it's skill sets or data or infrastructure? What do you have that can contribute to collective health equity goals? And then I'll just say, I think it's also important for people to understand, particularly those who don't think about health equity every day, it is not a zero-sum game. The thing is, there's actually enough resources across the globe and here in this country for everyone to be able to achieve optimal health. So it's important that people understand that as we talk about health equity, it's not that one person's health has to go down in order to elevate someone else's. It's really not a zero-sum game.
And so I'm going to follow up with that, and I'll come to the other panelists as well. So what's the business case for making sure that there is equity amongst the different populations that may or may not be able to utilize your services?
So I'll say, an estimated $93 billion a year can be attributed to, and healthcare costs can be attributed to healthcare disparities. And as a business, you can also even think about your own employees. There's $42 billion worth of lost productivity annually due to health disparities. So I think the business case is for the communities that you're serving, but also for your own employees, productivity, decreased costs, and making sure you're serving your communities well with the resources that you have as a business.
Yeah, because I'm a pharmacist, I can relate to many of your comments. I think your comments are so relevant, and I think the pharmacist plays an important role in the community, not just during COVID, but always. And so, Wara, tell me, in your organization, I want to hear what Amazon's business case is for ensuring that health equity is a priority in your organization.
I think one of the pluses of Amazon is that you don't always have to make the strongest business case to move in a direction. You can really make the customer case first. So you can say, here is the customer, here is how this benefits us, and that is reason enough to run at a problem. So I've been glad to find that we have leaders who will let us drive at that. That being said, it's still a business, so there is still a business case to be made. And when I think of the business case, I think of three main pillars and three main arguments that I make. One is that in business school, we're always taught that you should see all challenges as opportunities. And unfortunately, because of the health inequities we have in society, a lot of our underserved, a lot of our minority communities have higher rates of all diseases, higher rates of heart disease, higher rates of diabetes. And because of that, that also means there is more need for healthcare services, more need for pharmacy services. So therefore, there's a disproportionate need in those populations and a disproportionate need to be served. So therefore, there's a disproportionate opportunity there. Second, for us as Amazon, we are new into the pharmacy space. These are often customers that aren't served as well by the existing system. So that's an opportunity. Those are customers who are looking for a change. They're looking for a more convenient, lower cost option. In a lot of ways, that's, as a new entrant, that is a great place to start. Those are great patients to serve. So to me, those are some key ways in which I think about the business case for health equity.
And so without asking you to divulge any business secrets, because certainly you would not do that. But is it a business imperative for your organization or organizations that you've been involved in to make sure that there is equitable treatment for diverse populations throughout the marketplace that you serve?
There is, and one of the things that we've been working on over the past year is thinking through what are those mechanisms, because it's, you can say we need to do this. This is important. There's opportunity here, but in a lot of ways, there are a lot of factors that have people not focus on these communities, whether it's because of, oftentimes it may be because the internal team itself doesn't reflect those communities, so they don't understand the communities as well. So, we oftentimes build for what we know when we build for people that are like us. There's also the risk of oftentimes people will shy away from government payers because there's a little bit more regulation in Medicaid. It's a little bit more complex, so people will shy away from that complexity. One of the many mechanisms that we put into place is for each new feature that is launched, one of the things that we've been doing is pushing all of our product managers to answer the question. When we're developing new features, we have a robust development process. There's a document that all the product managers make for each feature. One of the things we've been pushing is to have included in there a question to explicitly ask, what effect is this going to have on health equity? How is this going to serve diverse populations? That way it's explicit if there are any trade-offs being made. It's also explicit if they haven't thought about that. So that's one of the, that's a concrete example, but one of the example of the many mechanisms that we're trying to drive to make sure that we are designing with equity in mind from the beginning. Part of that also means that having our UX team reaching out to and engaging with a diverse population, that way, as we're figuring out what customer needs are and what the customer problems are to solve, we're hearing from a diverse population. That way we're serving all of those needs.
So we'll come back to that. So I really appreciate your going into that level of detail, and we'll come back to that because I think it's important that we talk about sort of how large organizations are able to drill down and to make sure that the important aspects of serving communities is addressed, while also making sure that you have a profitable business. And I don't think anyone's arguing against the criticality of a profitable business. So Nirav, I often hear that academic medical centers are not necessarily sort of the first place you think of when you're a part of a diverse community, because oftentimes they're not viewed as necessarily as friendly to diverse communities. And so I want you to put on your Stanford hat now, because I know you play multiple roles. So put on your Stanford hat and tell me what at Stanford you're doing to make sure that your academic medical center is welcoming to diverse populations that may not be as willing to ask all of the questions that are necessary? Or so what are you doing to reach out to the community to make sure that you're bringing them into your organization?
Yeah, let me start by saying, first of all, it makes absolute business sense to improve access to care. That is probably number one on the list for improving equity, is access in many healthcare systems. And Stanford and many other systems have seen an opportunity to do that through COVID. We went from 0% telehealth visits in our primary care, 0% video visits, to 75% in 3 weeks with COVID, right? And so what that meant was that people who had very little access, who had to travel, who had bus transfers, who didn't know how to get in to see their doctor, could do so over their smartphone. In America today, there is no digital divide. There's a digital divide when it comes to rural broadband, when it comes to high-speed internet. There's no digital divide across the races when it comes to smartphones with the cellular plan. Maybe the data is limited from one plan to the next, but if you look, they're over 90% according to Pew 2019 surveys, if you look across races, ages, et cetera. So our opportunity to reach out and connect with members and patients directly through video visits has opened our eyes to the opportunities. And what we thought was once sacred, you have to come in to see your doctor to do something. Suddenly, we realized that 60, 70% of these visits can safely be done remotely. And that's a win-win-win-win for the patient, win for the system, win for costs containment. And so it allows us to expand access and improve the business of healthcare, thereby creating capacity for moving upstream and into prevention as well. Whereas once upon a time, it was only focused on the downstream expensive subspecialty care where you make a lot of money if they show up in the hospital and get admitted. There's ways to now think broader and expand your business case for health.
And so have you started having conversations about what happens post-COVID?
Yeah, and unfortunately, like most other institutions, our eyes were open to the opportunities. You swing the pendulum one way to 75% video visits, but then the pendulum swung back. And right now we're figuring out what the right rate is in terms of the optimal safety, quality, business case, et cetera. But it's not zero. It's probably not 75%, but it's right now it's in the lower end of the low 20s. We need to figure out the right place and then understand for different populations, you may want to do where we're learning text messaging works for certain populations much better because they're used to chatting and they're used to doing that kind of interaction with their clinical team. So there's lots of opportunities to learn right now, and we're exploring many of them simultaneously.
So is there a literacy issue there?
It's interesting. You'd think there would be, and I suspect there is, but when you wonder, are older adults and Medicare populations going to use telehealth? Well, surprisingly, they do. They're already using these platforms to video chat with their grandkids. They have other ways to connect through WhatsApp and Facebook and others. So they've already engaged with these platforms. So there's health literacy and there's digital literacy, and both have to be considered. But I'm surprised and pleasantly surprised that you can actually reach many members and patients directly through something as simple as a smartphone.
Okay, I live in Boston, and so we have lots of academic medical centers there, and so I'm keenly aware of this shift to telehealth, and so watching this quite closely. And so I want to switch topics because I know we're limited on time, and so it's almost like we need to quickly go from topic to topic. But what I'd like to just hear your thoughts about is kind of how do we make sure that businesses are not just paying lip service to the importance of health equity. So it's this whole idea that everyone's on the health equity bandwagon right now. And how do we make sure that this is not sort of the flavor of the day, so to speak, that this is something that's important, that's sustainable, that we can have this conversation 10 years from now, and we will have elevated this conversation versus putting it up on the shelf. And so I'm going to start with you, Janae.
Yeah, I think that's incredibly important. And one of the things that I've tried to do in my former roles and my current role at CVS Health is think about how you integrate equity into your actual policies and practices so that people don't even know that they're actually addressing health equity. So I love what Nora said about just when you're thinking about your product development, have a question about how you are impacting underserved communities. That's incredibly important. I think data, we haven't gotten into this, but I think data is incredibly important. Can we just think about our data infrastructure? How are we thinking more granularly about race, ethnicity, asking about disability status? How are we asking about preferred language, understanding that data, analyzing it, and then implementing our programs based on what we actually see? So I think that it has to get beyond people making those initial investments. It has to get beyond training. We need our infrastructure, our policies, our data, so that it's just automatic, so that people just do it and don't even know that they're actually addressing health equity. I think that's important.
And I could not agree more. I think everything Ginny said is exactly right. It's about building it into your system. We talk about systemic racism, the fact that it's built into systems so it happens otherwise, right? What she's saying is let's do the reverse. Let's build equity into our system so that even if you're walking in and you're going about your regular job, you're moving the ball forward. I think that's exactly what we need to be designing for. And a lot of that starts with data. It's surprisingly hard to understand, are you doing a good job in health equity or not? There's not an established set of metrics that everyone holds themselves to. So you can see how is organization A doing compared to organization B? How's hospital A doing versus hospital B? I've said to friends for the longest time, if we really wanted to change kind of the makeup of the patient population at academic medical centers, what you could do is have U.S. News and World Report take the diversity of the population into their rankings. And I guarantee you would see an uptick at every single major academic medical center. And that's true across the board. Metrics are, they're how we measure ourselves, they're how we measure success. And if we're going to enact change, it's got to be around data and metrics, because that's how you enact that kind of systemic change.
Exactly. Yeah. And let me add to that, measuring what matters, right? It used to be we only did randomized clinical trials in white males. And so we knew the answer for white males, but that answer didn't necessarily apply to other folks. And today, this morning, actually, Alex Hardy in the first panel talked about the importance of diversity in recruiting for clinical trials. So with our SmartOmics decentralized clinical trial platform, we're doing exactly that. We're reaching out and finding underserved populations who aren't traditionally found in research, because there's a business case for that when you want to start selling a drug based not on just the price to develop it, but on the value to the patient getting it over years, like that understanding that patient and the experience and getting all of those people into those trials makes a big difference. So measuring what matters, absolutely. And as part of measuring what matters, you really have to start collecting data. We've invested in something called the Community Wellbeing Index, which has over 600 different elements. How safe and walkable is your neighborhood? This CWBI is for 99.9% of America, because it allows us to then say, okay, so we understand the communities, the opportunities in that community, and how do we target that community to improve population health, leveraging this platform and all of our partners around it to optimize health. You've heard of blue zones. That's part of our approach at ShareCare, is like measure what matters. Oh, and by the way, one last thing, bring the CFO into the conversation early, because the CFO's metrics may not be my metrics as chief medical officer or chief quality or this or that metric. And so to create the scaffolding early on for the sustainable business case, you get the CFO at the table and you fill out the form in his or her format for that pilot study right from the beginning, so that when you ultimately build it, you've proven the business case, not just for yourself from a clinical perspective or an outcomes perspective or a quality perspective, but from her or his perspective as well.
So you definitely are making the case for what gets measured gets done. And I think all of us in business have sort of lived by that. And so I want to just go back to a theme that we talked about earlier, which Dr. Garth Graham from Google made this point earlier on an earlier panel, and I wrote it down, and I just want to hear your reaction to it. He said, whenever an urgent situation is no longer urgent, we fall back to what we were doing before. And so Nirav, what's your reaction to that?
We have an urgent situation, and COVID showed that care moved to the home. I don't think that care in hospitals and health systems and in bricks and mortar that's built up, that's going to be the exception, not the rule going forward. The billion-dollar valuations in healthcare are coming to companies who's figured out how to do gig employees, how to do care in the home, how to do telehealth, how to do all these new models. And so there is a burning platform. And that burning platform is you're going to be left behind if you don't figure out how to meet people where they work, live, pray, and play. And that means understanding your customer. So I'm actually more optimistic than I've ever been about the opportunities to reduce disparities, improve equity, improve outcomes for various populations now more than ever.
And maybe I'll just add to that.
Yes.
I think certainly because of COVID-19, disparities have kind of come to the forefront. But as many of us know, the discussion around equity and disparities has been going on for quite a long time. It's just that some folks are just now learning about that. So the urgency, particularly in minority communities, has been there for some time. And it was not a surprise to a lot of folks that we had higher rates of COVID-19 infection, hospitalizations, and deaths. So I think it's important, going back to that theme about systemic change, what are the reasons for those outcomes? Why is it that Black and brown people are more likely to live in poor housing, crowded housing, not have access to transportation? Let's think about those things, because again, it's urgent for some people now. It's been urgent for many folks for generations.
So we have a question from the audience. The question is, can the panelists comment on efforts to increase health literacy among underrepresented communities and how this makes good business sense to ensure provider and patients are communicating? So we'll start, Wara, we'll start with you.
I think health literacy is so important, and part of what we want to do is meet patients where they are. We know that we have millions of customers on our platform every day, so that means millions of customers are on Amazon, whether that's buying groceries, reading about products, shopping for their medications. They're there. So part of what we want to do is be able to meet people where they are, use the patterns that they're used to, and that means that Amazon.com, the platform, if we design it right, if we do it right, if we partner with the right communities, if we listen to the right communities, we can, I call it the Spider-Man principle. With that great power comes great responsibility. So if designed right, we can use that as a tool to also drive health equity, because we can meet people where they are. And part of where they are is on.com. So that means using that platform and that tool to drive health literacy, but also that means to drive access to medications, access to fresh foods, and connectedness.
Great.
Yeah. Let me add to that. I think, to the extent that we start to understand how, what is capturing people's attention today, it's the Facebooks, it's the TikToks and all, it's our job in healthcare now to create really high quality, engaging content that's short, that's digestible, that's made by people who look like them. And that's where the platforms now allow us to do that. We have 20, 40,000 different video clips right now on the ShareCare platform around all different kinds of health concerns. And they're updated in real time, and they're validated, and they're evidence-based. And that kind of approach of going to where the patient is and meeting them where they are, rather than expecting them to come to our house, our clinics, and our hospitals on our terms, that's our job now, is to go to them.
And I'll say I've never loved the term health literacy, because I think built into health literacy is that the patient should understand all of this jargon that the doctor is saying, and to me it's more like, no, the doctor should know how to communicate things clearly, and if the doctor or the nurse is not communicating things clearly, that's a problem with the way that the doctor and the nurse is communicating. That's not a problem with the way that the customer is understanding. We think about that all the time at Amazon. If we're not creating a good experience for the customer, that is our fault. That is not the customer's fault.
So we are almost out of time, and I can't believe how quickly this time has gone by. So just sort of one quick final comment from each of you. So as we think about sort of this business case, what does success look like? So this is a kind of a rapid fire last comment. So Janae, I'm going to start with you.
Yeah, success is when we see the disparities decrease or eliminated, quite frankly. We can put all our efforts into doing work and programs. If those disparities don't go away, then we're not going to be successful.
Great. Nirav?
Ditto. And I'll add, I think we have the opportunity now. The anecdote I'll give you is we used to rely on clinical claims data for signals to understand patients, and that built our AI models. Then we relied on electronic health record data. Then we relied on natural language processing of the EHR chart. And so we're getting closer and closer to the patient. Soon we'll realize that the best AI models and the best actionable insights to change behaviors will come from the patient, him or herself. And to be able to do that well, we need to understand that whole patient in their full context. We're already doing that. We now only pay, United pays for hip replacements only if you report back patient-reported outcome measures. So how are you going to collect that? Some clinically validated tool that was done for research from 40 years ago? Or you're going to figure out how to do that in real time, in the real world, from the real patient, so that you get paid for it, right? So we're getting there. The vectors are pointing towards success, and I think we'll see a lot of movement in the next 3 years.
Great. Wara, you get the last word.
I've got to agree. This is about outcomes. This is about serving people. It's not about making big statements. It's not about, saying that we're going to do the right thing. It's about knowing, are we actually reducing outcomes for patients? Are we serving our customers? And the only way that we're going to know that we're serving all of our customers, that we're eliminating these disparities, is if we measure them. And we measure them so that we can know when we're hitting our outcome, and we can be held accountable by ourselves and others when we are not.
Great. So thank you so much. So I will close by just reiterating what Janai said. In the Black and Brown and minority communities, we've known for a long time that there were health disparities and inequities. And it's just now sort of coming into full light. But we owe it to ourselves and to our communities to not allow this to fade into the background once COVID moves back into whatever state it will be in. We owe it to continue to have this conversation, and that we continue to shine a light on the importance of making sure there's equitable treatment of all people. So with that, I say thank you to the panel for this rich discussion, and we'll turn it back to Jewel.
Thank you all for such a rich discussion. I mean, I think you perfectly captured in that time that, it is no longer a nice to have. It is not about doing the right thing. There is real justification to focus on and to integrate health equity as a core part of our business strategies if we are to future-proof health innovation and to improve health outcomes for all. So that's kind of my key takeaway from this amazing discussion that just happened. But there was so much else that was shared. So thank you all for such an important discussion. Thank you to our attendees. Please tune in for the next session, which is starting soon, on diversifying the human genome database. We will be back in just a few minutes.
Hi, everyone, and welcome back to the Real Health Equity Summit. Thank you to all of you who've been with us all day. I know some of you have jumped in and out, but it has been amazing. And I certainly have been looking forward to, for weeks, this next session on diversifying the human genome database. But just before we jump in, a few housekeeping items. We will be sharing the recordings from all of today's sessions with everyone who registered for the event. Immediately following the event, we will be taking questions for this panel if time permits. So if you have questions, please feel free to submit them via the chat box on the right-hand side of your screen on the YouTube Live. And then also join the conversation via your social channels by using the hashtag RealChemRHE, that's RealChemRHE. So I am, one of the reasons I've been looking forward to this session is because I am moderating it. I pulled some strings to moderate it myself. I just wanted to do it because I'm just so excited about being on the panel with our two panelists, but also about the topic. It's just something that's very near and dear to my heart. So with that, I will introduce our panelists. We have with us joining for this session, Quita Highsmith. She is the Vice President and Chief Diversity Officer at Genentech, a member of the Roche Group. She is responsible for leading Genentech's diversity and inclusion enterprise strategy, including recruiting, retaining, and developing diverse talent, investing in initiatives to support science education, and addressing barriers in clinical trial participation via the Advancing Inclusive Research Initiative. Joining Quita is Dr. Christopher Cross. He is the Managing Director and founder of Cross River Strategies, LLC. Dr. Cross is a biomedical engineer, an anatomist, a neuroscientist, a population geneticist. I'm so glad I majored in communications and I can read it. Okay, a cancer biologist and an LGBTQ plus advocate and entrepreneur. As I said, he leads Cross River Strategies, which is a US-based boutique consulting firm that uses community engagement and scientific research to power health equity strategies and services across biotech, pharma, and academic institutions. So both of them are just amazing folks who have been doing some tremendous work in this space. And I am super excited to talk to you about it. And our topic today is all about the human genome database. And of course, Dr. Cross is going to make sure that we're very clear on what that means. But our topic is diversifying the human genome database. And until diversity is really recognized as a critical driver of scientific success, we are not going to fully witness the benefits of genomics for overall disease awareness and improved health. And certainly we won't reach and achieve our goals of precision medicine and personalized health. So as health equity continues to evolve, we still have a lot of work to do, including non-European individuals in human genome studies, so that we can collectively combine the scientific advances, the new technologies, the real-world data to drive scientific innovation, and to also create new standards for inclusive clinical research and resulting therapies. And if you've participated in any of the sessions today or listened in, you have heard everyone talking about that the status quo and how we've been doing things in the past is not going to get us where we need to go. And there is a business case for this, there is a societal case, but even more so, there's a plain old human case for people and humanity, and making sure that everyone has the opportunity to benefit from the best of all of the whole health ecosystem that we have created. So we want to zero in a little bit more on why this piece is so critical, again, to us really achieving full health equity. So I want to start with you, Dr. Cross. health equity doesn't start and stop with clinical trials. And that's something that I certainly have been emphasizing a lot. It's one of the reasons why we did the summit. But there is a need to decentralize the approach we take to these trials. So the clinical challenges of health equity and why we have to think out of the box and go beyond diversifying our clinical trials to address these health equities across the clinical health ecosystem. Talk to us about that and why that's so important.
Well, thank you so much, Mary. First and foremost, I'm just so happy to be sitting here with you and our distinguished guest, Quita, who I'm so excited to have this conversation with as well. And so to answer your question, in the context of our talk, which is diversifying the human genome database, the human genome has been used in lots of ways to create advancements. And so we kind of have to understand what that is, right? And so when we talk about the database, we're talking about really a collection of the genetic code from many different individuals. And so right now, I think the largest database that has that is from Genome AD. And they have over 140,000 individuals within their database. And so how that actually helps us in the clinical setting and where people care about it is these studies that you use that human genetic research for to then understand where is that genetic variation and then how is that correlated with disease. And so those studies are called GWAS studies. So I know Quita and Genentech guys are super familiar with all of that. And those are sort of the gold standard studies that are used to actually do disease correlation. And so that's why it's so important that we diversify the human genome databases and include more information for people of color and underrepresented groups. Because it's about, I think right now to date, there's, of the GWAS catalog, 80% is from European descent, 20% is non-European, and of that non-European, majority of that is 10% Asian, and then about 2% of African descended populations. And keeping in mind that 2% is both African American and people from the continent. And as we know, that's a huge disproportion of people that are missing. And so, yes, we are 99.9% the same, but that 0.1% is about 3 billion base pairs. And so that 0.1% of genetic variation very much influences how we can acquire disease or disease susceptibility. So we need to start to understand that more and have a general understanding of how do we actionize ourselves to make solutions to include other people to increase those different databases so we can address different diseases.
Excellent. Thank you for that clarification. And it is, I mean, those are dire straits when you look at those numbers. And I know we're going to talk about that some more, but Quita, why don't you tell us why you decided to focus on inclusive research and to spearhead this whole inclusive research initiative at Genentech? What led to that?
Yeah, let me just piggyback on what Dr. Cross just said. When we think about the human genome and the sequencing, this is continuing to fail us, right? There are populations, we're going to be left behind as we think about the road to precision medicine. Precision medicine is going to be targeted based on sequencing. And if we're not in the database, guess what? We're not going to be in the precision medicine category. And so for us at Genentech, what kind of really led to this about 5 years ago, when I was leading Alliance and Advocacy Relations team, which is engaged with patient advocate organizations, we were planning a patient summit. And I wanted to include a diverse set of patients from underrepresented groups that had participated in the clinical research. And unfortunately, we could not identify not one single patient of color that had actually participated in the study. So I began to ask, why is that? We're a big organization. Why can't we find nobody? And a colleague of mine, Nicole, who I think is also going to be a speaker, was asking those same questions as well. So it led us to co-found Advancing Inclusive Research, which is for Genentech, it's our initiative to address barriers to clinical research and to increase participation of racial and ethnic underrepresented groups for a couple of things. One, you can't have a singular approach, right? You've got to be thinking, like, this is systemic. This is going to take a lot of effort. But we've narrowed it down to 3 things that really have helped impact our clinical work. And when I say impact, I'm talking about, we did a study in COVID-19 for COVID-19 pneumonia, and 85% of the study population came from communities of color, African American. We went to Africa, Mexico, Brazil, the Native American population here in the US. But it's, how do we think about recruiting more representative populations? And I say that we've been working on this since 2016. And when the pandemic hit, we were ready to take that step, because you can't just jump up and then go to a community and ask investigators, hey, start doing this work. You got to build trust. And so that was one of the things that we have been working on, is how do we think about building external coalitions? Because a lot of communities in Black and Latinx, Hispanic communities, we believe in the 3 Bs, right? We getting information and carrying on conversations with the bishop, so the church, the barbershop, and a beauty salon. So, like, how are we thinking about external coalitions? And then third is, how do we think about enhancing the diversity of data, right? Meaning, how do we better match the population that has the disease with personalized healthcare so that we can begin to optimize treatments? And now, years later, 2022, as the Chief Diversity Officer, advancing inclusive research is a core fundamental of the business of Genentech. And I believe Alexander Hardy, our CEO, was on, and he was talking about the business impact that we've had. And I will say one last thing. Because when I was raising my hand, I wasn't the chief diversity officer. I wasn't a vice president, but I knew we needed to do something. So I would say to the audience, you can raise your hand from any seat to start to really make real change.
I appreciate that, Quita, because that is exactly right. I'm sure that's how all of us have gotten to where we are. It's raising our hand and speaking up to acknowledge that this is wrong and we need to fix it. And I'm raising my hand to help fix it. And I think that is critical for everyone that's listening to the summit, for all of the speakers that are participating, because this is really just the beginning. And our goal is that this is not just a moment in time, but this is actually a movement, and we will continue advancing, and we will be able to look back, because I'm going to ask you all to share what success looks like to you in the next 5 to 10 years. But we are capturing all of that because we want to be able to look back and track and see, have we moved the needle? What gets measured gets done. And then also holding people accountable as well is very critical. So I want to ask you, I want to talk about other solutions. I know you talked about some. I'm going to come back to you, Quita, to talk specifically about some of your initiatives. Dr. Cross, I want you to talk about the significance of digital health solutions to moving the needle on health equity. I am a firm believer that this is not going to happen by just mandating everybody has to go to a doctor's office or to a hospital or, to get their care or whatever. We've got to reinvent and reimagine this whole thing. And I think digital health will play a huge role. So tell us about that and your work in that space.
No, absolutely. And I think, with digital health, we think of electronic health records. We're thinking of patient-generated health data that we've talked about before in our last talk.
But I want you to talk about it now, because I want you to go into a little bit of detail about that, because I found that very interesting and fascinating, and we need to educate more about that.
No, absolutely. So with electronic health records, we know we're used to kind of getting our information now, going to health systems and getting that information collected. A lot of us don't sometimes understand how that information can still be used to create advancements. And then if you've actually had an implant, there's also the user device identifiers, the UDIs, that are actually coded with those implants. And that can actually be included in your EHRs. So when pharma wants to create an advancement, or if there's an issue with that device, they can more readily understand who has the device, who needs that advancement, and use that to actually create new technology. So that's an example. In the context of our talk with the human genome, what underlies the ability to do the sequencing, to do the studies, is artificial intelligence and machine learning as tools. And so you can't do really any of this without that. And so these are tools that are created to utilize or really to understand this big data, right? Because the genetic code, there's over 26,000 genes. There's, billions and billions of base pairs. So you can't use a Punnett square to figure this out. You've got to have technology that actually understands and unpacks these things and puts it in ways that we can understand it and utilize it and actually make advancements for. So how I see digital health solutions moving the needle to create health equity, it ultimately could be, if you envision this scenario, right, we use our phones and mobile devices all the time. If there was a dynamic clinical management tool where you say you have your genome sequence, and now we understand that 0.1% variation, and then how that can increase your susceptibility for disease. How can that influence your metabolic ability to process treatments? How can that influence potential side effects for medications you may be taking? We can actually get there. It's going to take time, but there are also two, I think, major things we need to do to make sure that can happen. The first is making sure that we have more underrepresented scientists in this space, right? So I think over the last 10 years, it's stayed at around 6% as far as the number of African-American PhDs in STEM. And we're 12% of the population? That's not enough, right? There is also new technology with AI technology and AI degrees. From the Pew Research Center, I think they did last year some work. There were 2.4% of PhDs were going into AI research that were African American, and I think it was 3.2% of Hispanic descent. So there is a dearth of representation in the pipeline to do the work. And lastly, which may be a little controversial, is removing a colonizing mindset from doing the research. And what I mean by that is there are a lot of investigators, of European descent who are doing great work, but there is a subset that has this ownership mentality on taking certain geographic areas under their purview of research and blocking out other investigators that want to do that work. So that's something we have to really address. And then just to make that even more clear, with the SCOTUS decision of 2013, where they shot down, I think, Myriad Genetics' ability to patent the BRCA genes, that was the first step into owning genes. And so there's a lot of researchers who were in the habit of trying to patent alleles and genes of people of African descent. Yes. So it doesn't get any clearer than how a colonizing mindset has been used throughout time, and in particular, the Human Genome Database is another ripe space where that can still be taken advantage of. So we've got to remove that colonizing mentality, and we also have to diversify the pipeline of people who are doing the work.
Mary, I'm gonna have to piggyback on this one because I know this conference is called Real Health, but let's have some real talk. Okay. Because what he just said is critical. Artificial intelligence can be a very powerful tool in healthcare, but here's the situation. A Nature article from 2019 demonstrated that millions of Black people are affected by racial bias in healthcare algorithms, right? Because the colonizing mindset, the people who are putting decisions in this software are favoring white patients over sicker Black patients. The second thing is because the GWAS, the genome-wide database, is predominantly of European ancestry, this means that the tools and the algorithms are basing treatment decisions really on, so if I, as a Black woman, get breast cancer, only 6% of the information for the algorithm is going to be based on a Black woman. So the algorithm is going to spit out a treatment for me based on a white woman's breast cancer. And so we have to be very careful about artificial intelligence not creating a further gap in health equity.
That's exactly right. And that's why we want to draw attention to this and talk about it. So who is accountable to make sure that that does not happen? We understand that it's probably happening right now, but through these channels, through our voices, through this collective focus on health equity now, we're really drawing attention to it. But how do we make sure that this is addressed and that it's brought out and that people are addressing it? The organizations, the folks that are doing the research, those that are developing the algorithms, all of that. Who's accountable to make sure that this is done equitably?
I think everybody in the healthcare system, but a couple of things. One, we got to stop blaming patients of color, right? Because let me tell you, a few years ago when Clear came out, my husband didn't want to, go and give his fingerprint and his eye scan because he's like, I don't know what they're going to do with that, right? It's like, what people say, well, I want to do a genetic test. They hear about 23andMe and all this and that. So for one, we've got to explain it. What is the value for you and your family to participate in this? And so we've got to, because we're skeptical and we have a reason to be skeptical. Healthcare and the system hasn't always been treating us properly. So we have to come up with some real solutions to address people's concerns because we can't just do things differently. We've got to do different things, right? And so we have to make sure that patients of color feel valued, feel respected, feel understood, feel heard when they are seeking care. And so then, and the provider and the resources available to us, we have to really take time to explain the why. It's not just enough to say, Mrs. Jones, you've got cancer and we're going to do this. It is, here's the value of this. Here's why we want to do this so that we can find a targeted gene that can maybe get you a specific therapy. I think the other thing is we've got to realize that if healthcare is not affordable, then you know what? It's going to be hard for you because if you don't have access to medical benefits, so you can go get the genome test, right? If you got high copays, if you don't have access to fresh foods, if you live in red line neighborhoods that don't have a doctor's office, a hospital, a pharmacy on the corner, then you don't have quick access to healthcare. And so the financial burden is quite high for some. And Alexander mentioned one of the things that we're doing at Genentech is we're seeking opportunities and ways to think outside of the box to ensure that patients who are participating in our clinical work are not bearing the brunt of that. And then I think Dr. Cross hit the nail on the head when he said, we've got to have more diversity in the pipeline. And one of the things that we're doing is we're committed to a program initiative that we call Kindergarten to Careers so that we can help develop and fund a pipeline of talent that can then come in and address and ask these questions, Mary, that you're asking in their own institutions.
Mm-hmm. Absolutely.
I want to piggyback off of that too with what Quita mentioned around, who is more responsible, who's holding, I guess, the industry accountable for this bias that disproportionately has affected and can affect people of color. And I think, honestly, there really isn't anybody. I think the only institution, there's only protections in place is there's the GINA Act, which is the Genetic Information Non-Discriminatory Act of 2008 that Congress passed, which took a long time to pass, by the way. But there have been some advancements. But what the GINA Act does is that it provides protections for your genetic information. So insurance companies cannot use that against you and increase your premiums and whatnot. And then now it's been expanded also into employment, where employers cannot use your genetic information against you to prevent promotions or firing. So that's something that is a comfort in the space. But what's also interesting is what's not covered by the GINA Act. And so that is a long-term, that's like long-term life insurance. So other long-term care, other disability things. And so the state accounts, so then that goes to the states. So then states can then say, hey, this may not be covered by GINA, but I'm going to put in additional protections. And so some states have done that. I think, honestly, the best state that's done it is California. I think they call it CalGINA is the name of their legislation there, where they have all those protections across the board. So honestly, I would say with lawmakers and regulators, there needs to be policy created that will protect vulnerable populations from the FDA, from HHS, and within our houses of Congress.
So let me ask you, is there a campaign, asking both of you, knowing that you've both been very active in the community and doing community initiatives, what kind of, as have I, but I'm still struggling with this, what kind of, initiatives, community initiatives or whatever partnerships do we need to do to be able to get more diversity in that database, in the catalog? Sorry.
Yeah. Well, I know for us, last year we launched a new and really very exciting project for us that we call the Advancing Inclusive Research Site Alliance. And this is a coalition of sites, and we're early days. But it's an industry model where we're looking at sites that are in historically underrepresented locations. So City of Hope in LA, the University of Alabama in Birmingham, West Cancer Center in Memphis, Tennessee, and the Mace Cancer Center in San Antonio, where we have vetted, they can do all phases of research, because we don't want anybody on the team to say, oh, well, I wanted to do a study with them, but they couldn't do it. So we know they can do phase 1 through post-marketing. So they can do all phases of research. They have representation in the investigators that come from communities of color. And they, which really was important to us, they have a team of folks that engages the community. So, and we've seen great success with them being able to recruit underrepresented groups into cancer clinical research. And so now we're going to take that model and we're going to expand it, because we know it works. And we're not only going to look at, how do we think about expanding in the US? Because if we think about the world's population is in Asia, Oceania, India, and Africa. So we need to be thinking about how do we think globally about patient populations. And so we're going to be looking at how do we expand our site alliance. But I would say, because we're working with targeted groups in communities of color, one of the pieces of fake news says, well, if you concentrate on enrolling Black and Hispanic patients, then it's going to slow the study down. That's not true. We have proven that hypothesis is incorrect, because we just closed a multiple sclerosis study with Black and Hispanic patients, and we enrolled faster. The IMPACTA study I mentioned was one of the fastest enrolling studies. 85% of the study population came from communities of color. One of the fastest enrolling studies in our history. So there's a lot of fake news that we have to dispel in order to move the needle.
Yeah.
I love that, Quita, because Genentech, you guys have been now the new gold standard on how this should be done. And so for me, in my perspective, we're a boutique consulting firm that focuses on health equity. So we become more integrated in a more intimate sort of setting with our clients and with our partners. And so the way that we've worked with them is to have the conversation, because my background as a population geneticist, and then my business partner, Dr. Diana Liu, her background as a molecular biologist, we can talk across the different sort of major sections, because our engagement model is to work with governance, human resources, the product delivery, and the supply chain folks. And so we can talk to each person in one of those organizations and say, hey, your technology may be biased. It more than likely is, because you're using the human reference genome. And as you may be familiar too with Quita, that's the reference genome that folks all used for alignment. Right. And then I can let them know that reference genome was created from 11 people. Yeah. And of those 11 people, there's one man that's majority's DNA is used in those 11 individuals. So there's been just now new energy into creating what they're calling a consensus genome or a pan-human genome, which will then actually be more representative of the worldwide populations. And so the National Human Genome Research Institute is really leading that charge and doing a lot of work, and they've got a lot of money to help figure that out. So what for us, we articulate this is the case, and then how do you mitigate against the current circumstances, and then how do we communicate that to potential trial enrollees or students that we're training or academic investigators, so then they can be aware of all the things they need to be aware of, and then redesign that trial or redesign that program or curriculum that can be inclusive and help address these different inequities.
So now I heard recently on the news that one of the companies that has been collecting DNA, one of the ancestry folks, that they are now looking to get into drug development. So now how is that going to work when this is not necessarily DNA of sick people? It's healthy people. So what are your thoughts about that? Is that a good thing? Is that a bad thing?
The thing about, so I'll speak to that directly because my dissertation actually did exactly this. So with my work, and now my advisor, who now we're colleagues and friends, Dr. Michael Campbell, he's an assistant professor at USC. And so my dissertation focused on actually respiratory disease. And we looked at healthy, individuals from the 1,000 Genomes Project. And so basically there were, I think it was about 25,000 folks, genomes that were in there. And so basically we don't know if those people were sick or not. Very similar to the Ancestry.com or the other sort of commercial geneticist folks. Yeah. But what you can do is that there are tools where you can figure out potential genes and variants that are likely to be linked to disease, because you don't know that control, right? You don't know if they have that disease or not, but you're using, usually it's at least like 3 or 4 to 5 different tools that basically say, it's kind of like, you can think about it's exploratory research. You're going into the ocean, you're fishing, and you're like, I really want to catch this one fish. And so you do your due diligence on background and say, okay, I can't, boil the ocean. So let me figure out okay, is it the Pacific coast? Okay, what area? So you do a lot of research to figure out what then is the prime gene area that is implicated in disease. And then you can focus on that and see what is this person's genetic variation? Is it more aligned with the reference? And we know the reference to be healthy, or is it an alternative? And then that alternative, if that's an alternative, it may increase the person's chance to develop that disease. So it's not a bad way of doing research at all, but you have to do additional studies to really confirm if it's going to be causative to have that disease manifest.
I'll weigh in here. I think the increasing popularity of these genetic testing, 23andMe, Ancestry, all these other ones, I think they do have the potential to support the understanding of the relationship between genetics, geography, social determinants of health, biology, right? Because you find out a little bit more, right? So I did my 23andMe and Ancestry and, realized that, 40% came from sub-Saharan Africa, but some is European, some is Native American, right? And so there's an ad mix there. And so while America is just going to look at me as Black, the reality, there's a lot underlying that could potentially have impact on the types of diseases that I might end up, hereditary having. So I think those companies are going to be helpful, to be honest, because I think they're opening up people's eyes around, even though genetics and genomics are 2 different things, they're opening up people's eyes to the conversation.
Mm-hmm. Yeah, but I also just, I think to your point, I agree with everything you said, Quita. I would just say I know how those commercial companies work. They typically have a proprietary set of blueprint genes that they kind of match everybody to, which is why you can get very different results from 23andMe than you can from Ancestry.com. So I would just say that with a bit of caution, because that's just the way that when you privatize the experience without sharing, right, a little bit of a colonialist mindset is happening with the companies.
Bring it, tell the truth.
And when that happens, you're going to get less than accurate results because everybody's in their silos.
Wow. Yeah. See, so we still have to be diligent no matter what, and keep calling out these colonistic behaviors. And I know it makes some people uncomfortable, but again, change does not happen when everybody is comfortable. So we're over trying to make everybody comfortable. We want to move forward. So in the time we have left, I'd like to ask each one of you to just tell me your vision of what success looks like when it comes to health equity, from your company perspective, from your personal perspective. But, we want to be, again, very visionary with this as far as what needs to happen, where this is going, where it should be going. And all of you, we brought together all these experts. So we want to make sure we hear from you, your thinking about what success looks like in the health equity space as far as advancing it and moving the needle, next 2 years, 5 years, 10 years. So we'll start with you, Quita.
I think a success to me is kind of in three buckets. One is at the system, right? Like system level, are we really addressing the systemic infrastructure issues around the policy, who gets treated? How do we think about who becomes a doctor, who becomes a scientist? Right. So at the system level, how do we start to address some of these systemic causes of why we don't have more inclusive research? Then I think at the patient level, we have got to build trust. People are not just going to come to us and because we say, oh, well, we're doing a clinical trial, we want you to participate. We have got to understand and show up early and really start to think about sustained engagement. Because what I have seen from companies is we love to come in and out, but we need some sustained engagement with community stakeholders. And then I think at a study level, in the life sciences industry, we have to match the patient population with the disease, right? So if we're talking about prostate cancer, we know that mortality is higher in Black men. Black men should be in the clinical studies. Like that, to me, it's at the system level, at the patient level, at the study level. And then the last thing that I would say that I would like to see is I don't want any more allies. I want some change makers. And what's the difference between an ally and a change maker? An ally is somebody who says, yes, I agree, we should do something, but they don't take any risk. I'm looking for people because the only way we're going to make change and have a real discussion around changes in healthcare is we've got to have change makers, people who are willing to take a risk and stand up and fight to make a difference.
Mm-hmm. Absolutely. I agree. Dr. Cross.
Well, I'm just still taking in what Quita said. But so for me, there's a couple of things. I think what I would love to see is, we have a White House COVID task force. It would be great to have a White House Diversifying the Human Genome task force. And I think that's very realistic to have because we've got the Office of Science and Technology, which is in the White House. And then one of the directors is Dr. Eric Lander. And he is a geneticist by training. He was a part of the 1,000 Genome Human Genome Project. He is the first science advisor to be included in a presidential cabinet. So he's very familiar with what we're talking about. And I think creating a committee, whether it's a COVID-19 equivalent task force or even within, it's called PCAST, which is the President's Council for Advisory of Science and Technology. And under that, there's a Black woman named Dr. Lisa Cooper. And so she actually does some health equity work at Johns Hopkins. So I feel like we've got people in place. And if they could create that task force, that could help prioritize so many efforts and develop key pillars that we need to have protections for people of color who want to participate in getting their genome sequenced, and especially in this fashion that we're talking about. And secondly, I would say there should, I think, honestly, insurance companies, the GINA Act had to be created for a reason. So what if insurance companies said, you know what? We're not going to penalize you for understanding your human genome. We're going to provide you incentives. We're going to decrease your premium because now we can help predict how you may be getting sick in the future and create prevention. Prevention. So that would be great. And then lastly is the business perspective. So me as a small business, it would be great if folks really utilize businesses like mine and our services to really folks who understand the science, who understand the policy, who also have a business mind, to bring together folks that are in all of these different silos to help to actually create change. Because it's so hard to do that when folks only understand science, they only understand policy, they only understand business and ROI and metrics. So folks like us, we understand all of those buckets and we can create these innovative solutions. So those would be my things that I would suggest.
I love it. The intersectionality piece is so huge, and that has been a real focus of this summit. And that's also why we want to continue to do it. And just the things we've heard even today, when you bring all those minds together and they start connecting the dots, we've heard some really amazing and fascinating things that I think to see those things move forward and advance will really make a difference. And this is something we're all going to keep working on together, right? So thank you so much for your time today for this session. This is not the last time we will be together talking about this and advancing this and tracking the solutions and coming up with the metrics. I love that idea about the insurance, I have to say, because you get a discount if you, control your weight. If you join the gym, why not add this? Absolutely. And that's not even getting to the whole business value. Dr. Jonay from CBS was talking about 92 billion is what they've calculated. Health inequities is costing us 92 billion. Wow. And then there's another 42 billion related to not diversifying your workforce and having the proper workforce to be able to treat patients, look like patients, be developed and have that future pipeline. So there's a huge business case for this as well. So ideally, we will continue drawing attention to that and folks will get out of their silos and start working together. So thank you so much for joining us on day one. Hope you can tune in tomorrow as well. And I'll be back in a few minutes with our CEO, Shankar, so that we can close out the day. But thank you so much, Quita and Dr. Cross. Bye.
Bye.
Well, here we are at the end of the day. I'm Aaron Strout, CMO of Real Chemistry, and man, what a powerful day of content we've had. Thank you all for sticking with us. I know that it's hard to, while it's great to hear all this great content, it's a lot to digest and a lot of heady thoughts. What I would like to do, and we'll try to keep this fairly brief, is I know that you've met Mary. She moderated, she emceed today. We'll hear from her in a second. Who you haven't seen yet, probably, but you probably read some of the news about it, is our new CEO. He's a wonderful guy. He just started, I think, last week, Shankar, if I'm not mistaken. But anyway, he's here, and we're going to get some of his observations. His name is Shankar Narayanan. He is dedicated to health equity. He's very much in support of this. We had Jim open it up because it was his baby. Shankar is very much, wanting to keep the legacy going. So with that, why don't you talk a little bit about why you joined, why you're so excited about this, and then maybe we get a few observations from the sessions you were able to watch today, Shankar.
Yeah, thank you, Aaron, and thank you, Mary, for inviting me into this as well. This is a real privilege for me to be here, so thank you. Aaron, to answer your question, I joined Real Chemistry mainly for two reasons. Initially, I thought, right? One was I truly believe that we have the power to save lives in the work we do, right? We're obviously not medical doctors or drug developers ourselves, but the work we do in identifying patients, engaging with them, connecting with physicians, helping them engage with patients, and using data and analytics in powerful ways to do that ultimately saves lives. That's what I sincerely believe. And that's one of the biggest reasons that brought me here. And of course, the people and the culture of Real Chemistry, everyone I've met so far has been wonderful. And we're all so mission-driven and so purpose-driven. So that's exciting as well. But after today's sessions, I would say, Aaron, I think there's a third reason. Right. And that is that I am so proud of our support for health equity. I had a somewhat, layman's understanding of the issues and the problems here, but I think having spent some time with Mary and her team, having talked to Jim at length about this, because I know how passionate he is about this topic, and most importantly, just listening to some of the speakers today and the topics and the discussions today, I walk away even more convinced that this is arguably one of the most important healthcare problems we have in our nation. And I am really proud of Real Chemistry for stepping up and being a leader in this discussion and this important agenda. So that's what I would say about that. I think in terms of today's session itself, Mary and Aaron and everybody, I like to think of three things that I take away from every discussion that I'm in. And so I'm going to share the three things that I took away. The first thing I took away was how important it is for leaders to commit to this initiative and this priority. I had a chance to sit in and listen to the CEO panel, which kicked off the day today. And I was struck by how, whether it was Alexander Hardy or Dr. Wayne Frederick or any of the leaders on that call who talked about the importance of how they needed to lead from the front, right? And so this is one of these issues in our country where I believe we're not going to solve this problem by subscription only. We're going to need sponsorship. We're going to need commitment from leaders. So listening to leaders like that talk about how this is a priority for them personally, the organizational resources they're committing to the problem, the way they're making this goal something that is a goal that is shared by the entire leadership of the organization, those are all things that we can learn. And I think if we're going to make a real dent and in this problem of health equity, that's going to be, I think, a big thing that everybody is going to have to step up and lead, right? And that starts here at Real Chemistry with me, and then it also extends to all of our clients and other participants in the healthcare system. So I would say that was my number one takeaway. The second thing I took away is we cannot achieve health equity without building trust in the healthcare community and amongst healthcare participants. Whether it's payers, providers, drug manufacturers, device manufacturers, whoever it is, every one of us needs to understand where people are coming from, and meet them where they are, right? That's how we build trust. And so this example that Dr. Frederick shared of this patient that he was treating, this is a lady who had 5 children, and she couldn't make her vitally important chemo appointment because she just had to put food on the table for her family, right? And he was so humbled in sharing that story because he was like, look, I was embarrassed to be frustrated with her and sort of mildly admonish her when, I had no idea about her realities and her economic realities and the life she lived and so on, right? So that, to me, that understanding and just being able to fully relate with and being able to fully understand where people come from will ultimately build trust. And I think when we build trust, we will start to bring down the barriers that prevent health equity being a reality. And then the last thing I would say is, this is going to take real investment. I think Jim and Mary talked about this at the beginning. I'm glad to see venture investment going into this. I'm happy to see corporates making real commitments. Tomorrow we're going to hear from Dr. Woodcock about how the FDA is also stepping up here. I mean, it's going to take a wholehearted team effort here with real resources, real dollars, real capital to make this happen. And I feel excited and bullish coming out of today that the needle is moving right in that direction. So those would be, Aaron and Mary, my 3 takeaways, which is we have to lead from the top and show the commitment as leaders. We have to work hard to understand where people are coming from and engender trust. And lastly, there has to be real investment and real dollars and resources going in to address this problem. So those would be the 3 things that I took away. But Mary, I'd love to hear what you've been observing and your perspectives as well.
Yeah, thank you, Shankar. Those were great observations and all very critical and spot on. And so I would just add a couple of things to that. So certainly what we heard about the pipeline and the talent, the people, the workforce, and the physicians and the STEM folks, all these folks that are going to have to help us achieve this over time. And we heard that, Howard University, Howard Medical School, Meharry, Morehouse, Drew can only graduate so many positions of color. People are going to have to move out of their silos. These other academic institutions are going to have to do their share to make their organizations a place where students of color not only want to come, but can come, get accepted, and then get the support to get through. And so, the comment about the talent in the communities of color is not invested in because that talent is not seen as future doctors and scientists and investigators. So this whole mind reset that we need to have and broaden our view, and certainly, again, organizations, the whole health ecosystem and beyond needs to broaden their view of what you see and who you see as a doctor or a CEO of pharma. So that part is critical. Also, the ongoing bias, we heard a lot about the references to the maternal and infant morbidity rate amongst Black women, and this misinformation and fake news, as one of our panelists said, of trying to make everything seem like it's the fault of the diverse population somehow. But, that is not standing up, certainly with the maternal and infant health morbidity, because you have Serena Williams, who certainly knows her body and takes care of herself, and yet she almost died in childbirth. And it's not about educating folks even more. We're not dying higher in childbirth because of diseases. It's the practitioner's reluctance to treat us and to acknowledge our concerns, our input, and there is segregated care, and it's showing up in clinical trials and lack of diversity. Folks at Real Chemistry know I shared last year when I did the Black History Month about my own experience. My first child died of a crib death at 2 months old. My second child and I both almost died in one of the top hospitals in the country because they left me in the room bleeding when I told them I was bleeding until, I almost died and the baby almost died and they had to run in and rush us into surgery. So it's not about your income level. It's not about your education level. It's not about your geographic location. This is real. And we've been saying this for a long time. And we cannot educate ourselves out of dying in childbirth and our babies dying. So the data is showing that there's a need to be treated by physicians who are empathetic. So I really was pleased to hear that kind of narrowing down on that. And, our vice president has been trying to get legislation passed around that, which Congress has yet to pass. But we're hopeful that now voices like Serena Williams, the tennis player, and others have been added that maybe they'll move forward.
Well, I think to that point, Mary, today was a seminal day. And one of the things that, if you're just watching the video and, you can see it over on YouTube, but I think you probably noticed it, the level of engagement in the chat,
yes,
and the level of people that were engaging, people like Quita Highsmith from Genentech and people like, Dr. Maybach and others, that they're the movers and shakers, and many of them were speaking, and they didn't just sort of drop into their session and drop out. Like, they were there all day commenting and engaging. And I feel like one of the things that was another theme was the honesty, the honest conversations, the getting to the truth of how do we fix this and how do you meet people where they need to. Like, one of the sort of hidden gems for me of the day was with our own Jennifer Paganelli, JPEGs, with Dr. Graham from YouTube and Dr. Fitzpatrick from Grapevine. And they just talked a lot about the impact of that disinformation and how we need to get the right information to people in the channels where they're digesting, which, by the way, looks a lot like this on their smartphones, right?
That's right.
So that was a big deal. And I think that will help move the needle, is when you have leaders that are this engaged, people like Dr. Hardy or Alexander Hardy, who's the CEO of one of the biggest drug companies in the world, showing up for this and telling you this is a priority for us. And like you said, Shankar, leading from the front, committing to, I loved his program with Howard University, FDA, and Genentech, right? That 2-year fellowship. What an innovative program that was. So kudos to you and Joel Jones, who you'll hear from tomorrow morning, as Mary and Joel do a little bit of a recap and a re-intro.
I just want to add one more thing to this, though, the business case for this. At the end of the day, I've worked in corporate America my whole life. So I certainly understand the business value and all of that. And so the point that Dr. Jonay made from CBS and their panel about the business and societal value, $93 billion in losses due to health inequities. That is huge. We've been saying that for a long time. You're leaving a lot of money on the table. Didn't realize it was that much. But then also $42 billion in losses in employee productivity because it's not being addressed and it is adversely impacting employees, and especially employees of color, who can't work or lose their jobs or whatever because of illness. So that's the other piece that we need to remember. There is a societal value and there is a business value and case. And this is why we cannot just let this be a moment in time. This has got to be a movement.
Amen. Yeah.
Well said, Mary. So it's not just about doing good. It's doing good and doing well. You can do both.
You can do both. That's right.
And that right there is the mic drop, I think. So Shankar, Mary, thank you so much. Thank you to everyone speaking today, participating, the whole events team, your partner in crime, Joel Jones, who again, everyone will hear from tomorrow as we open up at 11:30 a.m. Eastern time. So make sure you're tuned in, have a action-packed schedule. Shankar nodded to the fact that we have Dr. Janet Woodcock, the acting commissioner of the FDA, tons of other great speakers, our second CEO panel. So thank you everyone for tuning in. Great day today. I think we started the process of moving the needle, and we're going to keep moving it tomorrow. And then we'll hear from Shankar, Jim, Mary, and Joel tomorrow at the end of the session. So we'll have even more insights And I'm assuming that Shankar, as a McKinsey man who does everything in threes, will have another 3 for us. So get ready for that with bated breath. So thank you, everyone.
I will try. And thank you to all our Real Chemistry colleagues. I'm really proud of what we achieved today. Thank you.
Excellent job, team. Yay, team. All right. Thanks. Bye.
Bye.